Audible. Hello, am I audible now? Yes, everybody, can I get a thumbs up regarding whether I'm audible or not? Hello, hello. Am I audible, guys? Payal? Yes, am I audible now? Okay. Okay, I'm audible now, I think. Taruna, just check. I think I'm audible now. Okay, fine. So, guys, hi everyone. Manisha, Shailesh, Indranil. Um, I was no harm done. I was just basically just introducing. We are DBMCI MDS, guys, for everyone's knowledge. This is the mega recall session for your INI-CET MDS May 2026. I was just telling you guys that, the last couple of weeks must have been very hectic, full on stress, because the two most important exams, especially the first half of the year, have come up in very quick succession, right? Just 2 weeks back, you had NEET, and the paper also was very different in terms of pattern. And yesterday, you had your INI-CET MDS. As usual, INI people, um, pretty tough paper, isn't it? Apparently easy to see, but yeah, they make brand new questions, uh, outliers, pretty tough, right? But that's okay, guys. You worked hard, two exams done. Take a break for a couple of days. Obviously, be bang on your recall. Try to get as much accuracy, because now these questions become your PYQs for your future exams. Right, guys? Hi, Happy. How are you, Taruna? Aman. Hi, Aman. So we're starting. So if we are to just slightly break into, because I'm taking both DM and endocons, slight basic idea. This time, DM questions in number was slightly less, and endocons, as usual, is pretty heavy on weightage. Usually, in the INI people, in the INI paper, I've seen that in the last 1.5 years. Hey, that's a nice way of saying hi. Hi, hey, how are you doing? Yeah, yeah. So usually in the INI people, in the INI papers, we do have a lot of DM. This time, relatively DM was slightly less, but nonetheless, the questions were pretty conceptual and going from the moderate to the tough, pendulum, right? Nothing easy. So let's start with a couple of questions with DM. There was a question, two questions related to the degassing procedure, guys. Now, degassing is a concept that is used very casually in dental materials. When you degas or you do annealing of your direct filling gold, that is also a type of degassing, isn't it? But here specifically, you're talking of degassing, wherein this question was from the perspective of your metal casting that was there. You have to fabricate a metal ceramic crown or a FPD. And in order to facilitate chemical bonding between the porcelain that you're going to fire on the metal or the alloy coping, you do want to precipitate some amount of oxides in the form of iron, indium, and tin. Right? Time and again, we keep telling you in our Telegram groups, in our notes, in our GTs, iron, indium, tin, right? You have a noble metal alloy, you heat it to about 1083 degrees Celsius, and you have the precipitation of iron, indium, and tin oxides, which facilitate the chemical bonding between the metal alloy and the porcelain that you're firing, right? So metal ceramic crown was planned. Degassing of the noble alloy is decided. Degassing of the noble alloy is actually better in terms of degassing a nickel chromium or a base metal alloy, in the sense that the precipitation of iron, indium, and tin as small impurities that you deliberately add onto the noble alloy is pretty good here. So degassing of noble alloy helps in chemical bonding due to the formation of metal oxides. Now, which are these two metal oxides? Okay, so it's something which you've been just memorizing: iron, indium, and tin. Right from your BDS days, it's these three. Now, out of these three, tin and indium was mentioned, iron was not mentioned. So, anyways, so tin and indium was the answer. The other options, gold, silver, palladium, are not the answers. Now, very similar from this exactly the same topic. a simpler question, more conceptual instead of memory based was asked. So I put this together here. Degassing procedure of the metal alloy after its casting helps in the formation of a chemical bond with the porcelain, isn't it? It helps in the formation of metal oxides to form chemical bond with the porcelain. Yeah. Yes, excellent, Happy. So, just sharing a screenshot of the fact that we keep telling you about annealing, degassing at various platforms when you're teaching direct filling gold, when you're teaching your various ways of, those classifications of firing your porcelain at different temperatures, and obviously your basic BDS knowledge. You've been doing it, your Viva questions all throughout your BDS. Then one question was applied in the sense that you had the application of your knowledge of your physical and mechanical properties, which we do very extensively in our curriculum. So, applied to the clinical practice of making a long span FPD bridge. Big question, simple answer. Just have to see the keywords and you just have to know the concept, right? So, guys, for fabrication of a metal ceramic restoration, it was decided that you choose a nickel chromium alloy. Okay. During sintering, it was found that it has a very high value of modulus of elasticity. First of all, this is slightly, not very correctly framed, right? I mean, nickel chromium or cobalt chromium definitely has a very high value of modulus of elasticity. That is the virtue, that is the property of this dental material. I mean, you don't find that during sintering until unless you're working with substandard material. But anyways, you give this benefit of doubt to the examiner that he's trying to just, play around with words and long sentences just to kind of confuse you, but the concept remains the same, right? So during sintering, it was found that it has a very high modulus of elasticity. What beneficial effect would this high modulus of elasticity serve when you are planning for this metal ceramic restoration to be a long span bridge, long span FPD? I hope all of you know FPD is bridge. Okay, all of us know that. So very simple, guys. I mean, time and again, we've been talking about this concept of modulus of elasticity, wherein in the notes also, lectures, GTs, like we make so much effort in telling you, isn't it, that the higher is the slope, steeper is the slope, more is the modulus of elasticity. So more is the force that you will require for it to bend, for it to flex, right? So that is what you want in a long span FPD. So just bang on, just go straight to the option. This is like, you just know it, go straight to the option. There is going to be a high, I'll put this in another color for contrast. So there is going to be a high resistance to flexure. That's the biggest advantage, isn't it? It won't bend. The material would be stiff. And this minimizes the tendency of the ceramic or porcelain to fracture or chip, isn't it? I mean, the porcelain is a brittle material. Metal can still flex without fracturing. Now, but you have fired porcelain over it. You don't want your metal to flex. That's why you've chosen a nickel chromium alloy with a high modulus of elasticity. It won't bend. The metal substructure won't bend. That means the porcelain structure also won't bend. If that won't bend, you won't have tensile forces on the outer curvature of the bridge. When you don't have tensile forces, then for a brittle material like porcelain, that's what you want, because a brittle material like amalgam and porcelain is weak in tension. So it won't fracture. Simple question, simple concept applied. This is what we expect from INI people, isn't it? You know your knowledge, you know your concept, you get this thing. Right, guys? At what temperature are magnetic properties lost? Now, guys, this is the second time these guys are playing around with this magnetic property outlier question. So you can see here the answer is Curie point. And those of you who did attend the last recall of INI November, this is the exact screenshot from the recall session of INI November 2025. You see here, there was a tougher question actually, wherein they were playing around with the flux density, increase in temperature of neodymium, samarium, magnets, etc., etc. And you can see here, we are talking about this concept of Curie temperature. That this temperature, this kind of phase transformation takes place where the magnetic properties are lost, right? So Curie temperature is the answer. This is not there. This is an outlier. This is not there in 12th edition, 13th edition, 11th edition of Phillips. Not there in your standard theory, but we made those extra efforts during November 2025 to get you that data. We solved that tough question also, and this time a relatively easier question came, in which if you saw that recall, you would have an idea that, Curie point is the best answer here. Okay, guys? Yeah, it's happy. It's not exactly the PYQ, but Yeah, I mean, yeah, taken from, you can say, those of you who religiously. I always say this. I mean, if you remember, I took your morning motivation 4 days back from the NEET exam, and I told you, like, guys, last 2 days before the exam, last 3 years paper, do them repeatedly. 5 days before the exam, 10 years paper, but last 2 to 3 days, just 3 years paper. Both INI and NEET for both the exams. I mean, everything is interlinked, right? The subject remains the same. Yeah. Yes, Abhishek, that's okay. If you are confused in such an outlier question, that's okay. You can leave it. Please, I always say this: don't do akkad bakkad bambe bo amongst the four options you don't know. If you can eliminate at least two, then you can still take your chances, depending on how you're doing the rest of the paper. Okay, guys, arrange the following in increasing order of fluoride release. Guys, I mean, this is way simpler than than what we discuss about silver alloy admix, this and that. I mean, you go from that continuum of composite, which is lowest, right? Then obviously all these modifications in between, like a resin modified GIC, yeah? And then obviously a GIC would be the highest amongst the modern materials. Obviously, if you have silicates and silicophosphates in the options, which was not there, they will have the highest fluoride release. But wait, this was simple, guys, right? You have composite, you have a resin modified GIC, and you have geomer. Now, geomer is, as the word suggests, geomer is what? It's pre-cured GIC, and mer is coming from compomer. And compomer, as I always tell you in our dental cements lecture, is more towards composite than GIC. So anything that's more towards composite is going to be having lesser fluoride release. So if you have to arrange this in increasing order of fluoride release, lowest composite, then geomer, then resin modified GIC, then GIC. Yes, in fact, I always go to the extent of telling you guys in my classes. So if you can see here, we discuss this fluoride release in such great detail in our lectures and in our notes. But this was pretty commonsensical again, right? Now I go to the extent of telling you guys in my lectures that, Philip says that the fluoride release of resin modified GIC and GIC is very much similar, but Sturdivant says that GIC obviously is fluoride releases more than resin modified GIC simply because the more the resin content, right? It's basically, what is resin? It's plastic, methacrylate, no fluoride there, right? So in that order, more the resin content, less is the fluoride release, more you go towards the glassy phases, the calcium fluoride, silicon fluoride, sodium fluorides of the GIC powder particles, more is the fluoride release. Yeah, yes. So simple, guys. I mean, obviously there are multiple combinations here. So if you are to arrange this in increasing order, the lowest is resin composite, so that's A. Then you have the geomer, that's D. Okay, and then you have C, resin modified GIC, and then you have B, that's conventional GIC. So A is the answer. A, D, C, B, right? That's the answer. Simple, right? Okay, so this also we take. I mean, just see, we're taking efforts to, just tell you the standard thing and the outliers, just a holistic knowledge, and obviously you will be able to solve your INI paper. Failure of ceramic restoration due to slow crack growth. Now, this is a brand new question, guys. We do discuss glass modifiers, right? We do discuss glass modifiers, but specifically, there is one in between line in your Philips, especially in your latest edition, that, if there is water contamination, that acts as a further glass modifier, which would basically, what is a glass modifier, right? We discussed this, no? That you have this silicon tetrahedra and you want the sintering temperature to kind of slightly decrease. Otherwise, when you're firing porcelain, the metal would sag, right? So you have these boron oxide, right? You have boron oxide and the other oxides. No, that's not the answer. So you have these boron oxides and the other oxides, which would kind of play around with this tetrahedra, right? Intercept this tetrahedra, increase the flow, reduce the sintering temperature. That's a glass modifier. Over a long period of time, now in the exam, failure of ceramic due to slow crack growth in the oral cavity over this, there was another line here, I'll just add it, over a long period of time. And that's the catch. Now, this was a brand new question, guys. This was a brand new question. And this happens when, apart from these oxides, during the service life of the restoration, some water particles also go inside and start to interfere with the bonding of the silica tetrahedra of a feldspathic porcelain, and that would help in, that would facilitate, not help, I would say it's a bad thing actually, because it's a way of failure of your ceramic restoration. So that would cause slow crack growth. So it's the water contamination over a long period of time. That's a star marked question. Um, please make a good note of this. Very good question. Yeah. Okay. This is simple, guys. So many times in the GTs, guys. So many times in the GTs. You're fabricating a heat cure, you're heating it rapidly. It's not a good conductor of heat. So obviously, the temperature inside increases beyond the boiling point of your methyl methacrylate monomer. That's 100.8 degrees Celsius. It vaporizes. There's internal porosity. Simple. Yeah, simple. So vaporization of monomer due to increase in temperature beyond 100.8 degrees Celsius is very simple. Then again, brand new question. Actually, it's related to orthodontic bonding, but it's related to bonding. So okay, I've included it here. And also obviously we've discussed it with our ortho faculty. I'm going to take this. So okay, Trupti, yeah, there is slight controversy whether it was mentioned. So even if slow crack growth, go with water. Even if it is not mentioned over a long period of time, my sources say that it was mentioned. Even if not mentioned, slow crack growth, um, go for water contamination. That's the best answer. Okay, which is added to composite to minimize tooth demineralization without compromising the bond strength. So first of all, you have to be very clear about the composition of the various types of methacrylates that are there. I mean, you do have Udama, that's the basic composition. 4-meta is one of the components of the bonding agents, especially the self-etching, because it has acidic group, right? Simple. Degdama is nothing but just like Tegdama, it's Degdama. So we call it, so we are discussing all of this, right? Bisgama, Udama, Tegdama. We've been discussing this. This is an applied question. We've been discussing this, right? These are standard components of your composite and bonding agent. Tegdama decreases the viscosity, makes it more flowable. Degdama obviously is nothing but the diethylene glycol methacrylate. Tegdama is triethylene glycol dimethacrylate. Udama and Bisgama are the basic components, basic methacrylates that are there in your conventional composite. Then you're left with MDPB. I mean, you could reach this answer by knowing your basic knowledge without actually knowing the answer here. So that's one way of reaching the right answer by exclusion, right? If you are to talk about specifically, sir, what is this MDPB? MDPB is basically your P stands for pyridinium, right? And M obviously has a methacrylate group. I don't remember the exact full this thing, but the concept is that it's a kind of a methacrylate which has pyridinium, which is antibacterial, okay? Which is antibacterial. Now the question is, which is added to composite to minimize tooth demineralization without compromising the bond strength while bonding the orthodontic brackets. So basically what he's saying is, if you have an antibacterial agent, it's going to kill the bacteria, right? Pyridinium is going to kill the bacteria. Yes, it's going to kill the bacteria. Yes, it's going to kill the bacteria. There won't be any white spot lesions, no decalcification. But at the same time, because it has methacrylate, it's pretty tightly bonded to the composite other methacrylates like Degdama, Udama, etc., etc. So it won't leak out. So therefore, it would not contribute to the weakness in the bond strength, right? So whether you read it directly, whether you reach it by exclusion, this is one of those questions which, even if you don't know the direct answer, based on your existing knowledge, you should mark. The rest of the options are pretty straightforward, right? Udama, Degdama, Tegdama, 4-meta, Hema, these are all standard conventional things, nothing new in them, right? So MDPB is the answer. Even if you've left it, it's okay. Better not to do a negative marking because this is a brand new question, no doubt. Beta, slow crack growth is the key word. That's, as I said, that's a brand new question. You have to consider that now a PYQ. Slow crack growth, water contamination, best answer. Right, guys? So you keep doing this. So that was your DM. In endo, this is simple, guys. This is very simple. Traumatology, fracture involving enamel, dentine, pulp, and cementum. You have, your tooth, which is, if I'm to see the side section, yes. So you have enamel, dentine, and then pulp, and then cementum. So this is a crown root fracture, but because it's involving the pulp, it's a complicated crown root fracture, right? So that's simple, guys. Complicated crown root fracture, right? Simple enough. Yes. Next question, which of the following is not a longitudinal fracture? Guys, we're discussing all these, you see our notes. We're discussing all these cracks and fractures, right? So everything related to crack and fracture, whether it's cracked tooth, whether it's cracked cusp, whether it's a craze as simple, not even a proper crack, but a craze line in the enamel. Yes, whether it's a split tooth, whether it's a vertical root fracture, all these are part of the big chapter of cracks and fractures where mostly they're all longitudinal. Yes, one would be mesodistal, the other would be buccolingual. That's okay. One would be originating on the external surface of the root, some would be originating on the marginal ridge. That's okay. They're all longitudinal. Which is the diagram that I just made before here. Does this seem longitudinal? It's more oblique, right? It's more transverse and oblique. So crown root fracture is the answer of exclusion. Simple, isn't it? So you have this small chapter, but you can see here we spend so much time in discussing all these in our notes, in our lectures. You have the crack, you have the split. Split was there in the option. The crack was there in the option. You have a cracked cusp was there in the option. We have this knowledge. They're all part of the same family, right? Crack root. Hmm. Right, guys. Now this is the simplest. Again, one of my favorites. When I tell you in your lectures, notes, everything. It was an image-based question. There were three types of images. One was simple X-ray showing a J-shaped lucency, right? Radiolucency. So that's a J-shaped radiolucency. One was a CBCT, right? And the third was this deep isolated periodontal pocket being shown. Where and it was mentioned it's a root canal treated tooth. So what is this? This is a VRF, right? This is a VRF. Answer is VRF. Simple, guys. Answer is VRF. So you can see here in our notes. In fact, in the notes, we also have this, J-shaped radiolucency. We have the deep periodontal pocket. And I've also, in fact, I've gone to the extent of mentioning in the notes that you have a draining sinus tract. You have a RC treated tooth, which is pathognomonic, J-shaped radiolucency, pathognomonic of vertical root fracture. When we have these three things, isolated periodontal pocket, RC treated tooth, draining sinus tract, it's pathognomonic of a vertical root fracture, guys. Simple. Ah, right, guys. So that's simple, guys. The answer was pretty simple, right? Yes, SS. The answer was pretty simple. Yes, VRF, right? So I think three images. That is my source. All right. This was a good one, guys. This was a new one. Good one from IDT guidelines. Okay, guys. Resorb root is acceptable. I mean, you will have some resorption when you have radiolucencies, right? So which of the following is true regarding a combination traumatic dental injury in which there is concurrent occurrence of two or more injuries? Now, this is from IADT 2020, specifically our students. Our students, are you there in the group? Happy, Anirban? I personally keep forwarding these AAPD and IDT guidelines. Combination injury is simply mentioned as, you're in one traumatic episode, one tooth is undergoing, say, a root fracture, whether it's horizontal root fracture, along with a luxation injury or a crown fracture, right? I'm just giving you an example. Luxation injury or crown fracture, or they can be any other, basically two or more injuries happening at the same time in a single tooth. That's a combination traumatic dental injury. Again, I mean, I always stress this for INI. Please read for vital pulp therapy, please read your APD latest guidelines and IDT latest guidelines, right? So many a times I've shared this in the Telegram group of our students. So the answer would be a single tooth, multiple injuries suffered in a single traumatic episode. Yes. No doubt, tough question. No doubt, tough question, but that's how it is, right? Okay, guys, excellent. This was the simplest. I teach you this in your irrigation and in your cleaning and shaping. Calcium hydroxide is matched with a high pH antibacterial. Then EDTA is chelation. Obviously, the options were jumbled up, but I'm just telling you the final answer here. Sodium hypochlorite, yeah, here there is some jumbling. This is tissue dissolution. And what do you match your chlorhexidine with? Substantivity. I hope that's pretty simple, pretty straightforward. I hope हाँ बेटा, single tooth multiple injury in one tooth multiple injury in the same traumatic event. Okay, that's a combination TDI, combination traumatic dental injury. So you can see here, guys, that's a screenshot wherein we are talking of your EDTA. Yes, it's a chelator. Yes. Um, then you're talking of your chlorhexidine, which is showing substantivity, right? So everything is there in your notes, in our lectures. Then you're talking of your um, sodium hypochlorite, which is having its tissue dissolution activity because of your tissue dissolving ability. That exact word is there actually, isn't it, in our notes? Then you talk about what is the fourth one? EDTA. Yeah, calcium hydroxide is also mentioned, probably not on this page, but yeah, everything is mentioned in our lectures and subsequently in our notes. I hope this question is pretty simple. Now, this again, so many times, this is specifically again, guys, your IADT and AAPD and IADT guidelines. Again, all of you, time and again in morning motivation, in specifically for our students, in the Telegram group, I keep sharing the latest guidelines. In a deciduous tooth, you have any luxation injury, forget about intrusive luxation. If it is not, there is no risk of aspiration, there is no significant interference and occlusion, don't do anything. Otherwise, you end up harming the permanent tooth germ. Okay. So a 2-year-old suffered intrusive luxation to a primary incisor to direct it towards the permanent tooth germ. Patient is stable, no risk of aspiration. What should be done? In fact, the examiner is actually giving you pretty good hints, right? That the patient is stable, there is no risk of aspiration. Basically, the examiner is telling don't do anything. You don't have to reposition, splint it. Do not have to remove it. Do not. Otherwise, if you do any manipulation, you might end up harming the tooth germ. This is the latest IATD guidelines. IATD guidelines for primary teeth luxation injury management, shared with you all so many times. I've told you, please be updated on these things. There's certain things, you know, there will be always a couple of things here and there, guys, which we keep telling you at a personal level on the Telegram group, because say some AAPD 2025 guidelines came in say November, December, right? And you have your notes with you say 3 months or 4 months before that. So you will have to kind of, but we keep guiding you for that. So wait and watch. Call for regular follow-ups. That's the best answer. Nothing doing, nothing. No pulpotomy, no extraction, no pulpectomy, no splinting, no flexible, no rigid, no, nothing. All right. Yes. Okay, happy, excellent. Happy is there. Nupur. Where is Anirban? Where are you guys? Guys, please see these recalls. You see here, these are now your future PYQs. Whatever I'm speaking, you might have a question coming from in between the lines of what I'm speaking, guys. Please see the recalls, at least our students, guys. Excellent, happy. Yeah, very good. Which of the following is true? Yeah, this is a tough one, guys. This is actually a tough one. This is not there in any of the textbooks. This is a new one. Probably Anderson mentions one concept, that too with the incisor displaced labially, not palatally. In this exam, there was someone who was, wanted to really trouble us, right? So we have, which of the following is true regarding intrusive luxation to an incisor with apex displaced palatally, right? Now, this is something that you, first of all, star mark this and please memorize this, okay? There's no real logic to this. I'll tell you the logic also, but please just memorize this. Whenever you have an intrusive luxation injury where the apex is displaced buccally, where the apex is displaced buccally, which is usually the case, okay, right? Then there is foreshortening. And when the apex in an intruded tooth is displaced palatally, there will be elongation as compared to the adjacent tooth, okay? Right? Memorize this, guys. That's the answer. So in this, it was asked displaced palatally. I would wish that you would leave this question. This is one of those questions. See, in a 200 question paper, 240, whatever, you should, beta, yes, foreshortening or elongation, depending on the angulation of the cone, is not a bad option. But the thing is, the catch here is, which of the following is true? And the exam also mentioned which of the following is true regarding intrusive luxation to incisor with its apex displaced palatally as compared with the adjacent incisor. So if you're changing the angulation, the comparison with the adjacent remains the same. You understand? You're not comparing the angulation with the tooth itself. You're comparing with the adjacent tooth. So that's the catch here. When you compare it with the adjacent, displacement palatally would always give you elongation. Displacement buccally of the apex would always give you foreshortening. So that's that's when I got this recall from my source, I knew that many of you would mark this as foreshortening or elongation depending on the cone. But the answer is elongation because the catch here is as compared. The options mentioned as compared with the adjacent incisor. So guys, this is the answer. Okay. So don't worry, even if you've left it, great. If you marked this wrong, no worries. 70-80% would mark this wrong. If you've got this right, and that kind of strike rate with the new question is going right for you, then expect a rank in top 20 in the country, right? Good. Okay. If the same strike rate is there with the other subjects also. Wonderful. I mean, even I had to check this. I did not know this exactly. But yeah, good question. Very troublesome question. Okay. Oh, wow. Taruna, you did this right? Nahi. हाँ B करा है. Wow. Happy also did this elongation. Wow, guys. Excellent, man. Excellent. Okay. Okay, great. Match the following, guys. Now this is applied clinical. How we don't expect BDS people to do split dam techniques and apply widgets, but that's how things are. That's how they make new questions. So, guys, split dam technique is basically a technique in which you connect the holes, and if you have a root stump, partially ruptured tooth, you isolate 2 to 3 teeth together, right? So I'll just mark the right answer first, and then I'll talk about other things. So, split dam technique. Um, Isolation of multiple partially ruptured teeth. Okay, that's the correct match. Then rubber dam napkin is simple, guys. You have a patient comfort as barrier to the latex of the rubber dam. That's very simple. Then you have a winged clamp. Winged clamp, basically, what happens is that if you are to put your rubber dam sheet and the clamp together, then on the lateral extensions of the wing, you can actually engage the sheet without it getting dislodged. So you can do both the things simultaneously. So it saves time. So placement of clamp and sheet simultaneously. Okay. And then what else? Which other color should I use? Then wedget is basically like a interdental thick floss kind of a thing, right? So wedget is for rubber dam stabilization without clamp in selected cases. You can't do it in every case. It's usually done in anterior teeth, wherein the rubber dam sheet gets engaged in the gingival third of the contact area, right, with the help of wedget. Uh, uh, 1 minute, Happy. I'll just come back to you. And then you have the last option, heavy duty rubber dam. Iska ye hai, better soft tissue retraction. The only thing that I found controversial here is better retention of the clamp. I don't feel a heavy duty rubber dam sheet would help in a better retention of the clamp, but that's the answer of exclusion, right? So that's how you're supposed to match this. I matched the colors with the right answer. So that's the answer, right? I hope that's clear. If you see our screenshots, yes, we do discuss, you have this image of this. This is the wedget, okay? This is like a nothing but a kind of anchor which you can use the separate wedgets like this, or you can use a rubber dam sheet material, cut it right about 6 mm, or you can use, as I said, dental floss to basically ensure that your dam remains gingival to the contact area, doesn't get dislodged, so that in some anterior teeth you don't have to place clamp, right? Examiner was very smart. The wordings were so clear, right? In selected cases, rubber dam stabilization without clamp in selected cases. Yes, you can't do that in every case. Usually, yes, this question came twice. They the in the first part the language was correct, but in the second part there was this some other question and the options were this. So what you can do? You can't do anything. That's a typo error. Ha beta. Hmm. Yeah, can't do anything. Okay, so again, this also, if you've read the discussion, read our notes, you would be able to achieve the right answer by, you would know at least from 5 options, you would know 3 or 4, and then you can, by exclusion, you can reach the right answer. I would suggest that go ahead and mark this kind of question if you have been thorough with our notes and in our lectures. This was simple, guys. This was the image-based question in which, in this back was not there, right? Number 2 was not there. They had shown this oscillation and they had shown this as, this also was there, like a small triangle and back and forth. So this was watch winding, right? So you'd say this is an image-based question. Forward arrow was there, that you're applying some apical pressure and you're approaching the working length by doing watch winding, right? So this was watch winding. There was an option of pull and watch wind. I don't think that was the better answer would be watch and wind. Okay, watch winding. Pretty simple. We keep doing this. Okay, this was a new question. I don't expect you to answer this. Nobody was. This is a continuous chelation procedure. Now, standard chelator is EDTA, right? And you have sodium hypochlorite, which you're supposed to use throughout the irrigation. So you either, what is the standard protocol, guys? You either do your sodium hypochlorite irrigation throughout the treatment and then in the end do rinse with EDTA, right? Or you can do an alternating regimen, but you never mix these two, because EDTA inactivates the hypo. There's certain recent evidence that there is a very weak chelator, which can be actually mixed in the same solution as hypo and used together. So this saves your time, right? And that is etidronate. Okay, so again, outlier, this becomes your PYQ. I would suggest this is one of those questions which you have to intelligently leave, right? So this becomes a brand new question. Answer is etidronate. Okay. Yes. All right. Okay, this is something that we do, guys. This is commonsensical also. I've done this in the notes also in the lectures. In regenerative endo, in which step local anesthesia is used without the vasoconstrictor? Now, guys, I mean, this is commonsensical, right? You're adding epinephrine, which is a vasoconstrictor. So if you, in the second appointment or in the third appointment, depending on whether you've achieved adequate cleaning or shaping or not, you want to induce bleeding, right? You don't want to place a vasoconstrictor, right, in that appointment. So obviously the answer is simple. At the time of inducing periapical bleeding, do not use a LA with the vasoconstrictor. Use the LA without the vasoconstrictor. Simple. If you see the screenshot from the notes, we have a proper protocol in which there's the first treatment visit and a second treatment visit. In the second treatment visit, we are recommending 3% mepivacaine, no epinephrine. But in the first treatment visit, simple, proper, standard LA is adequate. Local anesthesia has to be administered. No point in giving vasoconstrictor at the time of inducement of bleeding. So this is straight from the lectures, notes, everything. But even if you don't specifically remember it, commonsensical, simple, right? Yeah. Okay. Next question, ideal treatment. Oh, wow. This is my favorite. So many times I've told you, lectures, classes, cracked tooth with reversible pulpitis. The moment you see reversible pulpitis, you do not do endo. So you eliminate 2 options, non-surgical endo, they can't be the answer, right? I mean, it's reversible pulpitis. Our job as clinicians is to save the pulp, save the healthy pulp, right? So, Okay, dear. So the other thing that I always tell you is that you have to give a cuspal coverage restoration. Now that can be an onlay or a full crown. Okay. As far as giving an orthodontic band is considered, that's an interim procedure. Like you don't have time, you just place a band for patient relief. That's interim. That's not the ideal treatment, right? So orthodontic band cannot be the answer. Then there are certain people who say now we have bonded restorations. That again is still in, there's no clear cut evidence that that really helps. So the best answer is the option of full coverage crown. If there would have been full coverage crown slash onlay, that is also right. Basically, you have to splint the opposing cusps so that you don't have flexion and pain. Right, guys? So composite restoration with orthodontic band nahi hai beta, Saurabh. Right? So if you can see here, I always tell this. Temporary measure, देखो ये सीधा notes से, right from the notes. Temporary measure, orthodontic band. Definitive measure is either a onlay or a crown. It has to be a cuspal coverage. Okay. If it is irreversible pulpitis, then do RCT. Not in reversible pulpitis. Bang on. Straight from our lectures and notes. Isn't it? Okay, now this was a good one, guys. This was a brand new question. I'll tell you. In which of the following persistent pain following root canal treatment is there despite radiographic evidence of healing? Okay, this is from the latest. This is MDS SR level question, rather even higher than that. The answer is actually central sensitization. Okay. The answer is central sensitization. Again, consider this as a brand new PYQ. Do not mark this if you don't know this. Neuropathic pain, obviously, is a reason for pain, but then any clinician who has some knowledge would diagnose a trigeminal neuralgia. You understand? So, central sensitization or persistent idiopathic pain, idiopathic, right, is the answer. Central sensitization or persistent idiopathic pain is the answer for future questions. Please remember this. We don't expect you. Missed canal, I mean, you would diagnose it, it would be seen on the radiograph, right? Occlusal trauma, yes. You've done a perfect obturation, there's a high point. I mean, obviously, the patient will come back to you in 1 week, 2 weeks, 3 weeks, right? So if there is central sensitization, there is barrage of, this thing, with nociceptive, very severe preoperative pain, and the central nociceptors in the second order and third order neurons are activated. They're just firing like crazy, generating action potentials. That is may cause persistent pain. And then there is persistent idiopathic pain. That's basically nothing but, again, you're not able to basically locate a physical reason, right? Neuropathic pain, trigeminal neuralgia, there's a physical reason. You understand, you damage a nerve during procedure, like you placing an implant and the implant impinges on a ventral nerve or inferior alveolar nerve. That's a neuropathic pain, neural pain. That's a proper pain, right? Which a good clinician would diagnose, right? Yes, dear, there might be confusion regarding the options combination, but the answer here is that one option of central sensitization. That's the answer here. Okay. So yeah, I'll again star mark this. Better to leave this kind of question. As I said, this is this thing. Okay. Now this is simple, guys. This was logical. This is something that you've been doing this from third year onwards. You want to do a class 1 composite incremental buildup. So what are the correct options? You don't want to, you don't want your composite to be in a thickness of more than 2 mm. Obviously, entire depth of preparation should be bulk filled. No, obviously not. Right? Preceding increment should be cured before placing. Yes. Increments placed in oblique or diagonal manner. Obviously, this is one of the methods of incremental buildup, right? So data does not say that, if you're placing increments in a simple stack-like manner is bad or worse than placing it in oblique manner. The statement was very simple. It was not comparing. It was simply saying that this is one of the methods of doing an incremental buildup, and that is in an oblique manner. So statement A, C, and D are right. Okay, so the answer is A, C, and D. That is simple, right? So many times in the notes also, we've been discussing about these C factor values and the shrinkage stress. So it's all related to done in increments, less polymerization, shrinkage, straight, right? I mean, literally the same line, right? From our lectures and our notes, isn't it? So that's pretty simple. That was clinical theory, commonsensical. That was a simple question, guys. You should get that right. All right. What else is there? Ah, yes. Again, one of my favorites. I always tell this in traumatology. Ideal sensibility test, not vitality test. Sensibility test. So first of all, laser Doppler flow meter is not there in the, cannot be the answer. Okay. He has asked a sensitivity or a sensibility test in a traumatized permanent immature tooth. You understand so many times, guys. I hope my students, at least our students at DBMC, have got this right, guys. You have an immature tooth. So many times I've told you in the GT, in the lectures, guys, the innovation trails behind it, follows the vasculature. So you cannot, EPT is not good. Laser Doppler flow meter is great, but it's not a sensibility test. It's a true vitality test. Heat test, in any case, it's not a good vitality test or a sensibility test. So what is the cold test? So the answer is cold test, guys. I hope our students have got this right, guys. Cold test is the answer. So many times we keep telling you about all of this, guys. Yes. So cold test is the answer. Yeah, that's the screenshot. Management of type 2 apical. This is a PYQ, guys. This is a brand. This is a PYQ. I don't think I have a screenshot here, but that is, I think, many a times, like I think May 2024, November 2023. I would have loved to to put the screenshot of the PYQ discussion, but that's simple, guys. Management of so many GTs. That's a hardcore PYQ of INI only, right? Type 1 apical transportation, do nothing special. Type 2, place an MTA barrier. Type 3, do surgical, right? Simple. So that's MTA barrier. Okay, that's simple. Yeah. Treatment of choice for, yeah, this again. Oh, wow. This is, if you have seen the discussion of our PYQ from November 2024 INI. Schweck type 4. What is Schweck type 4? Non-vital Schweck type 4, meaning it's still an open apex, but the length has completely formed. So what you can do? You can do either revasc or MTA barrier. MTA apexification or MTA barrier. But better answer, don't waste the patient's time when there is no added advantage because the length is already formed. It's not blunderbuss. MTA apical barrier is a better answer. So many times I've told you when I've been talking about Schweck's classification, guys, please, at least our students. Yes, and I'm sharing a screenshot here. This is November 2024 INI exam. Yes, you had the statement 1 and statement 2. Schweck type 2, what should you do? Schweck type 4, what should you do? Bang on. So this is actually a simpler version of this PYQ. And we have discussed this so well in our recall. Isn't it, Saurabh? Trupti, wow. Excellent, guys. MTA सबने किया हमारे बच्चों ने. Wow, excellent, man. Wow. Excellent. Okay, this is also simple, guys. This is also simple. Perforation is encountered at the start of endodontic treatment. Perforation should be prepared before definitive treatment of root canal. Yes. What are the... So many times this has been asked. In fact, so many times that I've not even put I think the screenshot of the PYQ here. Guys, what is the most important factor determining the success of perforation repair? Time, location, level, size. So time is as soon as you repair it. Repair it as soon as possible. Okay. So that's a correct statement. What is statement 2? Collagen is the material of choice for perforation repair when adhesion dentistry is performed. No. This is again a PYQ wherein it was asked calcium sulfate or capset. If I remember correctly, it's 2025 only. May. Either AIMS or NEET. Calcium sulfate is the material of choice for perforation repair when you are planning for wet bonding. That is adhesion dentistry. Right? Not collagen. In fact, collagen is contraindicated because it absorbs moisture. Yes. So statement 1 is right. Statement 2 is wrong. Statement 1 is right. Statement 2 is false. Yes. Excellent. Statement 1. Now this is also simple, guys. Accuracy of apex locator is influenced by pulpal and periapical condition of the tooth. Yes, unfortunately. I mean, if you have it full of abscess, it might give you a wrong reading. If you have periapical condition where there's a lot of root resorption, then you would want to go for a paper point method, right? So this is the right statement. Accuracy of apex locators influenced by the type of metal? No, dear. I mean, apex locators are not fools. They won't be fooled about with whether it's stainless steel or nitride because both are good conductors of electricity, right? So statement 1 is right. Statement 2 is wrong. So answer is C. Yes, straight from our notes, you can see here. Obviously, it was also not, that it was talking about any generation. So if you have the recent apex locator like 5th generation, pretty recent than what we are using, like root ZX is 3rd generation. If the canal is too dry also, then also the apex locator sometimes gives you false reading. And if it is full of abscess and pus, then also it gives false reading. Right? So it is influenced by pulpal and periapical condition, yes, but it's not influenced by the type of metal. That's false, right? So if you see here in our notes, you have this diagram wherein we are talking of that the disadvantage of the earlier apex locators is that it would be sensitive to pus, saline, pulpal remnants, etc., etc. Yes. So again, straight from the notes, and if you have used apex locator in your internship, then you would be knowing this answer. Okay, guys. Next question. Oh, this is simple, guys. So many times I've told you, I take so much efforts in telling you elbow versus zip versus ledge versus transportation. You have to mark it right. You just match the following. So ledge is what? It's uh, artificial irregularity that is obstructing the apical axis. Okay. Then what is a zip? It is the elliptical shape of the apical foramen. What is the elbow? It is the constriction or narrow anatomy coronal to the zip. And what is the transportation? Transportation is removal of canal structure on the outside curve, right? Yes. So you can see here, I've gone to the extent. So just see the accuracy here. I mean, literally on the same page of the note, I've shown you all these things. Can you see here? Elbow, you can see here constriction when you are doing an apical zip. Now you formed a iatrogenic constriction coronal to it. Exactly the same question, right? So you have this, then you have zip, then you have ledge. What else do you want? Everything is there. Ah, excellent, Saurabh. So everything is there in our notes, guys. Everything is there. Yeah. Yes. Obviously, this being a YouTube, session free for all. I mean, our students know this. Other students also for their information, guys. We at DBMCI take lots of efforts in our content also. Yes, not just in our recall, but our content also. Most common cause of failure of pit and fissure sealant, guys, moisture contamination. It's doing it in kids, guys. I mean, you can't apply. It's very tough to apply rubber dam. Cotton roll, they just take it out. So obviously, you're trying to bond it. Saliva will come. So this is simple, guys. I mean, you don't need anything, right? You just have to be a third year undergraduate to know this moisture contamination, right? That's the answer. Yes, simple. Okay. Match the following. Okay, guys. So Vatucci type 1. Oh, wow. So many times. Every time in my GT, I'm putting this, and here is the answer. This is from our notes, guys. So Vatucci type 1. What were the options? 1, 2, 4, and 5. 3 was not there. Okay. So Vatucci type 1 is 1. 2 is 2 merging into 1. 4 is simply 2 canals. And 5 is 1 dividing into 2. That was the answer. Okay. So you have to match the following. Match the correct one. Those of you who do our GTs regularly, forget about this. I mean, this is there in the notes, of course, but those of you who do our GTs regularly would never get this wrong. Yes, PYQ be a beta, but it's just that PYQ is usually asked as one diagram. Usually in the PYQ, they just put you this one diagram, right? And then they ask you. Yeah, thoda sa they wanted to confuse you by giving you match the following, right? So I hope at least our students got this right. I know people will get confused. 1, 2, 4, and 5. 5 में बहुत confusion है. 1 dividing into 2. I always tell you this mnemonic also, no? You keep on simple way. You keep on adding, on the left hand side 2 if 1 is there, 1 if 2 is there. But the catch is 4 and 8. At 4, you have to break that protocol. 4 is simple, 2 canals throughout. Isn't it, guys? Saurabh, yes. Happy. Anirban. कहाँ पे हो सब लोग? Shalini. Yeah. Simple, guys. Okay. This is simple, guys. Filing away from curvature, anti-curvature filing, guys. I mean, so many times. Anti-curvature filing. Again, you want to see the strike rate. Practically everything is there in the notes. Yes. We have this. Yeah. Anti-curvature filing. Yeah. You will find everything, either directly or indirectly, from our lectures, from what we tell you, from the Telegram group, from the GTs, from the notes, not just the notes, the GTs, the recalls. Now we've been doing these recalls now from since more than 3 years now, right? At DBMCI MDS. So guys, all that content, take even the PDFs that I share with you in the Telegram group, the latest guidelines I told you. I mean, if I've taken a lecture, say 4 months back, and there's a latest guideline today, please add this into your content. Add this in one way or the other. Take a printout, do whatever, add this to your notes. Okay. Yeah. Everything is content, right? Here. Excellent. Okay, guys. Yeah, this was a new one, guys. So matrix band and retainer you applied on a tooth. It leads to a decrease in the pulpal blood flow in the adjacent tooth. So, guys, basically, the question is that you have this premolar, okay? And this is just a hypothetical, I mean, right? And you have a molar in which you are doing a class 2, right? You've applied a Toffel-Mayer band. So this causes some, pressure on this on the gingival blood supply, right? So the body's homeostatic mechanism would be vasodilatation, right? So there would be increase in blood at the expense of the adjacent tooth's blood supply to the pulp. You understand? So this is known as the stealing phenomenon, okay, or the steal theory, or the stealing theory. So that's a new question, guys. Steal theory, okay? That's the steal theory. Uh, that's a new question, okay? So steal theory is the answer, or the stealing theory, actually. The stealing theory. Uh, you know, Stealing. It was my right, but because the body said, no, you need more blood. Okay. The one which is suffering trauma. Yes, it needs more blood. So stealing theory is the answer. Okay. Okay. This was kind of a repeat from the 2 weeks back. Neat, isn't it? Guys, laser, the moment you see affinity for both water and hydroxyapatite, forget everything else. Only two lasers should come in your head. One is erbium YAG, which works at 2940 nanometers, and the other is erbium chromium YSGG, which works as 2780 nanometers. Okay. This is what is known as laser powered hydrokinetics. Okay. And because they have affinity for both hydroxyapatite and water, pretty good. In fact, if you see in my notes, if you see here, PIPS, photon initiated photoacoustic streaming, erbium YAG laser. Do you understand? ये सीधा note से है, but I would tell you a better way of remembering this, because this question came as part of, I think it was discussed in perio in the NEET recall, which is good, but here we are discussing it here. Why? Because it was specifically mentioned endo treatment. Okay. Forget about everything else. The moment you have this question, which is talking about a laser which has got its absorption both in hard tissue, hydroxyapatite, and water, it's either a erbium YAG laser or erbium chromium YSGC. Both options will not be there. If both options are there, then obviously you will have a multiple correct answer type of a question. Okay. Yes. Straight from the notes, but as I said, remember this also what I'm saying. Laser powered hydrokinetics. Okay. All right, match the following. This is simple, guys. So many times, I mean, I take so much effort, and those of you who attended my recordings for my conservative, I do everything in detail. Class 1 amalgam separate, class 2 1 composite, class 2 amalgam, class 2 composite. Right? Mylar strip. What would you do a mylar strip for? Anterior composite. Huh? What would you do a window technique for? You basically have a Toffel-Mayer band. You cut a window for a cervical lesion. Yes. What would you do for a sectional is best for a posterior class 2 composite? Yes. I'll show you the screenshots also. What would you do for I'll show with another color here. Toffel-Mayer, because it completely encircles. So it's good for MODs. That's a complex amalgam. Simple. Yes. You see here so many times We are talking about in the notes Mylar strip, sectional matrix, Toffel-Mayer, sectional systems. I also give you examples of Palodent and Garrison. In fact, Garrison is my favorite. I use it in my clinic also. One of the very good sectional matrix for class 2 posterior composite. Yes, yes. So and if you see the notes, if you see my lectures, time and again, I would keep on repeating this so that it gets in your head, isn't it? Yes. Okay, this was a good one, guys. New one from endodontic surgery. A gap of 5 mm between bone defect and incision line should be there. All of you know that a gap should be there. Should it be 5 mm? That's actually right. Yes. This is a new one. This is the examiner is pretty smart here. So mark this as star mark because we don't expect you to know exact value of 5 mm. I mean, come on, but yeah, this is true. This is not given in Cohen, this is given in Engel. Okay. Following wound closure, the flap should be passive and tension free. Both statements are right. Okay. So both statements are true. That's the answer. I hope, I mean, those of you who got this right by chance, you guys got lucky, man. I mean, if I were you, I would not have remembered this 5 mm value, right? So, anyways, that's okay, guys. Happens. Okay, which doesn't belong to Bacteroidetes family. Rather, it's a phylum, I think that was asked, right? Now, this again, we don't expect you to memorize these names. This was again a question of exclusion. Those people who have done in the last 5 years in your entire BDS, no partying, only studying, only they will get this right. Okay, so you have this Bacteroidetes. I mean, even the fact that we tell you, I don't expect you to memorize this. Okay, so Bacteroidetes, you have Tannella was there in the option, Porphyromonas gingivalis and Prevotella intermedia. Okay, what is not there is Fusobacterium because that in itself is another phylum on its own, right? It considers itself pretty strong. It's another power center. So Fusobacterium is the answer. But as I said, only those students, despite the fact that we tell you, I mean, I don't expect you to memorize these bacteria for every phylum. So only those students will get these right who are really, I mean, who are really studious. I mean, come on. So guys, the answer would be Fusobacterium here, right? Which does not belong to Bacteroidetes phylum. Okay. The answer is Fusobacterium nucleata. Okay. All right, great. So speed of conduction of A beta nerve fiber, again, that's the answer is 30 to 70 meters per second. Again, we do discuss this, as you can see here, Erlanger-Gasser classification, but only the conceptual things. I don't expect you to memorize the value, but since it has come now for future exams, at least please remember now A beta speed, which is 30 to 70, which was the answer here, A delta, which is 6 to 30, and C, which is 0.5 to 0.22. At least those which are innervating the tooth. Okay. Hmm. Acha, that's good. Yeah, Pavana, that's good. If you, as part of perio, if you remember the red complex bacteria, that's good. So you should get this right. Great. So now going forward, till now, never a question has been asked in which they have asked specifically the conduction velocity. This is pretty tough, isn't it? I mean, we expect you to know which are myelinated, unmyelinated, which are thicker, which are lesser, which have a greater conduction. But I mean, this speed. So from now on, I would recommend remember at least these three values. Okay. Okay, great. So 30 to 70 is the answer. And I think we are left with just one. Splinting and traumatic dental injury. Oh, many times I've told this to you. The answer is flexible, guys. Ideally, the answer is flexible in general. Only if you have alveolar bone fracture, etc., then you can go for a more rigid. Now, in more rigid, it doesn't mention whether it's semi-rigid or completely rigid, but flexible is the best answer. Semi-rigid is not the best answer. Flexible is the best answer. कौन सा गलत कर दिया? हाँ, gap of 5 mm is right here. Yeah. Okay. So flexible is the best answer. This again, we keep telling you about things here in the notes. Now, this is, guys, match the biomarker and regenerative procedures with their effect. So the biomarkers that were given were DSPP, SDF1, VEGF, BMP7. I don't expect you to memorize this. From now on, just I've got this. Memorize this now, okay? So chemo attraction for for stem cells of the apical papilla to migrate into the pulse space is the function of stromal cell derived factor 1. Okay, this becomes I'll double star mark this. I mean, if I were you, I would never remember this. This is very tough. Directs BMP7, DSPP does what? It facilitates reparative dentinogenesis. That's the answer. For BMP7, directs differentiation of stem cells into odontoblast-like cells to reform functional dentine and pulp tissues. And VEGF promotes migration, proliferation, and differentiation of endothelial cells to form a new microvascular network. Okay, so guys, we need to remember this. Okay, so you had these options and you had these 4 lines, right? In order to remove the confusion, I just marked the right answer for you. Take the screenshot, or obviously this will always be there on YouTube, so you can always refer to this, right? So I've double star marked this. This becomes an important PYQ. From now on, don't get this wrong. That's the answer. Again, better to leave this. Better to leave this question. Okay. Yeah. So all in all, this is one question that I would expect you to leave one. Then the second one would be flexible splinting is right. I've told you this many times. Speed of conduction you can leave. That's 2. So out of a total of DM endo, how many have we discussed? We have discussed 40, right? So 1, 2, then 3, and lastly the water one, in which the slow crack growth. So 4 to 5 out of these, at least from my subjects, I would suggest out of 39 to 40 questions, you should have left. You should have left uh, 4 to 5 questions, right? Because the chances of you making a guess and getting them right are very bleak. So out of my 39 to 40 questions of DM, endo, and cons in this paper, which I consider moderate to tough, more on the tough side, you should have left 4 to 5 questions. You should have left. Because yes, there's always this thing of, if we get these right, even if we get, see the data, I'll tell you how it works. Say 4 questions you're guessing, right? If you get, say, even 1 right out of these 4, so that's +3, and you get 3 wrong, that's -3. So you took the risk, but you're still at no loss. Out of these 4, if you get 2 right, so that's 3 multiplied by 2, that's 6, and -2, so 6 minus 2, 4. So you're still at +4. But the problem is that these 4 questions were so off that the chances of you getting all the 4 wrong are pretty high, right? So I would suggest, yeah, excellent, Dr. Leafort, good. So yeah, this is where you have to be very intelligent in identifying. So out of a 200 paper question, you should leave in a tough question paper. I think you should leave 12 to 15 questions. A 185 to 190 attempt is pretty good out of a 200 paper question. If it's easy, then you can go up to 192 to 195. If it's a tough paper, 185 is not a bad attempt. 185 to 190. Yes, guys. So I hope all of you see the recall. In conclusion, the paper was moderate to tough, and best of luck. Relax. And next, our pediatric dentistry faculty, ma'am, Dr. Anaya, would be joining you. There were questions from VPT. Yes, so ma'am would be taking VPT questions, 3 to 4 questions. Again, all the answers would be all from the latest guidelines of AAPD, which I shared with you. So over to Anaya, ma'am. Thank you, ma'am, and thank you all for listening. Thank you, guys.
Hello, guys. Hi, dear students. How was the exam? How was INI? So I went through all the questions, and I feel these from the periodontics in INI generally. It was direct questions mostly, very less clinical questions, or the twist and turn type of questions were very, very less. What did you feel? I think more of, application kind of questions were asked in NEET, what I feel like. What do you think? Hi guys, have you all joined?
Please remember now.
Okay, so I'll just wait for a couple of more minutes for you guys to join and just let me know if I'm audible. We'll begin with the pedo session then. All right. So, as I told you, in NEET, we had a lot of, twisted questions. There were questions from child psychology where you needed to, think ki, okay, what can be the answer? You need a lot of application kind of knowledge for it. But yes, okay. But in INI, there were a lot of questions from pedodontics, but all of them were straight questions, straight picks from our lectures, straight, the direct picks from the notes. So I think pedo should not have been a lot of problem for you all. So good morning, good morning. So let us begin with the questions that you were asked in the INI-CET 2026. All right. So the first question that we have here is a child presents with white spot lesions. Okay. And all right, just give me a minute. Right. So, child presents with white spot lesions on the anterior teeth. There is visible plaque accumulation and there is a history of frequent night bottle feeding. Okay. So, what all is given that they have given already that there are white spot lesions, then there is visible plaque accumulation, and also there is a history of night bottle feeding. So, there's a history of night bottle feeding also, right? So, this itself says that the child has very very high chances of getting caries, or he comes under the high risk caries. Okay, high caries risk patient. Okay, so what they've asked is what is the caries risk assessment and what is the appropriate management of the same. Okay, so what they've asked, so you say moderate caries, but see, he already has white spot lesions, there is plaque accumulation, and there is history of night bottle feeding. So he does fall in the high risk caries, and you need to give a fluoride application because restoration is not possible. There is just a Okay, the restoration is not possible. There is just a white spot lesion. You need to remineralize it with the help of fluoride application, because he will and the fluoride application will prevent the further caries. See, he has night bottle feeding. That means he is a very young child, already having white spot lesions, already having plaque accumulation. So he comes under the. Okay, just give me a minute. I think. Right. So he comes under the high risk caries and fluoride application needs to be done. Just a minute. Right. So the answer here becomes, sorry for that 1 minute gap. Hmm. Okay, so I would go for high risk caries with fluoride application as the answer. White spot, visible plaque, which is going to very quickly make the child go from white spot to a full blown cavitated lesion if it is not remineralized. So the answer here is high risk caries with fluoride application. Okay. Yes, no cavity is present, but there is visible plaque accumulation with a history of night bottle feeding. So the child comes under a high risk caries, and you'll give fluoride application because he has just procured white spot lesions, and the presence of plaque and history of night bottle feeding is going to very rapidly increase the status of the caries. So the answer is high risk caries, high caries risk, because see, only one white spot lesion is given, but please understand there are other other situations that there is plaque accumulation plus history of night bottle feeding. He might have come to you in a situation where he has a white spot lesion, but you saw plaque accumulation and night bottle feeding ka history, so he comes under a high risk caries, and there you can give fluoride application because of presence of the white spot lesion on the anterior teeth. Okay. The next question is, so as I told you, ki the topical fluorides are indicated in case of high risk activity, high caries risk, as it is given, as the situation is given in the particular child where he has white spot lesions, but there are other situations that are going to very rampantly progress the situation of caries. All right. The next question is, match the following pulp therapy procedures with their indications. Okay, so they had given various pulp therapy procedures and the different indications. Okay, so the procedures that were given were pulpectomy, pulpotomy, indirect pulp capping, and direct pulp capping. So the indications were like this, like this is how it was procured. So pulpectomy is actually done in case of irreversible pulpitis. Yes, pulpotomy is done where there is coronal pulp involvement, but the radicular pulp is not involved. So pulpotomy is where the coronal pulp is involved and it spares the radicular pulp. So pulpotomy, coronal pulp involved in the deciduous teeth. Indirect pulp capping, where there are deep caries but the pulp is not involved. Okay, deep caries but pulp is not involved, indirect pulp capping. And direct pulp capping, where there is mechanical exposure. So this might have been jumbled up, but these were the options that were given to match. So A goes for 1, B for 2, C for 3, and D for 4. So the answer is A, where pulpectomy is for irreversible pulpitis, pulpotomy, coronal pulp involvement, indirect pulp capping, deep caries involving not involving the pulp, and direct pulp capping, mechanical pulp exposure. Okay, so these are direct indications that we've read in our lectures, right? So I hope you've got them all correct. We've read about the objectives of IPC, where we read that there is no pulp involvement, but the caries is very, very close to the pulp. Okay. We read about DPC, where there is the pulp, there is mechanical pulp exposure and the pulp is just pinpoint exposed. Then we read about pulpotomy, where the coronal pulp is involved and the radicular pulp is spared. And there is pulpectomy, where there is irreversible pulpitis. So this is straight pick from the notes. Direct what do you call as direct indications they've asked. No gumao firao thing. Okay, so I hope you've all got it correct. The next question was, what is the age range of the window of infectivity for transmission of Streptococcus mutans? So again, this is again a very direct question, nothing very conceptual or nothing very clinically applied in this. So we had read in one of the GTs about window of infectivity, where we had read that window of infectivity, the first window is 19 to 31 months, and the second window is ages 6 to 12 years, 19 to 31 months and 6 to 12 years. Okay, so the exposure of Streptococcus mutans is in 19 to 31 months of age. This is what is the window of infectivity. All right. Okay, I hope you've got this correct. Please let me know if you've any doubts so far. Yes, this was asked in the GTs. Okay. The next question was, a 5-year-old child presents with early loss of the second primary molar before eruption of the first permanent molar. Which of the following is the space maintainer of choice? Okay. So the child is 5-year-old, right? Again, a very straight pick. We've discussed this particular situation in the GTs over and over again. We've read about this indication in our notes, during the lectures, recorded lectures, everywhere. There is no brain, storming in this question. A 5-year-old child presents with early loss of the second primary molar, that is E, before the eruption of the first permanent molar. Which of the following is the space maintainer of choice? So, in this case, what is going to be the space maintainer of choice? The space maintainer of choice is going to be distal shoe. Undoubtedly, we've read about it. We've read that it guides the eruption. It is intra-alveolar appliance, and it basically is given in case where the E is exfoliated before its time and the first permanent molar still has time to erupt, so that the first permanent molar does not erupt into the position of the second primary molar that is exfoliated, you give an eruption guidance appliance. Okay, the eruption guidance appliance, also called as the intra-alveolar appliance, right? This is given, that is the distal shoe. This is again the straight pick from the notes where we had read about the intra-alveolar appliance, the indications where it is given. The next question was factors affecting the choice of space maintainers. So they had given 4 factors and you had to choose. It was a multiple correct answers type of a question. Okay, it included a word called as guidance appliance. Okay. But the situation is given such that there is no other, brain application required. It's a straight distal shoe there. Right? Now, factors. What they've given is dental age, chronological age, sequence of eruption, and time elapsed since the tooth loss. So, I just want you all to have a look at the screenshot of the notes that I have got. There was in the notes we had consideration for planning of a space maintainer. Okay, good. है ना? It was an easy exam, very nice. And INI-CET being easy is very good. Just that the seats are so less, but it's good. The questions were really straight, really straight. I think NEET this time was a little more, twisted as compared to INI. But okay. So this is from the notes, and directly we've given time elapsed since the loss, dental age, amount of bone covering. This is a straight screenshot, and they had given this question where there was an option dental age, sequence of eruption, and time elapsed since the tooth loss. So chronological age you really do not need to see when you are choosing a space maintainer. So the answer goes A, C, and D. The answer is C. Okay, the answer is C, that is A, C, and D. Chronological age is really not helpful when you choose these space maintainers. Next question, again, a match the column, match the following kind of a question. They had given oral habits and they had given the dental condition. That is what type of what happens or what is the oral manifestation of a particular oral habit. So there was tongue thrusting, bruxism, mouth breathing, thumb sucking. Okay, so I just came across the endo discussion also, and you had matched the column kind of questions within endodontic conservative and endodontics also, but that's nice. Again, a very straightforward one. So bruxism, you all can, it must have been jumbled up, but that's how I've written like straight here. So bruxism, it is occlusal wear facets you will see. Mouth breathing, you are going to see posterior cross bite, and sometimes you'll also see scissor bite in the posterior area. Okay, tongue thrusting, anterior open bite, and thumb sucking, anterior procline teeth. Again, just have a quick look at the notes. These are screenshots from the notes. Thumb sucking में just see thumb sucking, anterior procline teeth. So we have this picture. This is thumb sucking where we have the proclination of the teeth over here. Then we have bruxism. So in the bruxism, we have wear facets in the notes, screenshot of the notes. And then we have tongue thrusting, anterior open bite in tongue thrusting, direct screenshot, and mouth breathing. Again, we have buccal crossbite, posterior crossbite because of the collapsed segment. Okay, so these are, again, as I told you, straight picks, no brainstorming required there. The answer here is B. Okay. Right. Now, the next question is, which of the following toothbrushing techniques is commonly recommended for children? So we had so much discussion about, ma'am, where do we use horizontal scrub? Where do we use phones? Phones bhi aa gaya, horizontal scrub bhi aa gaya. So what are we going to mark for toothbrushing in children? So the paper setter for INI made it so easy for you. He gave you just phones. All of the rest of them are basically techniques that the adults are supposed to be using. You directly go for phones. You remember, my students, if you're here, there was so much discussion ki ma'am, there are two techniques that we are coming across in children. There is horizontal scrub and there is phones. And phones, है ना? तो वी हैड अ ग्रेट डिस्कशन कि 6 years से कम हो तो वी गो फॉर phones, and 6 years से ज़्यादा हो तो वी गो फॉर horizontal scrub. But all you got in the questions is phones, so you go for phones technique. Again, we had discussed this in our GT discussion. So GT में we had discussed about the children, that is phones is a circular method of brushing the teeth. Yes. Okay. The next question that was there was, pulpal change after traumatic dental injury includes. So, again, I think we discussed this in one of the GTs only. What pulpal changes occur after traumatic dental injuries. So, yes, in the GTs. So the changes in the pulp that occur after a trauma is the pulp undergoes necrosis, the pulp has inflammation, there is pulp canal obliteration due to calcification that occurs, there is transient apical breakdown, and there is resorption that occurs. So resorption is internal resorption basically that occurs. But 1, 3, 4, no, 2 is also there. Is pulp necrosis that occurs after trauma. The answer here is 1, 2, 3, and 4 if these were the options. Because just a second. Because pulp obliteration does occur, pulp necrosis also occurs. There is internal resorption that takes place because there is osteoclastic activity that is generated, that begins from within. So internal resorption also occurs. And in case of primary teeth, it does accelerate the physiologic root resorption also. Okay. So the answer is 1, 2, 3, and 4. The answer is 1, 2, 3, and 4. Okay. Anybody got this correct? Okay, so in case of primary teeth, there is an osteoclastic activity that begins in the internally and externally, because of which the external resorption also starts. And when the external resorption starts, the physiologic shedding of the tooth becomes very, very fast. So there is accelerated physiologic root resorption because of the external root resorption that starts. That is why we go for 4 also as the correct answer. Okay, who asked me? It is because of the external resorption that the physiologic shedding of the tooth becomes accelerated. That is why the answer 4 is also correct. So 1, 2, 3, and 4, all 4 of them are correct options. Correct? Right. Okay. The next question is, a 4-year-old child becomes anxious and cries in the dental clinic. The most common reason for fear in this age is. So again, this was a multiple choice kind of a question. And here the options given were novel situation, school peer influence, separation from parents, and health. Okay, so the answer here, basically what I'll tell you is, because separation from the parents is correct. Okay, because in 4 years of age, separation anxiety is like at the peak. The child is actually scared of being separated from the parents. Question was, what comes first and what comes last? Okay, in which one? In the previous one? If in this one you were supposed to arrange it according to the sequence, so the first thing that occurs will be pulp obliteration. It will be pulp obliteration, followed by pulpal necrosis, followed by internal resorption, and then accelerated physiologic root resorption. Okay, so these are going to be the this is going to be the sequence if it was asked in the sequence. Otherwise, all 4 of them are correct. Pulpal changes like these do occur in the traumatic dental injuries. Okay, now in this one, basically, as I'm telling you, separation from the parents to hai correct. The other correct option is novel situation. Now, what is a novel situation? Novel situation means a situation where the child is scared of everything new that is surrounding the patient. Sequence, no sequence was asked. Acha, theek hai. हाँ ठीक है. Okay. So in this one, the correct answer is option 1 is also correct and option 3 is also correct. है ना? Okay, so it should be 1 and 3 here. है ना? So basically novel situation का मतलब है something that is new. So a child who is 4 years of age will be scared of unknown objects or new situation, new people. Okay, and separation from the parents तो correct है ही. So the answer is 1 and 3. ठीक है? हाँ, 1 and 3 ठीक है. है ना? So this is a pic from the notes. So we had covered in the notes types of fears by the age. Okay, so in this 4 years of age, matlab the child is scared of being alone, that is being separated from the parents. So separation anxiety to shuru se, after the child becomes is like attains the sense of the parents around him, he'll have separation anxiety. So the child is scared of being alone or separated from the parents. And novel situation is something that is fear of environmental threats or imaginary creatures. So he is scared of new situations, new people, new environment. Okay, स्कूल इन्फ्लुएंस नहीं होता है इसमें. स्कूल इन्फ्लुएंस 4-year-old child, there is no peer influence. The peer influence is strongest at the teenage. A child is not influenced by the peers at the age of 4 years. So he's scared of being separated from the parents and he's scared of the novel situation. Novel situation matlab something that is new around him. Did you get it? 1 and 3. Yes, 1 and 3 kar diya na correct. I corrected it, Siddhant. है ना? So 1 and 3 is the correct answer. Next question. The next question was, match the following behavior management techniques with their characteristics. Okay, so behavior management techniques were given and the characteristics were given. So again, this must have been jumbled up, but I think I have just written the correct answer in front of them only. So there was tell, show, do technique, there was modeling, okay, then there was home technique, and there was voice control. Okay. So, tell, show, do technique, yes, tell, show, do technique is basically familiarization. That means the child becomes familiarized with what you are going to do. You tell the patient what is to be done, and then you show the patient what is to be done, and then you do what is. So, you are familiarizing. Okay, that is called as familiarization. Right? Modeling, that means observational learning. The child is looking at a live model, or particularly a video or a toy. So he is observing and learning. That is observational learning. And then the home technique, that is hand over mouth technique. So hand over mouth technique is like a tonic immobility or control. You are gaining control over the child. And then voice control is controlling a hysterical behavior. Okay, so the answer again here is A, B, C, D. है ना? I've just written the correct answer in front of them. ठीक है, I hope अभी तक तो सब करेक्ट गया होगा. Is there anybody जिसका अभी तक एक भी has? Do you have any even one question of pedo wrong until now? I think until now everything must have been correct only. Next question. So a young patient presents with carious pulp exposure in a primary molar. Voice control option was different. Was there okay, so can you recall what was the option given against the voice control? Aparajita, was it about a patient who had a whining behavior or complaining behavior, or who was making a lot of noise? Was it something like that? Okay, just let me know. I think it is right. The next question is, a young patient presents with carious pulp exposure in primary molar. So there is a carious pulp exposure in primary molar. Coronal pulp amputation is performed and hemorrhage is controlled. So the coronal pulp is removed and the hemorrhage or bleeding is controlled. There is no bleeding from the radicular pulp. What is the preferred material for further management? So what are you going to do further? So you've removed the coronal pulp and now the radicular pulp is not profusely bleeding. So what are you going to do? The first option that we've procured is the calcium hydroxide pulpotomy is better than MTA pulpotomy. So that's not correct. There is laser pulpotomy, formicrosol pulpotomy, and calcium hydroxide pulpotomy is better than ferric chloride pulpotomy. But if these were the options, the correct answer is formicrosol pulpotomy. So what you'll do in this case is you'll take formicrosol, fix the radicular pulp that is there, the pulp stumps that you all can see, you fix it, and then you do the coronal pulp, you restore the coronal part of the tooth. So the answer will be, okay, there was tone modulation there. Okay, let's go for tone modulation. Okay. And was tonic mobility and control an option? Because I think hysterical behavior to tha option. Was this an option? Okay. The answer here is formicrosol pulpotomy. The next question was very similar to this. A young patient presents with pulp exposure in a primary molar. After coronal pulpotomy, hemorrhage remains uncontrolled. So, yes, tone modulation. Okay, done. ठीक है. So tone modulation for voice control तो हो गया, है ना? हाँ. So tonic immobility was not the answer. Home technique के लिए the answer becomes hysterical behavior. Yes. So hysterical behavior becomes the answer for home technique, and for voice control, tone modulation is the technique. Done है? Yes, got it. Okay. So there was nothing like tonic mobility or control. There was a hysterical behavior that was the option. So home technique, that is hand over mouth, goes for the hysterical behavior. Somebody who's not listening. And tone modulation, that means you modulate the power, the volume of your voice, and that becomes voice control. ठीक है, तो ये आंसर है. ठीक है, डन. So wherever there was an option that this is okay, great. This is better than MTA, that is better than MTA. Nothing is better than MTA when it comes to pulpotomy. Pulpotomy ke liye MTA and biodentine are the best. So wherever you get a question, this is better than MTA, that is better than MTA, that is a wrong answer. Okay, MTA and biodentine are the best materials for pulpotomy. The answer here is formicrosol pulpotomy. Okay. The next also, a young patient presents with pulp exposure in a primary molar after coronal pulpotomy. Hemorrhage remains uncontrolled. So if there is still hemorrhage that is occurring. That means there is bleeding from the radicular pulp that is still happening. What will be the next line of treatment? So the next line of the treatment will be complete pulpectomy, because hemorrhage from the radicular pulp means hemorrhage from the radicular pulp means that the radicular pulp is also inflamed. Okay, this means radicular pulp is also inflamed. That means you have to remove the complete radicular pulp and you have to go for a complete pulpectomy. The answer is B, complete pulpectomy. Correct? Okay. The next question is, an 8-year-old child presents with trauma to the central incisor. An 8-year-old child presents with trauma to the central incisor. The tooth has immature open apex. Of course, 8-year-old hai. After the tooth erupts, it takes around 2 to 3 years for the root completion to happen. We've read it in our lectures. ठीक है? So, है ना? तो 8-year-old है, मतलब 7 year के around, if the tooth would have erupted at 8 year, the child will still have an immature open apex. The tooth is vital. There is still vitality in the tooth. There is no sinus tract. That means the pulp is healthy. What is the most appropriate treatment that can be done? So the most appropriate treatment that can be done is maintain pulp vitality. No need to go for epexification. For that, you'll have to remove the entire pulp, but the pulp is vital, so no need for that. No root canal, no extraction. Maintaining pulp vitality will result in a procedure that is called as apexogenesis. That will help in continued root development. That is apexogenesis. Okay, the answer is maintain the pulp vitality. Correct? Okay, we've read about apexogenesis. This is a screenshot from the notes. So it is just whenever there is pulp, the pulp is vital and there is immature root apex. So you go for a continued root development. That is apexogenesis. Next question. The preferred material used for anterior teeth civet pulpotomy is. So whenever you go for a pulpotomy, civex pulpotomy is the partial pulpotomy. So you go for MTA. Okay, so one of you is saying it was given as non-vital tooth. So in case it was given non-vital tooth, so you go for apexification. But the question that I have procured, it was a vital tooth with no sinus tract. So in that situation, we'd go for maintain pulp vitality. And if it was a non-vital tooth, you undoubtedly go for an apexification. ठीक है, आया समझ में? No confusion there. नॉन वाइटल है तो एपेक्सिफिकेशन, वाइटल है तो मेंटेन द पल्प वाइटैलिटी एंड गो फॉर एपेक्सोजेनेसिस. ठीक है, राइट. नेक्स्ट क्वेश्चन. A 7-year-old recall patient with very high caries susceptibility, proximal tight contact, which cannot be visualized or probed. it should be assessed with what? Okay, now the contacts are very tight, you cannot clinically see, you know that the child has a very high caries susceptibility. What are you going to do? So the best thing that you do is you take a multiple series of periapical radiographs or multiple series of radiographs. Okay, we have read about the radiograph protocol. Vital was given. Okay, okay. So we've read about the radiographic protocol, in which we have read about 4-film survey, 8-film survey, 12-film survey. So you remember, this is a screenshot from my lecture, from the PDF that I had shared with you. Remember? So this becomes an 8-film here. So for the 6 to 7 years, they've given 7 years of age. If there are extensive caries or no apparent abnormalities also, you go for Hanji Tarun. Interproximal caries were there. So you go for an 8-film survey and selected periapical X-rays will be taken. So if there was given an option that multiple series of radiographs should be taken, you should remember the radiographic protocol, the 8-film survey for the 7-year-old, and you should go for the multiple series of radiographs. If multiple series of radiographs was not one of the options, then you go for bite wing radiographs, but it's given only posterior. So the best option is multiple series of radiographs, where we go for the radiographic protocol that we have read in our lecture of dental caries. I hope you all remember this. Okay? Okay, the next question, I think yes, we just have 3 more questions to go. The next question, a 6-year-old child presents with yellowish discoloration of molars as seen in the image below. The child does complain of sensitivity. What is the preferred management? So this is a case of MIH that you can see, and in such a case, you go for stainless steel crown. Sealant will not help there. Composite restoration will not help. Okay, extraction not required. You will go for a stainless steel crown. Child was not able to open his mouth, it was mentioned. Okay, in this one? Okay. Okay, then but if there is a less mouth opening, then the OPG is only you're left with. Bite wing you cannot take. You cannot take the multiple series of radiographs. If there is very much reduced reduced mouth opening, then you go for an OPG. Okay? With tight contact. Okay, so I am telling you all the situations. If this was the question that was given, you go for multiple series of radiographs according to the radiographic protocol. If there was reduced or very less mouth opening, then you go for an OPG. Okay? In this question, you go for a stainless steel crown. The others will not work. Okay? Right. The next question is, a child with newly erupted molars presents with yellowish discoloration, hypersensitivity, chipping of enamel is diagnosed with molar incisor hypomineralization. What is the preferred management? So when there is chipping of enamel, a bonded restoration and composite restoration both require proper enamel to bond. Okay, so this is not going to help. Even amalgam restoration will not help, because it requires a proper cavity preparation. So for this situation also, you need a stainless steel crown. Okay, so the answer here is B, stainless steel crown. Right. Next question is, intervention for thumb sucking habit is usually recommended in. Okay, so adolescent may nahi. Before eruption of primary incisors, no. The child is very young, 2 years old, no. But less than or around 4 years, you have to intervene, because if you remember, this is a screenshot from the notes we have read. It can be considered normal till around the age of 3.5 to 4 years. So just before 4 years, you can intervene to correct the thumb sucking habit. The answer is less than or around 4 years, whatever was given in the option. Okay, so most of these questions have been picked up from our classes or from the GTs that we've discussed. Question number 19 was, a 28-month-old child with high risk is brushes the teeth twice daily. What is the recommended fluoride toothpaste regimen? So, okay, so the recommended fluoride toothpaste regimen according to AAPD is for up till 0 to 3 years or under the age of 3 years, less than 3 years, you gave a grain of rice sized toothpaste. Okay, and for 3 to 6 years of age, you give a pea sized toothpaste. Okay, so what before eruption of Nupur, what I have procured is before eruption of primary incisors. So before eruption of primary incisors, so will be very soon. That is why I'd go with less than 4 years or around 4 years. If permanent incisors was the option, so you can go for intervention before the eruption of permanent incisors. ठीक है, Tarun and Nupur. ठीक है, so okay. ठीक है. The last question was, treatment for bones nodules is. So bones nodules are just cysts that are present in the gum pads of the in the primary gum pads, and you need to do nothing but just observation. It resolves on its own. Nothing needs to be done. So that was the last question that we have for the this thing. Taruna, okay. Right, Taruna. So it was just if it is actually should be intervened around 4 years of age. And yes, if permanent incisors option mein tha, to you can go for before the eruption of permanent incisors. But what I have procured was primary. So I went for 4 years and under 4 years. And bones nodules, just observation you need to do. Nothing else is required. And okay. There it was framed differently, right? So I hope these were the questions that you got for periodontics. And so whatever you've told, we've just done a aisa hua to this answer, if that was there, that answer. I've tried to give you the various options for both the types of questions that could have come. So otherwise, whatever doubts you have, we can discuss in the groups. But my point is, आंसर फॉर फ्लोराइड टूथपेस्ट नहीं बताया क्या? अच्छा, 28 months है, तो दैट मीन्स इट इज लेस देन 3 years, so you will go for grain sized, है ना? 3 to 6 years में pea sized होता है, less than 3 years में it is grain of rice. It's actually not grain sized, it's grain of rice sized fluoride toothpaste, ना? चावल grain of rice sized. A is the answer. ठीक है? So that is what was asked in pedo. And I hope most of you all have got all of them correct, because we've covered everything in our classes, notes, and in our various discussions of the GTs. And all the very best for your results. And signing off here. Bye-bye. Thank you.
Yes, a very good afternoon to all of you. So we people have come here for discussion of questions which were asked from pharmacology subject. And I was just watching the discussion of periodontics, and I found around 20 questions have been asked from periodontics. So a good weightage of this subject in your exam. And we also expected the same kind of weightage for our pharmacology, but unfortunately this time they have given only 2 MCQ. So if we compare from the last time IMSS exam, so there were 14 questions, and this time there were only 2 questions from pharmacology. So I will not take much of your time. Yes, a very good afternoon to all of you. So I have come here to discuss those 2 questions with you people. So last IMSS 14 questions, this time 2 questions. Last time questions were easy to moderate, and this time questions were a little bit difficult, right? So I don't know why this has been done, why there was so negativity for pharma, but fine, it's fine. Like this is AIMS, so we have to respect the AIMS people. We have to respect the quality they offer to us. So it's always be you should always enjoy the AIMS paper, right? So overall paper level was moderate or difficult as per the students. And there were two questions from pharmacology. Question number one. So you people have to help me out in the language of the options which was asked in your exam. So question was, a patient has underwent some organ transplantation, and after organ transplantation, patient is on cyclosporin, that is an immunosuppressant medicine. So this question was also asked in your NEET exam. So this was asked also in your NEET exam 2026, like last month. This was asked in your NEET exam, right? The cyclosporin therapy. The cyclosporin drug was asked in NEET exam, and also it was expected to be asked in the AIMS exam. Now they're asking, what is the effect of this medicine on the odontogenic infection? So question is, what is the effect of the medicine on the odontogenic infection? So guys, the option number one, cyclosporin is an immunosuppressant drug. It will enhance the wound healing. Number one option. Second option, you were expecting that because it is an immunosuppressant, this will suppress the body immunity and the mild infection will be exaggerated. Number three, you are expecting when you take the immunosuppressant, the resistance of bacterial colonization will be seen as a side effect of the drug, and there is an increased neutrophil count seen in these patients. So were these four options there in the exam? So can you please confirm me about this, guys, first of all? First of all, please confirm me these are the four options asked in the exam, or there were other options. So anyone who is online, can you please confirm me, guys? So were these four options there in the exam, or the options were different? So these were the four options. Immunosuppressant drug, enhance the wound healing. Even the mild infection will be exaggerated. So basically, I have tried to find out the effect of cyclosporin on odontogenic infection. So the content was not there in the textbook. So I have tried to find out from the various clinical trials, but unfortunately, I'm not able to find out the effect of cyclosporin on odontogenic infection. So what I have already been able to find out, I have able to find out the effect of cyclosporin on the periodontal tissue. So periodontal infection may the effect of cyclosporin is there, but the odontogenic infection as such, some separate studies are not available. So here the best answer is, because the medicine is immunosuppressant, this medicine can suppress the body immunity. So if you have any infection present in your body, that can be exaggerated. So any infection of your body can be exaggerated because already your body immunity is less, and here hence your body cannot fight with the infection. So whatever infection is there, so this may be a mild infection, can be a moderate infection, that can be exaggerated after taking if you are already on the cyclosporin therapy, right? So the option number one, immunosuppressant drug, enhance the wound healing. No, bache. For the wound healing, we required our immunity to act. We want that our body mechanisms to act over there. So cyclosporin, this is the drug that has a negative impact on the surrounding tissue, periodontal tissue, and hence this medicine can delay the wound healing. You must be knowing cyclosporin can result in gum hypertrophy. Because of gum hypertrophy, you know that it's difficult to clean that particular area of that surrounding. It's difficult to clean that area around that tooth. So there are bacteria which can multiply over there. The infection can multiply over there. So this can delay the wound healing instead of enhancing it. So this statement is false. Now you can see resistance of bacterial colonization will be seen as a side effect of the drug. No, resistance is not seen. Rather, the bacterial quality will change, right? So bacterial quality will change instead of resistance of the bacteria. So we call it oral dysbiosis, right? So oral dysbiosis can be seen. So oral dysbiosis can be seen. The bacteria will change over there. So instead of the normal microflora of our buccal cavity, we have a different kind of microflora now. Like there is a risk of increased candidiasis. So increased candidiasis risk is there. That is a secondary infection that can occur. And also there is presence of some other bacteria which otherwise not been found in this buccal cavity. So that is seen. So instead of having a bacterial resistance, we can see the oral dysbiosis, and we can also see the secondary infection in the form of candidiasis. Now you must be knowing this medicine is immunosuppressant, so this will not increase the neutrophil count. Rather, this medicine will decrease the neutrophil count, and that is how this medicine can make the patient immunocompromised. And because now the patient is immunocompromised, the risk of getting the infection is more common. That's why if there is any infection present, that will be exaggerated. So answer to this MCQ is B, Bombay. So question number 1, answer is B, Bombay, according to me. So in case you people are able to find any study in which you are able to find the effect of cyclosporine on odontogenic tissue. So periodontal tissues studies I have available. So this is the study that is the best study available for this effect on the periodontal tissue. And you can see the unwanted side effect of the medicine is, you can see here the unwanted side effect of the medicine is gingival overgrowth. So this we people already know. This will cause gingival overgrowth and create somewhat different environment for the periodontal disease, right? It has an adverse effect on the alveolar bone homeostasis. So alveolar bone homeostasis get disturbed. This will increase the osteoclasia and decrease in the bone formation. So odontogenic tissue get affected because of all these reasons. So this was the only relevant study I'm able to find out, which is directly related to this MCQ. So let's move on to the question number 2. Now question number 2, I'm not able to accumulate this the all 4 options. So what are the 4 options for this tissue? Can you please let me know? Immunosuppressants decreases, Dr. Ritu is asking, immunosuppressants decreases the fibroblast activity and therefore reduce the healing. Yes, doctor, but actually this is a cyclosporin, and cyclosporin actually result in, you must be knowing, gum hypertrophy. Cyclosporin actually is a drug that will cause gum hypertrophy. So this will result in fibroblast accumulation, right? So there are 2 mechanisms you can say, Dr. Ritu. On one side, we can say that immunosuppressants are the drugs which can increase the level of TGF beta. So there is a chemical compound TGF beta. So because of this TGF beta, they can rupture the basement membrane. So they can rupture the basement membrane, and hence they will help in the metastasis of the cancer and also help in the spreading of the infection. So they can prevent the wound healing. But on the other side, we can say cyclosporin is a drug that can enhance the fibroblast deposition. So in case this drug is any other drug, like not the cyclosporin, then this point will be more applicable. But rather, this medicine can enhance the fibroblast accumulation and can result in gum hypertrophy as one of the side effects. So I would say, like, reason can be this also, whatever you are mentioning. So multiple reasons can be there, but ultimately this medicine can delay wound healing because of that mechanism as well. Okay, guys. So can you please help me out in finding the other 2 options of C and D? So here the question number 2 is based on what is the difference in the mechanism of action? So what is the difference in the mechanism of action of denosumab induced osteonecrosis of jaw as compared to that caused by the bisphosphonate? So what is the difference between 2? So can you please help me out to find out the other options? So both bisphosphonate and denosumab, these medicines are inhibitor of osteoclast activity. So both medicines are inhibitor of osteoclast action. And by inhibiting the osteoclast action, when these medicines are given for a long time, they can disturb the bone homeostasis. They can disturb the bone histology. They can disturb the bone homeostasis by inhibiting the osteoclast action. So by disturbing the bone histology, these medicines can affect the bone growth and patient can have the side effect like osteonecrosis. So this point we have discussed during our lecture also. Now, can you please help me out in finding the other options? So let me tell you, bisphosphonates are the medicines. These medicines will become the part of the bone. Like this is the bone. So these medicines become the part of the bone. And whenever the osteoclast will come, this will start the resorption of bone. So osteoclast will start the resorption of bone. And now this medicine will enter in the osteoclast. So this medicine become the part of the bone, inhibit the osteoclast by taking the entry inside the osteoclast. But if we talk about the medicine like denosumab, so denosumab is a drug. This medicine is inhibitor of a protein. We call it a rank ligand protein. So this medicine is inhibitor of a rank ligand protein. And by inhibiting this rank ligand protein, this will not allow the osteoclast. This will not allow the osteoclast to come into the bone tissue itself. This will stop the osteoclast activation. This will stop the osteoclast migration or osteoclast attraction towards the bones. So osteoclast migration is inhibited towards the bones. Osteoclast activation is inhibited. This is a rank ligand inhibitor. So this medicine denosumab is no doubt a medicine that will inhibit the rank ligand. This will inhibit the rank ligand, and by inhibiting the rank ligand, this will stop the osteoclast to get activated, and hence this medicine can disturb the bone histology when given for a long time. Basically, you must be knowing, like in bones, we have our bone remodeling. The bone remodeling may we require both components. We require the activity of both osteoblast, osteoclast taking place together. So both osteoclast should take place, the activity should take place together. Then only we can maintain the proper growth of the bone. So if we are inhibiting the one cell, if we are inhibiting the osteoclast and we are allowing the osteoblast to act for a longer time, what will happen? Ultimately, the bone histology get disturbed and this will start causing problems in the bones and this will ultimately cause the bone fractures. So femur fracture is seen. So that is not relevant for you people. The second is the osteoporosis of jaw. That is very much relevant for you people. So I just want to check the options. Something related to enhancing the osteoblast was given an option. So there is an option of osteoblast enhancement. So osteoblast enhancement was a one option according to you. By causing the direct necrosis of bone was one option. So there was an option of causing the direct necrosis to the bone. So direct necrosis to the bone is obviously the wrong statement. So one option is direct necrosis to the bone. So direct necrosis of bone is one of the option. Second option, there is a direct osteoblast enhancement. This is also wrong option. Third is osteoclast ka suppression. Now I'm just confused, like what was the second option? So according to Aprajita, there were two options. One was with rank ligand and OPG affected indirectly. And one option was direct inhibition of rank ligand. That's why I marked the second one. Okay, so there was a one option, direct effect on rank and rank ligand. Okay, according to Aprajita, there is an option in which they have given you there is an indirect inhibition. There is an indirect inhibition of rank ligand, and OPG. So according to you, this is one more option. So there was a one option, indirect inhibition, and there is a option of a direct inhibition. There is an option of direct inhibition of rank and rank ligand. Right? So if there is an option of rank ligand, so no problem, guys, this is a direct inhibitor. So this medicine is a direct inhibitor of rank ligand. So this was the answer. One option was it incorporates ATP and causes the death of the cell. Okay. So according to you, one option is it can incorporate. It can incorporate into ATP. What is bache ATP? What is ATP? You want to say osteoclast? It is incorporated into osteoclast or ATP. Like you wanted to write something else, Dr. Suman. So in case there is a word, I think ATP, some ATP क्या होगा फिर यहाँ पे? And causes the death of the cell. So this was the one option according to you. So incorporate into what? So what is this ATP? So there is a like calcium hydroxyapatite crystals. You want to say calcium hydroxyapatite. You wanted to write osteoid because in bones we have a osteoid present over there. So these are the names of different types of bone tissues in which the bisphosphonates get incorporated. So bisphosphonates get incorporated in calcium hydroxyapatite crystal. This get incorporated in osteoid, and by incorporating in osteoid, this will inhibit the bone cells. So this may be one of the option. So anyways, guys, so like whatever were the other options. So I'm trying to find out the various options, but I'm not able to get the proper answer from your side. But it's fine, no problem. You just keep on thinking and keep on recalling in case if possible to recall all the options, just send it to us. And according to me, the best answer is this one, the direct effect on rank ligand. So medicine is a direct inhibitor of these. So these were the 6 options I have written. These may be in the exam. So in case you are able to find a better answer, better and the more appropriate option that was asked in the exam, just let me know for that. Okay, guys. That's all from my side. So overall paper was moderate to difficult. And in pharma, less number of questions are asked. So paper was not justified according to me, just asked from a part of the faculty. But if you see the questions asked from dental subjects, it's going to be, these questions were more. So it's always good that you people get questions more from the dental subjects instead of the medical subjects. But still, guys, I wish you all the best for your results. I hope you people have done well in your exam, and my best wishes are for you. And once you get selected, do inform us and be with us, and we'll have the party. Okay, guys, take care of yourself. Now, I think the next faculty is ready. Dr. Pawan is ready with his questions. Bye bye, guys. Take care.
Hello. Hi, guys. Thank you, Dr. Saurabh, for the wonderful recall of pharmacology. Now, let's start. I'll just check whether I'm audible to you guys properly. If everything is okay, then we'll start and we'll proceed with the recall of the surgery. Thank you, Dr. Saurabh, for wonderful recall. Okay. Right. Perfect. Yeah, right. I am audible to you guys. So let's start. So in surgery, whatever the students have told me, that there were like around 6 MCQs. Um, Questions were not based on the topics like thyroid or hardcore trauma or something like that. The paper was more like more related to the basic surgical principles, what you guys might use in your day-to-day practice. So in that way, it was a kind of a paper which kind of checked your basic surgical skills rather than your theoretical knowledge of the surgery. So yeah, like without wasting any further time, let's kind of start and let's talk about the 6 questions which were there. Okay, so the first question which I got was a 65-year-old male was there with a long-term history of the tobacco chewing present with the lesion shown in the image. Based on the history, the clinical findings, what is the next step to be done? Okay, so whenever you have any particular ulcer, okay, whenever you have any particular ulcer, okay, always what you need to suspect is whether it is benign or malignant. Okay, whether it is benign or whether it is malignant. And only way to know, like whether it is benign or whether it is malignant or something like that, the only like a good way to kind of know this or get to the bottom of this is by doing a biopsy. So also over here was an incisional biopsy. You have to kind of do an incisional biopsy. CCT of the face to and observe for 6 weeks. No, you will not do that. I mean, CCT of the face will be used if at all the ulcer has already invaded into the surrounding structures. That in that case, that it's a very, very later part. That's when you're going to do that. Okay, topical application of fluconazole and like all those particular things you will not do. Okay, so you will not just blindly treat it like any particular benign condition or a pre-malignant condition. First, you get to know the diagnosis. So definitely no doubt about it. It was an incisional biopsy. Like that's what you're going to do over here. Okay, so no doubt like that is what you need to understand over here. Okay, so what you're going to do is an incisional biopsy. That is the first step to be done whenever you encounter any particular ulcer. Okay, so we had covered this in our kind of notes as well. Investigation of choices, a wedge or an edge biopsy. That is what you need to do whenever you are having any particular oral ulcer. What you basically need to do is a wedge or an edge biopsy. That is what you need to do. Okay, so indication is ulceroproliferative lesion for more than 3 weeks. Okay, and mainly it is in the painless ulcer. Okay, painless ulcer because painful ulcers are your after ulcers. Okay, so that is again a distinguishing feature whether it is a benign or malignant. Now, next question which I have got is very much similar to this, like the concept is similar. So let's kind of talk about this as well. A young healthy male with the family history of the oral squamous cell carcinoma. So there is a family history of an oral squamous cell carcinoma, which probably was given as a distractor. Okay, so this was used as a distractor. Okay, now the patient's present with an ulcer on the buccal mucosa since 1 week. Okay, so can you please write in the comment box whether 1 week duration was given, yes or no? Okay, did they give you the duration of 1 week? Just write it in the comment box. Okay, which is non-indurated on palpation. Now, this is a giveaway. Okay, so what they're trying to give you that there is an ulcer which is non-indurated. Okay, so this is relevant. We will talk about this. Okay, then the site of the lesion is exactly at the occlusal level where the maxillary third molar is impinging on the cheek. What is the initial step in this particular management? Okay, so what you need to understand is that they've also given you a molar which is irritating that particular part, which probably has led to the development of an ulcer. So this again tells you that okay, it is a benign cause. Okay, and especially this, like a non-indurated lesion, that basically gives you a benign cause, and also the duration was 1 week, which is again pointing towards an acute onset of that particular ulcer. Okay, so refer to an oncologist. No, you will not do that. Extraction of the tooth and observe for resolution. That is what is the answer over here. Excisional biopsy of the ulcer, not at this point of time. If at all, let's say you wait for a couple of more weeks and the ulcer doesn't get resolved, then probably you will go ahead with a biopsy. At this point of time, no. And even in the biopsy, what you're going to do is you are going to do an edge biopsy or a wedge biopsy. Okay, what you're going to do, edge biopsy or a wedge biopsy. That is what you're going to do in this particular kind of a question. Now, observation and regular follow-up, no. Okay, so you will not just observe, because it is very clearly stating that the third molar is impinging on that particular cheek, and that is the point where the ulcer has happened. So you will have to take out that particular tooth, because it is kind of causing a trauma to that particular cheek, which has led to the development of an ulcer. Okay, now why did I say that non-indurated? Because what you need to understand is that any ulcerative lesion, when there is a squamous cell carcinoma into consideration, okay, it will have everted edges, but more importantly, it is going to have an indurated base. So I have covered this at least 10 to 15 times, that any squamous cell carcinoma ulcer, okay, it will have everted edge, no doubt, but everted edge with an indurated base, that is something which is pathognomic for your squamous cell carcinoma. And like indirectly, you can also correlate that you will have to wait at least for 3 weeks to do a biopsy. That also tells you that, you know what you're going to do is extraction of the tooth and observe for resolution, because the duration was given as only 1 week. Okay, so these were the two questions which were somehow trying to check that oral ulcer, like how are you going to manage this? Now, if you look at this, it is very, very relevant for you guys. Okay, so now you are like the like you are the dentist, and whenever the person comes to you with an ulcer, you should not blindly refer every oral ulcer to an oncologist or something like that. I understand my point. You need to understand like whether it is a benign, whether it is malignant. You can always do a wedge biopsy if it all is indicated. And once the diagnosis of the cancer is made, then maybe you can refer those particular patients to an oncosurgeon or something like that. I hope you are able to understand. That is the reason why you need to understand. There was no option of observation and follow-up. Okay, if at all there was no, okay, what was the option then? What was this particular option? Like the fourth option? Okay, so it doesn't matter what the option was. The answer over here is extraction of the tooth and observation and observe for resolution. That is what is the answer over here. Okay, I hope you got this particular point. You can write down whatever the fourth option was there. If at all you have that, just write it down. That will help. Perfect. Now, this was a kind of a question where you had to use your logic. Okay, so let's kind of look at this. And also, I will need your help in kind of recalling the options in a proper manner. Okay, so the question was that there is an irregular asymmetric laceration of the face with unequal length of the tissue thickness. Okay. Okay, right. Now I'll just go back. Somebody's trying to say that, biopsy from the central lesion. That is never ever the answer. Okay, so what you need to understand is that if at all you have particular ulcer, the lesion which is in the center, it tends to be necrotic. So that is a basic fundamental principle, that whenever you want to take a biopsy, you do not take it from the center of that particular lesion. You always have to take an edge biopsy or a wedge biopsy, so that you cover the normal skin as well as that part of the ulcer. Okay, but again, this is not a point where you are going to take a biopsy. Here you will have to remove that particular tooth and observe whether the resolution is happening or not. If at all the resolution doesn't happen, then it will come to a point where you will need to take a biopsy. Okay, but this is a very, very important concept which all of you should remember, that whenever you have an ulcer, never take a biopsy from the center of that particular ulcer, because it will show a necrotic tissue. Okay, now this is the question which we were trying to talk to you about. Irregular asymmetric laceration of the face, unequal length, tissue thickness, blah, 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 can never be closed aesthetically. No, never say never. I mean, obviously you can close it aesthetically. Obviously, you will not be able to make it like exact normal skin, but as far as the aesthetic appearance is kind of there, yes, you can kind of close that. That's fine. So that is the wrong kind of an option. Should be closed with needle bites taken from thin to the thick tissue. Okay, why? Why this is wrong? So what you need to understand is that let's assume that this is a lacerated wound with irregular edges, and even the thickness is kind of bad. Okay, now let's assume that this is a thin flap and this is a thick flap. If at all you take a bite first from the thin flap, now you're taking it from the thick flap. So now what is happening is that the thin flap is stretching. And if at all it stretches, there is a risk of what you call as there is a cut through. The sutures can get cut through, which you don't want. Okay, so always you take a bite from the thick portion first, and then you kind of take it from the thinner portion. That is again the basics of the principles of your suturing. So you take a bite first from the thick kind of flap or the skin, thick area, and then you take a bite from the thin area so that the cut through of the suturing is reduced. Now, should be left for a long time before suture removal to allow better healing. So once you have taken the stitches, suture kept for a long period of time is not the answer. See, in the face, blood supply is not a problem. Okay, so if at all the blood supply is not a problem, the healing will occur timely. So especially in the face, you have to kind of remove the sutures timely, because if you keep it for a prolonged period of time, it will leave the suture marks. So if you do this, what is going to happen? Suture marks will be left behind, So this is also not the answer. So I would say that this, obviously we have not covered this particular point, this particular question at any point directly. Okay, but indirectly we have talked about these things at one point or the other. So what you need to understand is that this was a type of a question which you solve by eliminating the options. So once you have eliminated option number this option, and this option, ultimately you come to a conclusion that, you know what, option number C is the answer. Okay, now why I'm trying to say the option number C is the answer? Okay, so what I've got, and you will need to help me with the proper framing of this particular option, should be closed with an unequal bites of the tissues and suturing technique. Okay, so what was the suturing technique which was given? Somebody was trying to tell me that one particular technique was written, but they were not able to recall it. And even I was not able to figure out what kind of suturing technique are they talking about. Okay, now people are trying to say for the previous question that so it was the second molar, not the third. It doesn't matter. Whatever the tooth was there, we just remove it. And somebody's trying to say that, you know what, if you remove the tooth, the cancer, and if it was cancer, it will kind of progress. First of all, the findings which they have given, they are pointing towards benign, non-indurated base, acute onset, all those particular stuff. I specifically asked them about the pain, but the pain was not mentioned in the question. But removal of the tooth will not kind of lead to the increase in the size of that particular cancer. If you remove the tooth, obviously you're going to observe in, let's say, 1 to 2 weeks, if at all the ulcer remains the same or rather progresses, you will definitely take a biopsy and then you will manage it like any other cancer. Okay, so yeah, that's what you need to understand. Now, can you help me with this? Cushioned or ribbon suture, something like that. Okay. Please give your inputs. You can mail us or whatever this particular option number 3 was there. But by ruling out the other 3 options, you come to the conclusion that the answer is option number this C. Okay, so obviously here it isn't in D, but yeah, like the one which I'm highlighting, that is what is the answer. So what the concept is, if at all you have a ragged margins, okay, so margins are uneven. So now what you're going to do, if at all, let's say you will take unequal bites. Okay, so you will take unequal bites so that you're able to approximate those particular sutures in a proper manner. So you will take in unequal bites. If at all it's very deep, you will take a shorter bite and all those particular stuff. So that is what you're going to do. Okay, so should be closed within unequal bites. Whatever the framing was there of this particular option, that is what is the answer. And you can very well reach this by eliminating the other 3 options. I hope you got that particular point, guys. Okay. Ruffy's suture was there. Ruffy's. Okay, so it is like a Ruffy suture. Okay, so it basically, okay, I'll obviously research a bit more about this particular term, but the first thought which comes to me when you're trying to say the Ruffy suture is like, let's say if at all you're any particular cloth piece or your pant or jeans or something like that gets torn, obviously it is going to be a half of that tone. So what happens is they do ruffle. Okay, so to ruffle, I think it is something related to that. And in some book, they would have used the term as rough feed switcher, and that's why they have kind of used that probably. Okay, but yes, I'll definitely kind of look into it a bit more, and I'll come back to you. At least 2 or 3 people are trying to say that, you know what, rough feed switcher was there. So probably that was one of the option, and that was the one which was a correct option. Unequal bites with the rough feed technique.
The ruffled suture was there. I was trying to think of this word yesterday also. Ruffled
Okay.
suture technique was the word in that
Ruffled
unequal
suture.
bite.
Okay.
Ruffled suture.
Yeah,
I'll
they
try to
have
find
put
it.
it in
but
the comment box, ma'am.
something very
Right.
Yes, sir. So ये अभी Soloni June ने डाला है. Then I am recalling that it was ruffled suture technique.
Ruffled
Which
suture.
is right.
Okay.
Yes, sir.
Right. Let's go to the next question. Okay. Right. The next question was there. This was pretty straightforward. A large contaminated wound is kind of cleaned, surgically debrided on the left and left open to granulate for closure later. So the crux of this particular question comes down to closure later on. So we have talked about this a number of times that, you know what, if at all, let's say there is any particular wound which you kind of cut open, and like you don't take the sutures then and there, you leave it open for, let's say, 24 48 hours or something like that. And once that particular infection has gone, some granulation ratio has come, now you bring those particular edges close to each other and take a suture. That is what is called as a healing by the tertiary intention. Okay, so if at all the framing of question was like that, that you have debrided the wound and everything, and the wound was left open to granulate for closure later, ultimately you are closing that particular wound. That is what is healing by tertiary intention, or it is also called as a delayed primary closure. Okay, so did you have that, guys? Did you have that what do you call as for the closure later? If at all this term was used, definitely the answer is healing by the tertiary intention or a delayed primary closure. That is what is the answer. Okay, perfect. Right. So we have covered this obviously a number of times. So pretty straightforward question: healing by the primary intention, healing by the secondary intention, healing by the tertiary intention. Here, you leave the wound open and ultimately you apply the sutures, let's say after 24 to 48 hours or 72 hours, whatever. The main reason why you want to wait is in order to reduce the surgical site infection, but it can be done for this as well. Once the granulation tissue has come, now you are kind of closing that particular suture. That's also okay. Okay, so whatever the framing of the question I have got, as per this, the answer is definitely healing by the tertiary intention. Any changes in the framing of the question, you can please let us know in the comment box. That will be helpful. Okay. Perfect. Now, one of the, like, again, a very, very practically oriented question. Tracheostomy is planned for a patient, which is seen in the image below. Which of the following tracheal rings will be incised? Okay, so I don't have the, like any particular, like we did not put it in the notes or somewhere like that, but whenever we teach, we always tell that, you know what, you cut the trachea at the T2, T3, T4. It is something which we have read for a long period of time in clinical based anatomy, in anesthesia, and in surgery. Everywhere you kind of read that in a normal tracheostomy, whenever there is a conventional tracheostomy, what tracheal rings do you cut? You cut tracheal rings 2, 3, and 4. And that's what they were trying to ask. Okay, right. So in the traditional tracheostomy, what you basically do is you put an incision on the tracheal rings 2, 3, and 4. If you go above this, that is what is called as a high tracheostomy. Okay. Now, the last question which we had was that in a patient with the maxillofacial trauma, which of these is the safest way to provide an open airway? Head tilt and chin lift, Heimlich maneuver, jaw thrust, and head tilt and neck tilt. So head tilt and neck tilt, there's nothing like that. You don't kind of do that. Head tilt and chin tilt. Okay, that is kind of not kind of true. First of all, it is head lift and chin tilt. So like head tilt and chin lift. It is chin lift. So obviously that's not going to be there. So here there is a jaw thrust. The answer over here is the jaw thrust. So here in the severe maxillofacial trauma, what you need to understand is that the chin might be kind of broken. So you apply the pressure over here, you basically perform the jaw thrust. So we talk about this again, not directly, but what we basically have told you that, you know what, in order to maintain the airways, what you need to do is you need to do a jaw thrust and a chin lift. That is what you need to do. In a severe maxillofacial trauma, you will not be able to do this chin lift. So what you end up doing is just the jaw thrust. That is what you need to kind of do. Okay, so what you need to do is a jaw thrust. So these were the 7 questions, like 6 questions which were asked in the general surgery. My first take on this particular type of questions was that, you know what, the hardcore topics, for example, peripheral vascular diseases, aortic aneurysms, what you call as a thyroid, all those particular things were not that covered, but it was okay because they were trying to check the basic surgical skills for you guys. And I guess it was a more practical oriented question. Definitely there were 2 to 3 questions which were out of the mainstream line, but by having the knowledge of the basic surgical skills and by ruling out the options, you could have kind of reached to the correct answer. So that's all from my end. If any kind of changes in the framing of the question or the options were there, please help us by putting it in the comment box either, or maybe mailing us to us so that we can make the changes and improve the recall a bit more better. That's all. I will hand over the stage to Mani ma'am and she'll take it from here.
Thank you, sir. Thank you so much. Good afternoon, everybody. I hope till now you've seen the recall and the questions that you have seen. You're getting some correct. There may be some which are wrong. Don't worry about them. Whatever it was over. And questions, most of them in oral surgery also, they looked similar. They looked key. You have read them somewhere. You have seen them somewhere. But the options were tricky. Yes, there were some mistakes in endo, in oral surgery. And one by one, let us look at all the questions. Before we begin with the exact questions, let me just give you a spread out of what was the distribution of questions in the oral surgery paper yesterday. So, as expected, we know that AIMS is going to ask orthognathic surgery, AIMS is going to ask TMJ, AIMS is going to ask trauma. And this is what we had said before also, that please expect these questions to be there. So, in orthognathic surgery, there were 4 questions. From temporomandibular joint, there were 2 questions. 8 questions from trauma. Surprisingly, NEET gave us 0 questions from trauma, which has never happened before. But AIMS has obviously continued with the trend of asking trauma properly. 2 questions were there from exodontia. And medical history. From the medical history part, which we cover under local anesthesia, there were 2 questions. 1 question was there from infections, from the chapter of infections, severity of infections, and 1 question from the miscellaneous section, that is the obstructive sleep apnea. Okay, so this was the distribution, and altogether there were around 21 questions from oral surgery. Let us look at them one by one and look at the answers. So arrange the steps of Leafoot 1 orthognathic surgery in the correct sequence. This is direct pick from our notes. Let me show you the sequence first, and then we'll correct the answer. So first of all, for any surgery, the first thing, and see, even if you have not read this, okay, even if you have not kind of known the exact steps, the options are such that you can use your logic and you can use some understanding of the language. If you have the basic knowledge of surgery, you will know that whenever we do any surgery, the first thing we will do is incision, right? So the first option is vestibular incision and subperiosteal reflection of flap. So one has to be the first step. Okay. After that, you may be confused which osteotomy you have to do first. So always remember that first we do the front osteotomy, right? The maxillary anterior wall and the lateral nasal osteotomy, which is 3. After we have done that, in the end, we will go to the pterygoid regions and we will do the pterygomaxillary disjunction. So that is the next step. And in the end, when we have done all the osteotomies, either with a burr or a piezoelectric, then we use our thumb pressure and down fracture the whole maxilla with our thumb pressure. If some place we are not able to fracture it, that means there the osteotomy is not completed. We have to take the burr or piezo again to complete the osteotomy, right? So vomerine osteotomy, lateral nasal, maxillary, and last may pterygoid. And then last may the 4th step is to down fracture the maxilla and mobilize it whether you want to take it anterior, posterior, superior, inferior, wherever, whichever direction you want to take it. Okay, so the correct sequence is 1, 3, 2, 4, which is option C. Okay, let us quickly see how we have taken this question. Is there exactly like it should be in the notes. So we have given you the steps of leaf foot one surgery also, right? We've said that it is the work of maxillary orthognathic surgery, intraoral incision from left first molar to the right first molar region. It's an intraoral vestibular incision from molar to molar. When we put that incision, one additional fact I have given you, that we leave a cuff of 2 to 3 mm. Purposefully, we leave that free gingiva so that when you're suturing that incision, you should have some free gingiva so that you are able to suture it properly. Okay, all the osteotomies are also marked in the image given here. Okay, after that, the surgeries are performed: anterior maxillary osteotomy, followed by lateral nasal osteotomy, followed by high leaf foot one zygoma if you have to do, and last, as the notes say, pterico-maxillary disjunction. Very clearly, exact lines are there in our notes. Okay, then which chisels you use, we have discussed about the different chisels that we use: lateral nasal chisel, then septal chisel, then for the pterygoid we use the pterygoid chisel, which is a curved chisel, right? And last maxilla is after all these steps, then we use the thumb pressure to disjunction the whole maxilla, and then we use the fixation with 4 plates and fix it with 4 plates as given here, right? So absolutely, if you have read the notes properly, I'm sure you would have marked this correct answer correctly. I hope everything is correct and you guys have marked it correctly. I will see all the messages that you're sending here in some while. Okay, which of these is the most common cause of post-surgical instability or relapse after leaf foot one surgery? Now, this question might sound a little new, but it is again from that table of stability of maxillary surgery, which has been repeated almost every year. We have seen this question, which has come again and again and again every year. And we have seen also, it is straightforward from the notes, that most stable surgeries and least stable surgeries, right? In least stable surgeries, maxillary widening is the least stable, followed by maxillary down movement. Very clearly written in the notes. Very clearly it is there: mandible down, maxilla down, and mandible wide. Okay. So this is a direct pick. I know most of you have done it correctly, right? So if you look at the options, there is no option of widening. There is no option of maxillary widening. If this would have been in the options, then this would have been the first choice of answer. Okay. But in this exam, the options, there was no option of maxillary widening. What were the options? Maxillary impaction, that is upward movement, very, very stable. Maxillary advancement, another one of the stable surgeries. Counterclockwise rotation of maxillomandibular complex. So whenever we do a bijaw surgery, whenever we do a surgery of both maxilla and mandible, it is better for the stability, because if I do maxilla only and move the maxilla by 10 mm, right? Versus if I do maxilla and mandible both, move the maxilla by say 6 mm and mandible by 4 mm. If I distribute the discrepancy between the maxilla and mandible, it will always give me a better stability of surgery, because एक ही जॉ पे सारा movement का impact नहीं आएगा. The impact of movement will be distributed among both the jaws. So bijaw surgeries are anyways more stable than single jaw surgeries. Okay, and there are 2 kinds of rotations. There is a clockwise rotation where the maxilla goes down. There is a counterclockwise rotation where the maxilla goes up. Again, when the maxilla is going up, the stability is better. So this is also a stable surgery. Maxilla down fracture with bone grafting, right? So those who have attended the live classes, you know, we have told you very clearly that whenever there is a gap between the segments in orthognathic surgery, the gap surgery is always an unstable surgery, right? So when you do a maxillary down fracture, there is a gap, right? Then you have to put bone graft there. Whatever you do, whenever there creates a gap between the segments, that surgery is unstable. So the most unstable surgery among the options here is maxillary down fracture along with bone grafting. Yes, SSJ4144, you are absolutely correct. Okay, coming to the third question. Now this again is tricky, but if you have read the oral surgery notes properly, I am sure you would have marked this correctly. Okay. Which of these can be a major risk factor in increasing the chances of an unfavorable or a bad split during the bilateral sagittal split osteotomy of the mandible? Now, first question is impacted third molar not extracted earlier. Imagine this is the mandible and I have to do a surgical cut like this. Okay, I have to do a cut like this. If I take the saw, if I do the cut in a bone, in an intact bone, the cut will be neat. But if there is a third molar lying there like this, obviously I have to remove that third molar. That third molar removal will create a defect. And when I try to split my bone after removing the third molar, the chances of that split going bad are very high. All right. So third molar not extracted earlier, definitely it is one of the causes of bad split. Improper inferior buccal osteotomy. Now, this was there twice. In two questions, this option, this bad split was there. Okay. First question, only one most common cause was asked. We will discuss that question next. Most common cause was asked, and this is the most common cause. When you don't do this inferior osteotomy properly, that is the most common cause of bad split in most cases, right? So that was asked in question number 4. In question number 3, all the other causes are also asked. So they've converted that same question into a multiple correct answer question and asked twice. Okay, so what are the other causes? So 1 is a cause, 2 is a cause. Incomplete mesial osteotomy. See, whenever you are trying to, kind of do the osteotomy and split the, if your osteotomy is not complete, your split can go bad, right? We have discussed this in the class also. So this is also definitely a cause of split going bad. The fourth option, use of positional screw instead of mini plates and monocortical screw of fixation. Now this option is talking about fixation. This option is talking about fixation. And how to fix is a concern during fixation. Why do we have to think about fixation during splitting? राइट वो तो अगर बैट स्प्लिट हो गया तो फिर आप मिनी प्लेट लगा के उसको कुछ करके संभालोगे, राइट? बट दैट इज नॉट अ कॉज ऑफ बैट स्प्लिट, right? So the causes of bad split are option number 1, 2 and 3, and that is the correct answer. Okay, now I am just putting a screenshot of our notes where very clearly exactly all the causes are mentioned. Complications in mandibular orthognathic surgery. The first complication that we have discussed is the bad split. That means fracture in the body of the mandible when you are doing a BSSO. First, it can be prevented by third molar extraction 6 months before surgery. So if you remove the third molar before surgery, that site will heal properly. It will be one intact bone and chances of bad splits reduce. Second, Epker modification. What is Epker modification? Inferior buccal osteotomy should be completed. This asked twice in the exam, right? So inferior buccal osteotomy should be completed properly. That prevents bad splits. Third, complete all osteotomies before splitting. So medial osteotomy, buccal vertical osteotomy, and sagittal osteotomy. 3 osteotomies, 3 cuts we put. After we put 3 cuts, we kind of connect these 3 cuts by a split. So until and unless you complete all your osteotomies before splitting, you can have a bad split, right? If it happens, what is the management? Management is similar to any fracture. You fix it with plates, right? So again, those who have read the notes properly, I'm hoping that you might have answered this question correctly. The correct answer is option 1, 2 and 3. Okay, just give me some good news. If you have marked it correctly, I will be very happy to read that in the YouTube chat. Some of you can tell me if you have marked it correctly. It will give me some good feeling also. Okay, the next question again, like I said, similarly, which of these is the most common cause of bad split in BSSO? All the options were wrong. Somehow I'm not being able to recall these options. Anybody who recalls the options, please help us in completing the options. Improper inferior buccal osteotomy is the correct answer here also. All the other options were definitely wrong. This happens. Students tend to remember the correct answer. They don't tend to usually remember the wrong options, but very sure the other options were wrong. And one of the options were using a piezoelectric instead of burr. This will not increase the chances of bad split. Okay, piezoelectric is also cutting, burr is also cutting. The only advantage is piezoelectric will not injure the soft tissues. Burr can injure the soft tissue. So that is the only difference. Bad spread can happen with both if you do an incomplete inferior buccal cortical osteotomy. Yes. So Saloni June has marked it correctly. Prakash, I'm very happy you've marked it correctly. Okay, very good, Divya. So very good. I am happy that some of you have done it correctly. Very good. So what are the other two options? If you guys remember, please send it to us in the chats or in the Telegram group later on, and help us complete the options. Okay, so the correct answer is improper buccal cortical osteotomy. Again from the notes. Okay, next one. I'm sure all of you have done it correctly. Which of these is the single most common cause of ankylosis of the temporomandibular joint? Without even reading the options, you can mark it trauma. Obviously, you should not do it. Of course, you should read all the options, but correct answer is trauma. Whatever is the other causes, these are just 2, 3, 4, 5% chances of ankylosis happening from any other cause. The 99% chances are trauma. There has to be a history of trauma. Okay, so again, directly from the notes, causes of TMJ ankylosis. First, trauma most common. So straightforward from the notes. Okay. Next question. Now this was tricky. This question was tricky because it has actually brought to you to a point where your clinical judgment is used. Okay, your clinical judgment will be used to answer this question. Still, I'm sure some of you must have marked it correctly. Which of these is the correct indication for surgical repositioning of the articular disc of TMJ? Okay, now Wilkie stages are given. Painful anterior disc displacement with reduction. Okay, it is with reduction, not correcting with conservative measures. So here in this option, the examiner is trying to highlight 2 points. Painful, not correcting with conservative measures, or not correcting with the routine splint therapy or arthrocentesis, hot fomentation, massage, and everything. So it is not correcting with it. So these are the two keywords in the exam. See, painful, so it is Wilkie's 2, and not correcting with conservative measures. Let's look at the other option. Disc displacement without reduction, causing pain, reduced mouth opening, and not amenable to minimally invasive treatments. Again, here the keywords are again same. It is symptomatic. Patient is having pain. Patient is having decreased function. And we have tried the minimally invasive treatments also. You have tried all the other things. It is not working. Okay. Let us look at the third option. Asymptomatic reciprocal clicking. So the option is clearly saying that it is asymptomatic. There are no symptoms, right? I have given this example in the class also. I have told you that, sometimes when we do this with our thumb, we get this sound, right? So there is sound from the joints, right? Does it mean it requires a treatment? No. So the world is still divided. There are two schools of thoughts and they are still divided whether just clicking of the TM joint, whether it should be even considered as a disease or not, right? So just a click, just a reciprocal or an opening click, if it is there and the patient is asymptomatic, we can't even say whether it is disease. So that is why it is placed under Wilkie stage 1. Okay. Painless. Asymptomatic means painless. So definitely this is ruled out. When there is no symptom, why do you have to do the surgery, right? Especially an open surgery where you have to open and bring the disc back. So definitely we will not do. Fourth option, again, this was a little smart option. It said acute closed lock, less than 48 hours, and doing the surgery as the primary management. Definitely, if it is a closed lock for less than 48 hours, it can be because of anything. It can be most commonly due to muscle spasm. It can be just a muscle spasm, and this question has been there. This muscle spasm question has been there in the previous INI PYQs, right? We have seen that muscle spasm will cause an acute closed lock, and it will slowly over 1 week, 2 weeks, 3 weeks, it will resolve on its own. You don't need any treatment, right? All you can do is diagnostically, you can put some local anesthetic block in the lateral pterygoid if you know how to do it, and that will confirm your diagnosis. Okay, muscle spasm की वजह से acute closed lock हो गया है. ठीक है? So again, it's an acute case. So acute cases में तो वैसे भी आप surgery नहीं करोगे, will not operate in acute cases, right? And the duration of this problem is only 48 hours, less than 48 hours. So why would you operate in something which has just been there for 2 days? Slowly give it some time to resolve. Maybe it is because of muscle spasm. It doesn't require any treatment. सर्जरी तो बहुत बड़ी चीज हो गई, किसी भी ट्रीटमेंट की जरूरत नहीं है, just some symptomatic painkiller and muscle relaxant and fomentation is all you need, right? So the correct answer to this question is option 1 and 2, because these are painful, because these are symptomatic, and because these are not resolving with the routine conservative treatments. So we will consider A and B, or sorry, 1 and 2 as the indications for surgical repositioning. Okay, now here again, let me tell you the practical facts also. The world is divided. Some of the people, some of the surgeon school of thoughts feel that, when it is stage 2, why do you need to operate? Some school of thought say that no, it is symptomatic. Patient is in pain. Patient is not able to function. What is affected is the quality of life. Quality of life. So any problem or any diagnosis which is affecting the quality of life, and it is not getting treated by minimally invasive methods like splint therapy, arthrocentesis, hot fermentation, NSAIDs, and all of that, right? So 1 and 2 should be the best answer, what I feel. Okay, this is the correct answer. So in the notes, we have taught you about the stages, the Wilkie stages of internal derangement. We have also taught you how we do the invasive surgery. The invasive surgery, which is the disc repositioning surgery, which is recently done using a MyTech mini anchor. We take a small metallic sort of a gun pellet, and it has it has a hole in the backside. And through that hole, you can pass the suture thread, and that suture can hold on the disc and bring it back to the correct position from the anteriorly displaced position, right? So we have talked about MyTech mini anchor, how we do the surgery, and this very clinically oriented question. I don't know how many of us marked it correctly, but this is where we actually do the surgery. It is not resolving with other conservative measures. We proceed to surgery. Okay. Next question. So this completes orthognathic surgery and TMJ. Next, we begin with the 8 questions of trauma. A 28-year-old male underwent a road traffic accident with fracture of the body of mandible. Now, let me tell you, when I was working in the JPN Apex Trauma Center, which is the trauma center, level 1 trauma center with AIMS Hospital, for 4 years, this was very common. This is something very commonly seen in any big government hospital or even private hospitals, where you have a neuro ICU also, where you have all the specialists working together, working as a team. Okay, now this boy had a fracture, but he was in ICU for neurosurgical management. See, a lot of times patients who have maxillofacial fractures, so maxillofacial injuries are very commonly associated with head injuries and spine injuries, right? That is why the maxillofacial surgeon is somewhere between the neurosurgeon and the critical care surgeon or the neurosurgeon who's taking care of the spine. Okay, so a lot of times when you have facial injuries, you will suspect that this patient can have head injury or this patient can have a cervical spine injury, right? So a lot of times there are coexistent surgeries. So like this patient, he had a neurosurgical head injury. So he was in the ICU because that resolves slowly. It may take time. So he visits the maxillofacial OPD 2 months later. So for 2 months, he was in the ICU. What happened in these 2 months? Of course, with the neuro problem, he would have had a mandibular fracture. And in 2 months, the untreated mandibular fracture undergoes, what does it undergo? It undergoes malunion. See, the body has a tendency to heal, and this boy is just a 2-year-old young boy, right? So the fractures have a tendency to heal because obviously he is in the ICU, he must be intubated. The treatment for head problem is much bigger than the treatment for mandible. So obviously the surgeons will not care about treating the mandible at that point because that can be treated later on also, right? So what has happened in this boy is there is no pain because the fractures have united. There is no mobility because the fractures have united. But because they have malunited, so the fracture happened like this. Okay, and it took the fragment of mandible somewhere like this. So what was disturbed? The occlusion is disturbed. There is a step in the occlusion. There is open bite, right? So there will be open bite. There is inability to chew, but there is no pain. Why? Because there has been a healing, but that has been an abnormal position where it has healed. So such kind of fracture unions are known as malunions. Never ever a question has come in AIMS or NEET in malunion. Now we will start teaching you malunion also. It's first time malunion has been asked. Okay, so this is a malunited fracture. And how do you treat a malunited fracture? You fracture it again from the same place. You bring it back in the correct position and you fix it with plates. A malunited fracture, you will not do ORF because there is already a healed thing. So you will do a neat cut and you will bring the fractured part in the correct position and you will put plates. So the correct answer is osteotomy and ORIF. Osteotomy means you will cut the malunion, you will refracture it and you will fix it with open reduction. What is ORIF? Open reduction internal fixation. What is open reduction internal fixation? Plating, plates and screws, right? Can we do IMF for 4 weeks without osteotomy? The IMF will not work. Prosthetic crowns to level the. This will be a very aggressive treatment when you can just do it simply with just refracturing and correcting it. Occlusal adjustment of all remaining teeth. This is wrong. When you know the problem is that in the bone level, you correct the bone level. There is no problem at the teeth level. The teeth are going up and down because the bone has gone up and down, right? So you will correct the bony level instead of prosthetically or occlusally adjusting the occlusion. You will bring the bone to correct level, right? So this is a case of malunited fracture. The treatment for malunited fracture is refracturing, which is known as osteotomy, and plating ORF. Okay, so this is the correct answer to this question. Next question, it was a repeat PYQ from AIMS AIMS November 2017. Image below shows a fracture in a 65-year-old male. What would be the ideal treatment? We all know this is an edentulous fracture, which is atrophic fracture, showing a bucket handling on both sides. And whenever the quantity or quality of bone is compromised, we all know when the quantity, see here, the quantity of bone is compromised, the height of mandible is reduced because of atrophy. Quality of bone is compromised because this is a old, elderly 65-year-old patient. Obviously, the quality of bone will not be very good. So whenever the quantity or quality of bone is compromised, we always do a load-bearing fixation with reconstruction plate. It's a rule, okay? Even if you have not done the PYQs, if you have done our notes properly, exact image is there in the notes, exact words are there in the notes. Bucket handle fracture seen in edentulous patients. It's a bilateral body fracture seen in the first molar region, as you can see here in the image. Thinnest in the geriatric patients. Treatment is done with load-bearing plate, which is reconstruction plate, and rigid fixation. Okay, so I'm sure this is a PYQ also. This is there in the notes also, and you all have done it correctly. I'm hoping that. Yes, Madhu Verma, you are absolutely correct. Okay, next question. Okay, now this was new. As per Zink's classification of zygomatic complex fractures, which of these would be considered as type A or low velocity fracture? Now, never ever the Zink's classification has been asked. Okay, every bone in the body has multiple classifications of fracture. Okay, so zygoma also there are multiple classifications. Condyle, there are multiple classifications. The examiner has taken the advantage of this fact and they have asked about Zink's classification, which is not very commonly taught to in your BDS curriculum. So the correct answer to this question is 1 and 2. Okay, so D, whatever was the option. Let me tell you the Zink's classification once, or let me first tell you about the zygoma. See, now the zygoma is like a table. It is like a 4-leg table. Okay, there are 4 articulations or 4 joints that the zygoma. So this is our cheekbone. This is the zygoma. So there are 4 articulations that the zygoma will make. The first is this frontal bone, zygomatic bone. So this is known as the frontozygomatic articulation, the frontozygomatic suture. Then this is the temporal bone, which forms the zygomatic arch and temporal bone. So this suture is called the zygomatico-temporal suture or temporozygomatic suture, whichever way. Then it articulates with the maxilla here, and it is called zygomatico-maxillary suture, which is the most important suture to plate, because here if you put the plate, mostly the fracture becomes stable. Okay. Fourth one, you can see this is the infraorbital rim. The infraorbital rim is also a very good buttress, and zygoma also participates in the formation of infraorbital rim. So this infraorbital rim is the 4th place where you can put a plate, and which is kind of one of the articulations of the zygoma. And the fifth one is inside the orbit. If you can watch closely here, on the lateral wall of the orbit inside, this is the sphenozygomatic suture. So this is the place where the sphenoid bone articulates with the zygomatic. So basically this is the zygoma, and these are the articulations which the zygoma has. Okay. Now the classification of fracture, the Zing's classification of fracture is done depending on with how much velocity the trauma happened. If the trauma happened with low velocity, मतलब एक just छोटी मोटी कुछ ball लग गई है, little ball or a slap on the face, okay, what it will do, it will just fracture one or two things. It will just maybe fracture the arch, or maybe just fracture the FZ region, okay, maybe just fracture the rim and not displace it much. So without much displacement, it is just simple isolated fractures. If it is a moderate, so this was about low velocity. If it is a moderate velocity, what it will do, it will break all these four articulations. It will fracture the zygoma something like this. It will fracture the zygoma from all the articulations, from all the joints. What is articulation joint? So this is kind of this articulation of the whole maxilla, but this segment is still single. This big segment is still in one piece. So you can just put that big piece back in the correct position and put plates in all the four segments, something like this. So there is one segment which is disarticulated from all the four places, and you can put it back in the correct position. And third, level C, when there is a high velocity trauma. When there is a high velocity trauma, this piece is also not one piece, it is shattered into many pieces. All right. So this is the Zing's classification. The Zing's classification of ZMC. Why am I teaching you it in so much detail? Is because we don't usually teach it. So whenever you want to learn about it, you can go back to these videos and you can learn it. Zing's classification is type A, which is low velocity. Type A also has type A1, where there is zygomatic arch only. Type A2, when there is the lateral orbital wall. And type A3, which is the infraorbital rim only. Okay, so these are only arch, only lateral orbital wall, and only ring. Okay, then there is type B, where I have told you all articulations are fractured, but it is a complete fracture. Means the whole segment is one point. It is a one piece. All right, and type C is a very bad complex or a comminuted fracture. Right? If the examiner would have given it in a single answer type, then I'm sure you would have marked it correctly. But examiner has made the question difficult by making it a multiple correct answer question. And this you can answer only if you actually know the classification. Okay, so yes, this was definitely a difficult question. The answer is zygomatic arch, not involving the body, and lateral orbital wall. So this is 1A. Sorry, this is A1 and this is A2. Right, so these both belong to the classification of A. Monoblock fracture of zygoma involving all four articulations, this is type B, moderate. And comminuted multi-fragment fracture, this is type C, severe or high velocity trauma. Okay, so this is the correct answer to this question. By the way, I am not saying that this exactly we have taught, but we have shown you these cases. This case was shown to you in the live class also and in the recorded class also, where we have shown you a midface fracture where this patient had come under the train, and it was a comminuted right fracture with globe injury, multiple basofrontal contusions. And see, this is how it shatters completely. Okay, this was actually one of the cases which I had handled as a senior resident there. And see how the zygoma is broken into multiple comminuted segments. This is exactly the type 3 high velocity injury, because this patient had come under a running train and then he was brought to the trauma center, and then how we had debrided all the lacerations, we had fixed with multiple plates, we had brought the zygoma back into correct position and sutured all the soft tissues back. Right, so this is actually the high velocity type 3. Although we have not taught you exactly the classification format, but this is something new which was asked this time. Again, the next question was on Spizzle and scroll classification. Unless and until you know it, you will not be able to answer. Right? So the correct answer is C. Type 1 is So this is the spizzel and scroll classification. Type 1 is without any displacement. Type 1 is any fracture, usually of the condylar neck region, which does not have any displacement. Type 2 is low condylar neck fracture. Type 3 is high condylar neck fracture. Type 4 is low condylar fracture with dislocation. And type 6, which was there in one of the options, is intracapsular. Condylar head means intracapsular fractures. The purpose of this spizzel and scroll classification is just to basically differentiate that type 1, 2, 3 are extracapsular. They are outside the capsule. Type 4 and 5 are in the middle. I mean, they are causing a dislocation. So that dislocation is tearing the joint capsule. It is not within the capsule, but the dislocation is tearing the joint capsule with luxation. And type 6 is actually intracapsular, which we call as the dicapitular fractures. Dicapitular means in the head of the condyle. So head of the condyle mein hone wala dicapitular fracture. So correct answer will be type 1 undisplaced condylar neck fracture. So 1 will be 4. 2, it is low condylar neck fracture. So 2 will be 3. Type 3, high condylar neck fracture. So it will be 2. And type 6 is intracapsular fractures, which is 4. So again, these are the kind of questions, which you should leave. You've never heard it. You've never read it. Just don't come back to these questions. Leave it and never come back to them. You can never think and use any concepts and mark these answers. So such questions are put in the paper and are meant to be left. So anybody who comes out to be a topper, whenever we are doing the interview, we will ask them whether we marked it or not, and most of them will say that, ma'am, we have left it, because you can't guess in such questions. Okay, so such questions, it's absolutely okay if you can leave these questions. All right. Okay, coming to the next player question, again a direct PYQ. The Champy's internal fixation of mandibular angle fractures. Which of these is the ideal place of placement of plate to resist the tensional forces? We all know that in angle fracture, it is along the external oblique ridge on the superior border. We put the plate in this S kind of a fashion, which is a propeller kind of a plate. 2 screws on the buccal side, 2 screws on the slightly going towards the lingual side. And this is the place where maximum tension is there. So you will always put a plate like that. It is there in our notes. We have shown you how in the external oblique ridge the plate is placed, and it goes in a propeller fashion. This is one of the favorite questions of the AIIMS examiners, and it's taught to you in detail in the notes. Okay, in zygomaticomaxillary fracture, when the fracture line runs above the Wittnall's tubercle, which of these can be seen? Now, I feel that this question has a mistake. This question should be all of these can be seen except should be there, because most of these things can be seen if the fracture is going above the Wittnall's tubercle. Let us first understand what is Wittnall's tubercle. Okay, so this is the orbit. This is a direct pick from our notes only. This is the medial canthal tendon. This is the lateral canthal tendon. Okay, the lateral canthal tendon is attached to a bony prominence, which is known as a Wittnall's tubercle. Okay, this Wittnall's tubercle is like this bony prominence here, and it is very important. Okay, it is very important because what are the structures that come and attach to the Wittnall's tubercle? First structure is the lateral canthal tendon. Okay, so the medial canthus, lateral canthus. Okay, there is a tendon there which attaches, which is known as the lateral canthal tendon. This is the first thing which attaches. Second thing which attaches there is the Lockwood suspensory ligament. Lockwood's suspensory ligament. Now, we know what is Lockwood suspensory ligament. The eye, the globe of the eye is inside the orbit, right? But it is not just hanging in the orbit there. It is supported on the orbit with a kind of a hammock. Okay, you must have seen those, those jhulas which are there in the coconut tree, 2 coconut trees, and in between there is this jhula. There is this kind of a swing where you sit on the beach side and you enjoy the beach, right? So this kind of a structure is known as a suspensory structure. It is suspended between 2 columns, right? So exactly like this, there is a ligament which is known as the Lockwood suspensory ligament. What does this ligament do? This ligament holds the eyeball. It holds the whole globe or the soft tissue of the eyeball, right? Below the suspensory ligament is the orbital floor. right? Below the suspensory ligament, there is the orbital floor. If there is a orbital floor fracture, see in zygomatic fractures, the orbital floor can also be attached, right? So if there is a orbital floor fracture, but suspensory ligament is intact, the globe will not go anywhere. Okay, the globe will be right there, and you don't need to reconstruct anything in that case. Okay, the globe is still in place because the suspensory ligament are normal. But if the orbital floor fracture damages the suspensory ligament, then what will happen? The globe will go down, hypoglobus. The globe will go inside, enophthalmos. So two things will happen. Enophthalmos, that means globe has gone inside, and hypoglobus, the globe has gone down. When will this happen? When the suspensory ligament of Lockwood, when this is injured. When will it get injured? If the fracture line is above the Wittnall's tubercle. Okay, this is the question. The fracture line is somewhere like this, above the Wittnall's tubercle. So what it will do? It will take the lateral canthal tendon also down, causing anti-mongoloid slant. It will cause an anti-mongoloid slant, given in our notes very nicely. Okay, hypoglobus, enophthalmos, hypoglobus, restriction of gaze, diplopia, double vision, because the muscle is injured, because the nerve can be injured. So there's a very good chance that there can be hypoglobus. Okay, and it will also cause the lateral canthal to go down and give a this kind of an anti-mongoloid slant, right? So again, I would be happy if except word would be there, because raised level of eye was one of the options, and this will never happen. The eye will never go up. The eye can only go up if the fracture happens SA. Okay, blow in fractures. Whenever there's a blow in fracture, in that case, the globe is pushed upwards. The globe will go up or the globe will come out. That is the only place where the globe will go up, and it is a very, very rare fracture that will hardly happen. So this is the only thing which is absolute. It will never happen. So if except would have been there in the question, then answer would have been C. Now the examiner has not put the word except. Now let us see what we should mark. Now ideally, all the three happen. Monoocular diplopia, definitely it will happen. If, okay, third thing I forgot. Lateral canthal tendon is there. Lockwood ligament is there. And third thing which is there, which is inserting at the Wittnall's tubercle, it is the check ligament of the lateral rectus muscle. The lateral rectus muscle check ligament. The check ligament of the lateral rectus. So these three things are actually inserting on the Wittnall's tubercle. Now, whenever there's a fracture above this level, all the three will be affected. Okay, so the level of globe will also go down. Lower lateral canthus of the eye causing an anti-mongoloid slant. This will also happen. Depressed level of the globe of the eye, which is hypoglobus. Obviously, this will happen because the suspensory ligament is injured. Monoocular diplopia. Monoocular, why? Because in the one eye only. Trauma has happened to one side, so why binocular? Only monoocular. So only in the injured eye, there will be double vision. Why double vision? Double vision can be because of muscle injury. Double vision can be because of nerve injury. So here double vision, because we know that at the Wittnall's tubercle, the lateral rectus check ligament is also attached. So this can also happen. So ideally, all these three can happen whenever there's a fracture line running above the Wittnall's tubercle. Okay. So I don't know what you should mark here, but I would have been happy if except is there in the question. Okay, so this is a little controversial. We are still looking for references. We are still looking for answers that, you know, what can be the best answer. If the examiner wants to mean that the Wittnall's tubercle is not damaged, if the Wittnall's tubercle is not damaged, if that is what the examiner is wanting to tell us, then nothing would happen. So it is not clear what exactly the examiner is wanting to ask. We are still looking for references. Maybe it's a direct pick from some book, some lines from the book. We are still looking for references, and if we find something, we will put it in in the PYQ segment of our eGurukul app. Okay, so this is a little confusing there, and we'll still look for references for this. Okay. So lowered lateral Kenthan was mentioned. It is same as anti-mongolite slant. Okay. How will you clinically differentiate between Leaford 2 and Leaford 3? It's a straightforward question. Mobility of the dento-alveolar complex, this happens in Leaford. It should not happen in 2 and 3. Circumorbital ecchymosis, it will happen in both Leaford 2 and 3. Cerebrospinal fluid rhinorrhea, because this part is involved, ethmoids are involved. It will happen both in 2 and 3, right? So what is the only thing that will differentiate 2 from 3? It is mobility of the zygomatic complex and nasal bridge. So this whole thing, as a unit, it will move. All right. Now, I have shown you this video, and I have shown you a part of video. I'm going to show you both the videos, okay, which we have shown you in the recorded class also and in the live class also. See, I've shown you this video from our patient and trauma center, how this whole maxillomandibular complex, this is a patient of Leaford 3. You can see this whole nasal bridge and midface. The full thing is moving when the patient is chewing. You can see there is movement here. You can see there is movement here. You can see this whole segment is moving. This is typically how the nasal bridge is also moving, right? So this is the video we have shown you in the classes, and you know about it. And this is where we have also discussed about raccoon eyes. Okay, this is a video. This is a video in video. I will just move a little aside. And this is a part of the video where we have shown you that this is how the Guerin fracture will show you the palatine ecchymosis, the Leaford 1 fracture, which is the Guerin sign. We have shown you raccoon eyes also very clearly. So this is the video, actual video running, which is there in your app. Raccoon eyes means there is circumorbital ecchymosis. There is bleeding around the eyes of the patient, and the patient starts looking like a raccoon. Okay, starts looking like a raccoon. This is already written in your videos. And this can happen. When can this happen? This can happen in Leaford 2 fractures. This can happen in Leaford 3 fractures. And this can happen in NOE fractures. Okay, and all the 3 fractures, it is there. Okay, raccoon eyes can be seen. You can, if you just want to watch this video, you can complete watching this video. Okay, so in Leaford 2, it can be seen. In Leaford 3, it can be seen. And along with that, you can see it in NOE fractures. Okay, so NOE fractures also, it is written that you can see this raccoon eyes. All right, so this is again a direct pick from our videos and our lectures. I'm very happy that a lot of you have told me that you've marked it correctly. All right. Okay, let us go to the next question. The coronal CT phase shown in the image below shows. So obviously, I know this is a direct marking question. You can see the R. You can see the R written here. So all those who are confused that whether we will be able to tell right or left, there's a very clear R written there in the exam also. So it's a right-sided fracture. Left side, you can see everything is intact. Right side, you can see that there is a condylar neck fracture there, and there is a ramus fracture there. This was the exact image that was there in the exam. And the options, we don't remember the fourth option here, but the options, one of the options was bilateral condylar fracture. Obviously, it is not bilateral. Unilateral right condylar fracture and ramus fracture. This is the correct answer. Was it a unilateral condylar hyperplasia? No, it was not condylar hyperplasia. And fourth question, if somebody can remember the fourth question, you can just guide us what the fourth option was, and we will add it. So the correct answer here is right unilateral condyle and ramus fracture. Okay. We have also put this in our notes in some other format when I've shown you this case of a girl who fell down from the stairs, and we have shown you the exact coronal CT phase. This is the exact image from our notes, coronal CT phase and condylar fracture. So this is how a displaced, dislocated condylar fracture will look on a coronal CT phase. So again, I can say that this is a direct pick from our notes. Okay. Now this is 2 questions from exodontia. They were a little tricky, but I know most of you must have marked it correctly if you pick up the keyword. A patient undergoes extraction of third molar. He reports 6 hours later with continuous ooze from the side. Continuously there is some bleeding happening. The doctor suctions, clears and observes the socket. Then he compresses the soft tissue against the bone. Compressing the soft tissue against the bone, that means soft tissues are bleeding, and to press them, you push it against the bone so that the bleeding stops. So what is the source of bleed? The source of bleed are the soft tissues. It is a soft tissue bleed. It is not a socket bleed. It is not a socket bleed. It is a soft tissue bleed. How do you know it is a soft tissue bleed? Because when you compress the soft tissue, that means pressure. Pressure on the soft tissues, by pressing them against the bone, the bleeding stops. So the source cannot be any major vessel. The source has to be the buccal and periosteal vessels which supply the soft tissues around the bone. So the correct answer is buccal and periosteal vessels. This is the correct answer. Okay, during buccal cutting, now this is again a very vague kind of a language. During buccal cutting, the lingual split or the calcify technique, which of these is the indication of use and risk involved? So basically the examiner is wanting to ask that why do we do a lingual split, or what is that when you open the flap, what is it that you see that gives you the lalach or gives you the feeling that okay, I should remove the teeth lingually and not buccally. So normally the buccal gutting you do from the buccal side, whereas the calcify technique you remove the tooth from the lingual side using chisel and mallet. So what is the indication of using it and what is the risk involved? The only indication is that there is an adequate plane of cleavage on the right side. Again, we have not been able to find the exact words. We are still searching for references where these exact words of plane of cleavage is there. But looking at all the options, this seemed to be the best answer. Okay. And there is a risk of lingual nerve injury. Definitely. We don't touch the lingual side in the third molar region because exactly there lies the lingual nerve. Right. So what calcify did was he didn't reflect the flap alone. He reflected the bone along with the soft tissues. So chances of lingual nerve injury were reduced, but still it is a very big issue with the calcify technique. Okay. So decreased buccal swelling, no, that is not the reason why we do lingual split. Short duration of surgery, yes, lingual split is a very fast surgery, but that is not the reason why we do it. Better visualization of tooth and damage to facial artery, again this seemed to be a wrong option. The best answer here looks like adequate cleavage plane on the lingual side, and the risk involved is a definitely risk of lingual nerve injury. So the correct answer should be B. Okay. All of these are risk factors to increase chances of dry socket, except which of these is not a cause of dry socket? 100% the answer is hypertension. Why should hypertension be a cause of dry socket? Hypertension, what worse it can do? It can cause bleeding. And bleeding is helpful in dry socket. It will prevent dry socket, right? So oral contraceptives, definitely we have read in our final year BDS also, oral contraceptive use increase the chances of dry socket. Long-term traumatic procedure, a very traumatic procedure increases the chances of dry socket. Smoking definitely increases the chances of dry socket or clot dislodgement. However, these are all hypotheses, right? This is not a definite reason. These are hypotheses, and Burns hypothesis is the most acceptable hypothesis. We have taken it in our notes also. Hypertension here is the correct answer. This is the answer because this is nowhere related to the cause or effect of dry socket. Okay, so alveolar osteitis or dry socket, Burns hypothesis is the best, most acceptable hypothesis. Okay, and the treatment also is covered very nicely. So all you have to do is irrigate the socket and give good obtundant painkiller cover. That's it. Okay, so the answer here is hypertension. Okay, this was tricky, but if you have read the notes, you should be able to answer. 50-year-old patient is sitting on a dental chair for tooth extraction when he experiences severe pain in the chest. What is the meaning of severe pain in the chest? Angina. Difficulty in breathing. What is the medical term for difficulty in breathing? Dyspnea. Anybody who is not able to breathe, the best position in such patient is a prone position, or if not possible, erect position. This is the best position you can give to any person who is unable to breathe. We have taken this in our notes very nicely, and I have put it there that COPD COPD means the chronic obstructive pulmonary disease. Emphysema or chronic bronchitis. The lungs are not able to do the ventilation properly. So keep the chair erect. You have to keep the dental chair straight. Whenever you are doing any procedure, whether it is extraction, RCT, scaling, whatever you are doing, whenever a patient has difficulty in breathing, you have to keep the chair straight. Avoid supine positioning. Okay, so this is there. I would hope that a lot of you have read this and you have marked it correctly, that you have to avoid supine positioning in a patient who has difficulty in breathing. Again, the options were again very, very straightforward, because the only option that gave a treatment for angina is option D. Okay, the treatment for angina is you put a sublingual GTN. Okay, a glycerol trinitrate tablet, which is the emergency management of angina. And you keep sitting in supine position. Make the patient sitting. Do not lay the. ऐसा नहीं होना चाहिए कि जो भी patient uncomfortable है उसको लेटा ही दो. No. Whenever the dyspnea can be seen, if he's having choking or he's having difficulty in breathing, keep the chair erect. Otherwise, your breathing will worsen. Okay. Lay the patient supine position and head low. Never. Usually you do it in syncope. Lay down in left lateral position. No. This is usually done in case of pregnancy. You do that in pregnancy. Okay. Head low. Usually अब head low भी नहीं करते हैं. अब तो leg raise करते हैं खाली. There is nothing like a head low. Just supine and leg raise. That we do in syncope. Right, left lateral to prevent the the cable compression. You do the left lateral positioning in pregnancy. Wait until MI is confirmed on ECG. Yes, it could be an MI, but at least consider an angina and give him some emergency management. So this is also wrong. Immediately put a sublingual tablet. Why sublingual? Because the blood supply of the oral cavity in that region is very good. So it will get absorbed very easily directly into the bloodstream, and it will help in angina. And what will help in dyspnea? You keep the patient sitting in a supine position. Right? So all those who have marked this as the correct answer, hooray, you are all correct. Okay. Next question. Again, this was slightly tricky because they have given syncope and vasovagal syncope both. Okay. 28-year-old patient. ASA1. What is ASA1? ASA is basically, you classify the patient, usually before big surgeries, you classify the patient on ASA 1 to 3 based on his physical fitness and his ability to accept anesthesia and accept surgery. How fit he is to take anesthesia and how fit he or she is to undergo the surgery. So ASA1 is the fittest patient. He is not smoking. That patient does not have any comorbidities, no hypertension, no diabetes, nothing. So it's the fittest patient. Okay. So ASA1 means it's a fit patient. So 28-year-old female sitting on the dental chair waiting for her extraction, observing the instruments and extraction of other patients. So she's building upon anxiety. She sees the surgeon coming towards her and now she has the symptoms. What are the symptoms? Profuse sweating, lightheadedness, and drop in blood pressure. Why the blood pressure is dropping? Because of pooling peripherally. There is peripheral pooling. Why? Because of there is a profuse vasodilatation. There is profuse vasodilatation. All the peripheral blood vessels will dilate. So all the blood will reach the peripheries in the legs and it will not come back to the heart. Venous return will be lower, which is why the blood pressure becomes low. And where everything happens, where does this all happen together? It all happens together in case of vasovagal syncope. Okay. Now you will have your this thing, okay, ma'am, why not syncope? Why not orthostatic hypotension? Okay. Let me tell you the reasons also. Syncope is a broad term. Syncope is a broad term, which means transient loss of consciousness. Okay, this is the simple meaning of syncope. It's a transient, means short term loss of consciousness. Okay, it can be due to cardiac reasons because of angina or MI. It can be due to neurological reasons, some neurological reasons like TAI or something like that. It can also be because of orthostatic hypotension. When the patient stands up suddenly from the chair, then also suddenly there is pooling in the peripheries, and because of that movement, the blood is not able to come back. So syncope is and it also covers vasovagal. It also covers the vasovagal kind of a syncope, which is usually because of anxiety, apprehension. So this patient is observing the other patient. "Ore baap re, itne bade bade instruments mere muh mein jayenge, isko to itna dard ho raha hai," and she's expecting a lot of pain, and that is giving her apprehension and fear. So this is typical of vasovagal syncope. There is stimulation of the vagus nerve. The vagus is negative chronotropic, negative inotropic. It will cause peripheral pooling of blood, and it will cause a syncope. Right? The vasovagal syncope. Again, from our notes directly, orthostatic hypotension due to sudden standing from dental chair. It is always due to sudden standing from dental chair. When the patient lies down in supine position for 20-30 minutes, suddenly he stands up after extraction or after RCT. So that gives him a little dizziness because of that sudden movement change. So that is orthostatic hypotension, and no such thing is mentioned in the question here. Okay, so it is syncope. Yes, it is syncope. But what is a better answer? Remember, you always have to mark the best answer. And the best answer in this case would be vasovagal syncope. Okay, not anxiety, syncope, or orthostatic hypotension. Okay. The next question, involvement of which of these facial spaces is considered as a high severity? Again, directly from our notes, we have given you this table. Low severity, low risk, severity score 1, vestibular, subperiosteal, body of mandible, infraorbital, and buccal. Moderate severity, which is 2, all your submandibular, pterygomandibular spaces. And high risk or high severity, lateral pharyngeal, retropharyngeal, and pretracheal. And very high severity, which is 4, it is the actual danger spaces, or when it actually goes to the mediastinum or the cavernous sinus. So question has asked about severity score 3, which is high severity. Answer will be retropharyngeal. Pterygomandibular is a severity score of 2. Buccal is 1. Submandibular is also 2. Retropharyngeal is 3. So it's high severity. Okay. Again, directly from the notes, if you have read it properly, you should be able to mark. And last one, this was a new question. Drug-induced sleep endoscopy. Okay. It is used for the diagnosis of which of these conditions? Again, if you could just use a little logic and rule out options. See, it is endoscopy. Endoscopy means you are taking a tube through one of the natural openings, through the nose or through the mouth, and you are checking either the respiratory tract or the gastrointestinal tract, right? Trigeminal neuralgia. Trigeminal neuralgia is a neurological disorder where the nerve is firing abnormally. Why should we need endoscopy in trigeminal neuralgia? So it is wrong. Pansinusitis. Definitely you do endoscopy in pansinusitis. It is called FESS. Functional endoscopic sinus surgery. We have talked about FES in our pathology chapters. We do FES in pansinusitis to remove all the thickened lining. But this is not FES. This is drug-induced sleep endoscopy. Why would you do FES in sleep? You will do it either under GA or under LA. Why do you need sleep study in that? Right? So this is also wrong. CSF rhinorrhea. CSF rhinorrhea is usually a clinical finding. You don't go in and endoscopy, so you don't keep searching for the where is the hole and I have to put a glue. Yes, neurosurgeons do it, but it's an open surgery. So for CSF rhinorrhea also you don't do it. So the only place where you have to do a sleep surgery is obstructive sleep apnea. I know a lot of you must have guessed this correctly, because the only thing where sleep study is required, like polysomnography. Polysomnography is a sleep study. Why do we need a sleep study? Because obstruction is happening in the patient during sleep. Obstructive sleep apnea. Normally, when you and I are talking, there is no obstruction. But when I'm sleeping, there is an obstruction. So during sleep, you need to check with an endoscopy, something like this. If you do it in normal sleep, as soon as you put the endoscope, the patient will get up because his sleep will be disturbed. That is why you give the drugs. You give some drugs so the patient keeps sleeping throughout the endoscopy, and you can see that what is the level of obstruction. Whether the obstruction is due to some polyp in the nose, whether the obstruction is at the level of uvula, soft palate, or whether the obstruction is due to the large tongue, or whether the obstruction is due to some pharyngeal mass which is there. So what is the level of obstruction? Where is the obstruction actually happening? For that, we do a drug-induced sleep endoscopy. This was a new question, never asked before. And still, if you were a little, calculative about the options, you probably could have marked it correctly. All right. So the answer is obstructive sleep apnea. And Okay, one more question, which is again not a direct ortho or prostho or endo or oral surgery question. This is asking about the antigonial notch. Okay, this question is a patient is planned for an implant prosthesis, but on OPG there is a prominent antigonial notch. What is the cause? So basically, it is an anatomy question. Why does antigonial notching happen? Because some muscles are continuously pulling the angle of mandible. Okay, so if this is the mandible, this is the angle of mandible, there is a masseter which is attached at the angle of mandible, right? And of course, with it on the inside, there is a medial pterygoid attached to the angle of mandible. And both these muscles, they form a sling. They form a very tight sling, just like that hammock. They form a sling at the angle of mandible. Now, for any reasons, if these muscles are overactive, hyperactive, this can happen in ankylosis also, deep antigonial notch. We have taken that. This is a screenshot of the note. We have taken it during our oral surgery lectures of ankylosis, that when there is ankylosis, there is a deep antigonial notch. What is the reason? These muscles become overactive. They try and keep opening and closing the mouth, but they are not able to do it. So what happens? The angle of mandible becomes more prominent because the muscles are stimulating the angle, and this area undergoes resorption. So there is formation in the angle region, and there is resorption in the area just anterior to the muscles, just anterior to the insertion of masseter. So this causes the structure of the mandible to become something like this. So when you see the OPG, you will see that the mandible looks something like this. So angle is very prominent, and just anterior to the angle, there is an antigonial notch. Okay, so this can be seen whenever there is a chronic parafunction. Any reason, any cause where the muscle is used excessively. So it can be due to excessive chewing gum, excessive tobacco chewing, or because of ankylosis when the patient is trying to open the mouth but is not able to do it. So whenever the muscles are overstimulated, there will be muscle hypertrophy, masseteric hypertrophy, and there will be antigonial notching. I don't remember the other two options. If anybody remembers the other two options, please help us complete those options. And the correct answer to this will be masseteric hypertrophy due to chronic parafunction. That is the reason of antigonial notching. All right. So with this, we complete the oral surgery recall. Just like I've said yesterday, guys, whatever is your correct score, whatever is your right, whatever is your wrong, it is over. Just don't think much about it. Finish seeing with the recall, and we will start with the next faculty now. Rishabh, are we ready with the next faculty? So Dr. Ruchi is here. I will just invite Dr. Ruchi. Hi, Dr. Ruchi. So we can see Dr. Ruchi there.
Hello,
Welcome.
good afternoon. Good afternoon, Dr. Imani.
So I'll take your leave, guys. Dr. Ruchi is here with you, and she'll continue with the recall of prosthodontics. Thank you so much.
So very good afternoon to all our dear students. I am Dr. Ruchi Raj, your prosthodontics mentor, and I welcome you.
So you can see Dr. Ruchi there.
Hello,
Welcome.
good afternoon. Good afternoon, Dr. Imani.
So I'll take
Okay.
your leave, guys. Dr. Ruchi is here with you, and she'll continue with the
Just a second.
recall of prosthodontics. Thank you so much.
Okay. So very good afternoon to all our students. I am Dr. Ruchi Raj, your prosthodontics mentor, and I welcome you to this recall session of prostho. First and foremost, how was prostho for all of you, and what is your initial reaction about your questions in prostho? I did a small poll yesterday where majority of the students felt that it was a moderately tough paper, moderate to tough paper, less votes on the easy option. But you tell me, what is your opinion on Prostho? How was the paper? The general review that I got for this INI-CET exam was that it was loaded with Prostho, ortho, oral surgery, cons, endo, mainly all dental clinical subjects. And that we can see even Prostho, almost close to 20 questions are there. So let me know, how was Prostho for all of you first, right? We will start with the recall of Prostho. We have almost all questions here and we'll discuss all of them one by one. Let me have a quick look at the chat box. Hi everyone, good afternoon. We have quite a few students joined in right now. Okay, so let us begin with the discussion of question number 1. Which amongst these will act as force magnifiers and produce the most amplified mechanical stress on an implant? Now, this particular question specifically mentioned one thing, which is magnifier of force. So if there is any load or stress acting on the implant, what out of these options can actually magnify them? Now, my general review of this INI-CET exam and its paper was that there were a lot of classification based questions. There were a lot of questions that are multiple combinations. So you will be given 4 options and then combinations will be there. You are supposed to select what is right or wrong, right? So these kind of questions were there. This was also one of them only, right? Now, some students are saying that yes, Prostho was difficult. Yes, I agree. Prostho was difficult. What I felt regarding Prostho exactly was that the topics may have been something that you already know. The questions is also something that was already taught. But the question language was twisted in such a manner that you may be making mistake while attempting in a state of stress or anxiety. You may make a mistake. So as we have already said, even in the NEET recall also, if only your concepts are strong and clear, then there's a less chances of you making error. Otherwise, all of these questions are formulated in such a way that whatever your initial hunch would be, probably may be wrong. So you have to cross check, you have to verify, and in that way it becomes lengthy also for you. So that is my initial impression of Prostho. I can say topics is something that we all of us know that these are important. Some of them are relatively new, which were not asked that frequently in previous papers, are now being asked. But what we already know, even from those topics also, the language of the question has been made tricky in a way that error increases while attempting, right? Now, which of the following will act as force magnifiers and produce the most amplified mechanical stress on implant? Cantilever prosthesis, large crown height and length, bone density and width of the implant. Out of them, cantilever and a large crown height, the length of the crown or the height of the crown, if it is larger, both of them will amplify the stress. By amplification, we mean what? If X amount of load is acting on the implant and supposedly say cantilever increases or crown height increases, it will increase the load on the implant in multifolds. The density of the bone and the diameter of the implant do not have these kind of proportional equations with the stress that is acting on the implant, right? So correct option is this first and second one, and that comes under option number B. So this was our correct answer over here. Option 1 and 2, which is cantilever prosthesis and large crown height. Both of them are responsible for magnifying the force. And this word was specifically there in the question, force magnifiers. So this is something that you should keep in mind. Now, let's go to the second question. One more pattern which I saw in this INI-CET exam paper was that a lot of topics overlapped with the same topics that were there in your NEET paper. So there was a question regarding occlusal interference in your NEET paper, similar question regarding from the same topic of occlusion, subtopic, which is interferences in occlusion, has come in your INI-CET exam paper also. So a patient faces posterior occlusal interference in centric. Towards which side will the mandible deflect? Upon closing, was there or not? We are completely not sure, but it meant that it is upon closing only. So is it lateral to interference, medial to interference, antero-superior or postero-inferior? Basically, this revolves around the concept of centric. that we have taught to all of you during our live classes, even in our recorded classes also, but in much elaboration and detail. When we do our live classes, we enact it out also with our students, right? So when we take the tip of the tongue to the most posterior part of our palate and gently close the mouth, this particular position that we reach is our centric relation position. The question is asking that while closing in centric, if there is a posterior interference, now what will happen? How will mandible close eventually? So when there is a posterior interference noted at this point of time, the mandible will have a tendency to deflect anteriorly and close in a more comfortable position, and it will come into intercuspation or maximum intercuspation. So general tendency at this point will be to come anteriorly and superiorly to close the mandible. So mandible basically from this point, say it is trying to reach centric, right? If this is your mandible and it is trying to reach centric point and supposedly some interference is noted at this point and it is not able to reach or close in centric, there is a centric interference. So it will move anteriorly and then close superiorly. So antero-superior should be the correct answer for this. Right, students? I hope all of you are getting this. Hi, everyone. To all those who have joined, if you can just quickly write a hi in the chat box. I hope you are able to understand. It's a tough question. It's a tricky question because you need to understand how mandible moves. So you have to combine the knowledge of mandibular movements that we have done in FPD also, how mandible moves, what are the different planes, and how centric works exactly. That is coming from complete denture. Cumulatively, if you have this knowledge, then you would be able to answer this question. It's a tough question, right? It's a tough question. So second question, answer is anterior and superior. When we understand centric, and if you know how centric works and what is maximum intercuspation, you may be able to solve this question, but it's a tricky question. So when mandible closes, it touches the interference, it will have a tendency to slide forwards and then close the mandible into intercuspation. So anterior and superior, right? Hi, everyone. So question number 2 is done. Question number 3 now. An operator gives mandibular lingual plate as major connector. What should be kept in mind? Basically, the question was trying to ask what is an absolute requirement with regards to lingual plate, or what is something that you need to follow with a lingual plate, right? So all 6 anteriors should be present. At least 8 mm sulcus height should be there. Rest is to be given on proximal surface. There's a bit of, I would say, I'm not sure about the recall of option number C, but there was an option pertaining to rest or rest seat in this option. And fourth option was an absolute absence of lingual torus. That is something that I recall and remember, right? As always, I will also request all of you, if you find a better recall of any option or any question, you can definitely put it in the chat box and I can even verify it and probably correct our PPT so that it is available for you before your next exam. Now, for this question, let us dissect the answer. All 6 anteriors must be present. No, must is not a case. It's good if they are present, but even if they are not present, you can still give all 6 of them. It's not mandatory, right? Rest is to be given on proximal surfaces or mesial surface. There was some confusion regarding this option. And absolute absence of lingual torus is not a prerequisite for linguoplate. If there is a very small torus that you can relieve, you can give a linguoplate over there. But 8 mm sulcus height is something which is necessary. 8 mm or slightly less than 8 mm, that is the mandate for it. But that is necessary for linguoplate because you need to give a 4 mm relief. And 4 mm is at least for the major connector. So if we check our notes over here also, in the notes, the topic of linguoplate which has been given, in this, we have clearly mentioned in the indications, lingual vestibular height, right? Contraindications are your lingually inclined teeth. Now, a question pertaining to this and your major connector of labial wire was asked in NEET. This time linguoplate has been asked, right? So questions are coming from the same subtopic only. It's just that something is being changed here and there. But this is present in our notes and it's a relatively easy question. So question number 3 is that. Now, question number 4. For a constricted mouth opening, an operator wants to fabricate a RPD. In what sequence the steps should be carried out? So if there is a constricted mouth opening, that's an additional information not necessary or relevant even to the question. This is also something that we notice. A lot of irrelevant information was there in the question, which is there to actually confuse you, but may not be exactly necessary for that question. So even if you cancel this out, it has no relevance exactly. Operator basically wants to fabricate a RPD and is asking you the steps of surveying. And this is actually a very good question. I'll tell you why. Options were surveying the master cast, mouth preparation and rest seat preparation, primary impression and diagnostic mounting, and path of insertion determination. Now, the main word here is master cast. As soon as master cast is written here, the sequence is not the obvious sequence that you may be thinking. Most students have considered that it may be primary impression and diagnostic mounting, so C. Then they may have thought that surveying would come, so A. Then they may have thought that path of insertion would come, and then probably mouth preparation would come. So CADV is an assumption that most students have made, but this in fact is actually wrong. I'll tell you why. The sequence here would be first and foremost primary impression and diagnostic mounting. So C would come. You have to do this. After that, this is a master cast. Master cast is made after your mouth preparation is done, not before the mouth preparation. So then you are determining the path of insertion. So D would come over here. Then you would come to mouth preparation. And on that, you will get a master cast which you survey. So the option then becomes C, D, B, A. The exact sequence is what I'll tell you. First and foremost, you have a case, you do your primary impressions, make your primary model, do your diagnostic mounting. On the primary model, you do your surveying and establish the path of insertion. Once that is ready, you can do your mouth preparation in the patient's mouth. After that, you make your final impression and you get a master cast. On the master cast also, you can do a surveying to verify the mouth preparation that you have done in your patients, whether it is accurate or not. That is how you proceed. Now, if you have a look over here, since the option mentions master cast, the sequence here completely changes than what the obvious sequence you may have thought out. Correct answer here is first primary impression and diagnostic mounting is done. Then on the diagnostic cast, you establish the path of insertion. You do that relevant mouth preparation in the patient's mouth, whatever rest seat you have determined onto the diagnostic model and everything. And then you make an impression out of it, which will give you your master cast. On that master cast, you can again do your surveying to verify whether everything that is prepared in the mouth is accurate or not. And then you go ahead with duplication and all the other next procedures, right? So correct answer is C, D, B, A, option number B. Okay, now let us come to question number 5. The survey line or height of contour, it was given in the bracket, determines what? So basically, what exactly is the height of contour? The greatest circumference area along the path of insertion, dividing the retentive and non-retentive part, separating the gingival sulcus, or separating clinical crown from the root. So correct answer here is it's a fact-based question. It's the greatest circumference area along the path of insertion. So if you have a look at our notes over here, the exact image that is given in McCracken also, I had shared it over here. While in the chapter of dental surveyor and surveying, what basically is a survey line? A line that is scribed onto the tooth with the help of a surveyor. But when we have a fixed path of insertion, as you can see in the image over here, when we have a predetermined or a fixed path of insertion, the line that determines the widest circumference of that particular tooth, that becomes your height of contour. Wherever the tooth is the widest in circumference, that is your height of contour. So very simple question. But yes, in NEET also questions were from surveying. Surveying tools was asked. This time the surveying sequence as well as your height of contour is asked, right? So question number 5 is that. It is there clearly in our notes as well, and a relatively easy question. Now, according to Pound's triangle, placement of posterior mandibular teeth should be what? At the crest of the ridge, in the neutral corridor of tongue and cheek, labial to the buccal ridge, or on the same location as natural teeth. So Pound basically has given this Pound's triangle, where anterior reference is the mesial surface of the mandibular canine over here, and posterior reference is the buccal and the lingual of your pad area. And together then this Pound's triangle is formed. It is a guideline for arrangement of mandibular posterior teeth, right? So this triangular zone is where the lingual surface of lower posterior teeth should be there. If you go buccal from this, then interference with cheek may be there. And if you go lingual to this, interference with the tongue may be there. So basically it creates a neutral corridor of the tongue and cheek in which your teeth should be arranged to gain maximum stability for mandibular denture. So according to the Pound's triangle, a simple fact-based question, answer should be B. The placement of posterior mandibular teeth should be in the neutral corridor of tongue and cheek, not on the crest of the ridge, labial to ridge, or on the same location as natural tooth. These are all proposed theories of different scientists regarding occlusion, and we need to remember them as it is. You would have studied different theories of occlusion, different principles given by different scientists. This is also one of them. According to this, if you see, mandibular teeth need to be arranged in this Pound's triangle area to gain maximum stability of complete denture. Now, if you compare with your NEET paper, at that time you had something relevant to pleasure. This time it has been asked relevant to Pound. So I was very surprised actually looking at this paper is topic by topic, even the subtopic is also matching in contrast to if you see NEET, they almost are falling along the same lines only. Now come to question number 7. In a patient with, now this is one thing actually, relevant to Mission Judy's classification, quite a few questions were there in exam. So one of them is this, in a patient with anterior rehabilitation with implant, the tooth as well as the gingival part needs to be included in the prosthesis without the interdental papilla. What kind of prosthesis should be given? So tooth as well as the gingiva, both are to be included. Then it becomes a FP3 prosthesis. If we have a look at the table in our notes, it clearly mentions the classification. FP1 is just the crown only. FP2 replaces the crown and the portion of the root, and FP3 replaces crown and the gingival color also. It's a simple fact-based question and straightforward question only. I hope no mistakes have been made over here, right? So question number 7, correct answer becomes your FP3 prosthesis. Now let us come to question number 8. Before that, students, I'll just quickly open up the chat box also. If there are any queries, you can definitely ask. Even if any suggestions also, you can share and we can have a look at it. Fine. Now, in a patient with maxillectomy, Brown class 2 was mentioned. And after 6 months of chemo and radiotherapy, what kind of obturator should be given? Interim, surgical, definitive with hollow bulb and palatal lift prosthesis. Yesterday, I was discussing this question with some of the students and most of them suggested that because Brown class 2 was mentioned, they were a little hesitant to attempt this question. But if I remove that from the options, majority of you would be able to correctly then guess the answer over here, which is definitive obturator with hollow bulb. So this is what I was saying at the beginning of the session also, that if some irrelevant information or some name is written in the question in a way that you feel that, okay, probably this is slightly confusing, students were a little hesitant to appear for those questions also, or may have made a silly mistake, right? So in a patient with maxillectomy, Brown class 2, not a relevant piece of information. You just need to see in a patient with maxillectomy and after 6 months of chemo and radiotherapy, what do? You give a definitive obturator, not an interim, not a surgical, a definitive obturator with hollow bulb. Right now, here we have a doubt from Taruna. Taruna is saying previous question FP2. No, Taruna, you can clearly have a look at the classification that we have in the notes. See, the question very specifically mentioned in a patient with anterior rehabilitation in implant, tooth as well as gingival part needs to be replaced, right? So if you have a look at the classification, if it is only the crown part, it is FP1. Crown and some part of the root is FP2. But crown and gingival color has to be added. Then it goes into FP3. And then the rest are RP4 and RP5. Right? So I hope your doubt is clear over here. Some students are saying mastercast is not mentioned. No, students, we are absolutely sure over it. Mastercast was mentioned in that surveying question, and that is why it becomes tricky. Mastercast was mentioned over it, even for lingual plate. 8 millimeter was specifically mentioned, and that is why it becomes slightly confusing, because we say that lingoplate can be given in less than 8 mm also, or less than equal to 8 mm. But out of all of the statements, the more accurate statement was that option only. Rest all statements cannot be held 100% accurate. This is how I say the paper was confusing, because some information or some things were such that you can't hold them 100% correct with a yes or no. You may have some confusion while attempting those questions, right? So mastercast was mentioned, be sure about it, we are absolutely sure. And 8 mm was given, which is why some students were confused, because what do we say while studying? 8 mm or more is for lingual bar, less than or equal to 8 mm is for lingoplate. Now suddenly if that particular question comes over here, right, let me open it up. Out of all of these options, the most accurate option becomes that option only. An absence of lingual torus is not given actually in lingoplate. You can give it with a torus also. Regarding the option of rest, it was something else only. I will have to take a look at it, but the option was something that rest is given on the most posterior abutment or something like that, right? And all 6 anteriors mandatorily, it's not necessary that they need to be present. So if you then see which is most accurate statement, D becomes most accurate. And that is why that is our answer over here, right? So I hope all of our students over here who have mentioned certain queries here, your doubts are solved with regards to these questions. Now, let us come to what we were discussing in a patient with maxillectomy. So what I was saying is, if Brown class 2 is mentioned or not, that is not relevant over here. Patient is there with maxillectomy, 6 months post chemo and radiotherapy. What do you give? You give your definitive obturator, assuming that in 6 months healing would have been completed, right? So correct answer here is option number C. I hope doubts are clear, everyone. Yes or no? Please let me know in the chat box. Now, this is our short part of the notes that is relevant to implants, maxillofacial and splints. So implants, maxillofacial, splints, occlusion, these are topics where they are very vast topics, and it is genuinely very difficult to predict what can be asked for a postgraduate student in these exams, right? So okay, sorry for the interruption. So when we take up implants, maxillofacial and splints, under that we have shown this. The sequence of obturators, which is surgical, interim and definitive. Then the details of all of the different kinds of obturators also, advantages, disadvantages of all of them. Right? And if you come over here, okay, I'm just zooming in on it. If you come over here, used 4 to 6 months after surgery. Let me come to the next question of surgical obturator. I'll explain it over there also in details, the entire sequence with obturators is that whenever you have a case or a patient that is planned for surgery, generally you'll receive a diagram from your surgeon that this is the proposed diagram of surgery. On the basis of that, you make a diagnostic impression before actually the patient goes in for surgery, do the mock-up surgery onto the cast and prepare a plate in cold cure resin. That plate is your surgical obturator. If it has remaining teeth, you put clasps over it. If it is completely edentulous, you make holes over it so that it can be sutured in the patient's mouth. This is generally given immediately post-surgery. Now, for some reasons, if it happens that this plate does not fit into the patient or the plan of surgery changes within the OT, then what do you do? 7 to 10 days after your surgery is done, you make another impression and give a obturator. This is a delayed surgical obturator. There's a question pertaining to surgical obturator. We'll even come to it when that question comes. Advantages of these obturators are that actually they help the patient shift to oral fluids as well as semi-solid food quite faster post-surgery. They will help to hold the pack also that is there at the site of surgery, and they help the patient transition faster from a nasogastric tube to oral feeding, which is why these kind of obturators are given. Now, once the basic healing is done, then we shift the patient onto an interim obturator that can stay from the phase of 2 weeks to up to 2 months or even 4 months also. Basically, interim obturator is for the phase where the tissue is healing and there will be changes seen in the tissue. Generally, during chemo and radiotherapy also, you will see that the tissue reorganizes. Healing will occur at this point of time also. So at this stage, interim obturator is given. In your surgical and interim obturator, we do not generally add any teeth, except sometimes we add anteriors in interim obturator if aesthetics is of a larger concern, but no posteriors, because we do not want to transfer occlusal load on this abused tissue. Now, when you come to a stage where you feel that complete healing has been done, chemoradio is over, tissue is nice and pink, at that stage what you give to your patient is a definitive obturator. That is usually at the time of 6 months after your chemo, radiotherapy and surgery and everything is over. So that is definitive obturator. That was asked. It is even mentioned in the notes over here, the entire sequence of treatment and this point usually used 4 to 6 months after surgery. So that exactly was asked in exam. In a patient with maxillectomy, after 6 months of chemo and radiotherapy, what kind of obturator should be given? Definitive with hollow bulb should be given. Now, this is the question that I'm talking about. Surgical obturator is given due to what? It helps the patient to talk and eat after surgery. It needs retention from remaining teeth. It is given at the time of surgery, or is it made of autopolymerizing resin? So let us come to our notes also over here again. If you see, we have clearly mentioned under surgical obturator what are advantages. Other weakened tissues will be supported. Patient will transition to oral feeding. It can be worn immediately after surgery. And this entire phase of obturator therapy is very nicely explained actually in our videos also, in live class also, how the patient transitions from surgical to definitive obturator. I just explained it briefly to you in the previous question. So when we come to this particular question, a surgical obturator definitely helps the patient to eat and talk after surgery. It needs retention from the remaining teeth, and it is given at the time of surgery and made generally of autopolymerizing resin directly onto the cast. So all of them are in fact correct, and the option all of the above is correct for this particular question, right, students? Now, let us come to question number 10. For the rehabilitation of mandibular first molar in a 3-unit FPD, second premolar and second molar are used as abutments, what should be given? Some students do mention that PFM was written. PFM was written in the question for a PFM crown or a PFM FPD. Second premolar and second molar is used as abutment. What margin should be given? So here palatal chamfer and buccal shoulder is to be given, because in this PFM crown on the posterior teeth, we are assuming that it will be a buccal porcelain only. And as written over here also in our notes, if you see, it is shoulder is indicated for facial part of metal ceramic crowns, and chamfer is indicated for cast metal crowns and only metal part of metal ceramic crown. So combining both of that information, palatal chamfer and buccal shoulder is the correct option over here. Pretty easy question. So yes, even other students are confirming it. PFM was written actually in this 10th question. So simple answer, palatal chamfer, buccal shoulder. Beveled shoulder, feather edge, knife edge, not relevant actually to this and not correct answers. So this is a straightforward, simple, easy question. But this question pertaining to FPD was actually quite confusing, and I would say even partly wrong. Very clearly it was mentioned that it is a case of 5-unit FPD, but only 2 abutments and 2 pontics were mentioned. The 5th unit, we don't know what it was. So the question mentioned in a 5-unit FPD, canine and second premolar is your canine and second premolar. These are what? These are your abutments, right? And lateral incisor and first premolar. These are your pontics, right? So 2 abutments and 2 pontics they have mentioned. What kind of FPD this is? But the question clearly mentioned it is a 5-unit. So in that aspect, I would say the question was wrong, right? Now, let us try and still attempt and cancel out. Is it a conventional FPD? Definitely not. Why? Because it is a 5-unit FPD. 5 units are never conventional. There's nothing like a complicated FPD also. The only options that can be worked around is cantilever pontic and pyre abutments. Considering that it is a 5-unit FPD, I'm assuming one of them will be a pyre abutment somewhere in between over here. Either you have an anterior abutment or a posterior abutment, right? Somewhere a pyre abutment will be there. Either this will be a pyre abutment, or if there is a posterior say posterior pontic over here, which is cantilever, then this becomes a pyre abutment. Assuming that, I can give the answer for this question as pyre abutment option C. But I'm mentioning it very clearly. The question was wrong because it mentioned only 2 pontics and 2 abutments, and the question had a 5 unit written in it in the FPD, right? I hope someone can confirm also that this was the exact recall, but that is what I've gained from majority of students. Best case scenario over here would become a pyre abutment for this question, right? Now let us come to notes here. Pyre abutment already clearly described under the chapter of abutments. Here you can see, just a second. See, pyre abutment with an edentulous area on both of the side, also considered as natural abutment. Now, come over here. The entire 5 unit FPD also has been shown. This is a classic 5 unit FPD. See, this is a 5 unit FPD with a pyre abutment, right? So this has been mentioned. Even your next question's answer is also over here regarding non-rigid connectors, right? Ayush is confirming that 5 unit was given, but only 4 were mentioned. So this is something that actually I would appreciate, that question formation should have been better and not this confusing or controversial. Now, on a pyre abutment, what kind of a connector is to be used? A rigid connector, a non-rigid connector, a spring connector, or a loop connector? What can be used on a pyre abutment? So like I was showing in the previous screenshot over here, so just a second. Okay. Like I was sharing in the previous question, pyre abutment is something already mentioned in our notes also. And under the chapter of non-rigid connectors, you would be able to see this, the entire diagram that shows pyre abutments. And if the non-rigid connector is placed, what will happen? And mentioning that non-rigid connectors are necessary for pyre abutment cases. So over here, see, it has been mentioned over here. In this scenario, non-rigid connectors are preferred for the cases of pyre abutments, right? Now, let us come to the question. So on a pyre abutment, what connector can be used? Rigid? No, rigid are not used over here. Non-rigid is used. Spring connector is a type of non-rigid connector only. Loop connector, again a rigid connector, so it cannot be used. So correct answer becomes option B and C. Right? So correct answer is option B and C. That is your non-rigid connectors and your spring connectors. Okay. Just a second. Fine. So very clearly mentioned in notes as well, in both of the topics of pyre abutments, how non-rigid connectors should be used. Basically, it is a 5 unit FPD. If there is a rigid connection given between your retainer as well as the pontic, then excessive load will be transferred on the abutment, so it is not necessary. Now, let us come to question number 13. A patient comes with untreated teeth and further loss of video. During rehabilitation, the operator uses Lucia jig for 20 minutes as deprogrammer. What is the use? So you asked a question regarding the use of Lucia jig, right? Is it to establish or increase the vertical dimension, position of condyle in centric, for masseter strengthening, or breaking the muscle memory and recording centric relation? The case is such that it is a case of patient with atresia, loss of video, most likely planned for full mouth rehabilitation, and you have given the patient Lucia jig as a deprogrammer. Deprogrammer word was mentioned in the question. Deprogrammer is essentially used to break the muscle memory and pattern. It happens in a lot of patients that a wrong muscle memory or pattern has been created because of occlusal interferences, and because of this there is a habitual path of closure of mandible. This may lead to pathological atresia also. This may lead to bruxing also in some of the patients. Now, when we are rehabilitating the patient, we need to find the most accurate relation, which is a centric relation of this patient. And to break this muscle memory, we give an anterior deprogrammer, which is called as Lucia jig. We sometimes even use leaf cage cage also for this purpose. You make the patient wear this for at least 20 minutes, let the patient sit over there, and once after 20 minutes, it is assumed that your muscle memory would have been broken at that point. The correct word is actually muscle engram that is broken, and then you can comfortably take the mandible posteriorly and record your correct centric relation. So it is actually for recording centric relation, not for masseter strengthening or all of the other options. They are near about close to it, but the most accurate option was option number D. So when we were studying occlusion, at that time, we have shown this with an image also. Methods to assist the patient and retrude the mandible. See, Lucia jig is given over here, leaf cage and cotton rolls. These are the different techniques also that are used for anterior deprogramming. And we have explained this while conducting the classes on jaw relations in complete dentures. The same has been asked over here. The logic remains the same, whether it is CD or FPD, right? Now let us come to question number 14. In what condition immediate intervention should be done by removing the implant to prevent neurovascular damage and have long-term stability of implant? This was very specifically mentioned in the question, to prevent neurovascular damage and also gain long-term stability of implant. Now in previous exam, which is your NEET also, it was asked that under what conditions will you remove the implant, right? Similar question has been asked at this point also. Implant is placed at less than 1.5 mm distance to adjacent tooth. We are aware that actually it ideally should maintain 1.5 mm distance. If the distance is less, you will not have long-term stability of the implant, and possibly bone loss also can be seen. Implant is placed at less than 1.5 mm above the alveolar nerve. That was there. So the distance that you need to maintain from anatomical structures was actually not maintained. Implant is facially protruding. The option was somewhere like it is buccally or facially coming out or protruding. This is not its ideal buccolingual position. It should be centered in the bone. An implant is placed in anterior mandible D1 bone at 1500 RPM. D1 bone, which is a very dense bone, and you place it at 1500 RPM, the amount of heat that will generate, it will necrose the bone also, right? The amount of heat that generates, even if you use adequate coolant, it will still necrose the bone. So all of these are actually conditions that should not have happened, and you should not actually be inserting the implant in these. So correct answer would be A, B, C, and D. Now the question, if it just mentions neurovascular damage, then what happens is option number D, as well as your option number B will be correct here. But question specifically mentioned to prevent neurovascular damage and to have a long-term stability of implant. So when you consider both of them, then A, B, C, D, all of them are correct, and option C becomes your correct answer. So correct answer here is option number C, all of the above. Right? Now, let us come to question number 15. It was one of the image-based questions. Which of this is type 2 quality of bone as per ZARP classification? So, Licom and ZARP classification. Generally, we study Mission-Judy's classification, D1, D2, D3, D4. But Licom and ZARP was asked in the exam this time, but you should not worry because it has been there in our notes. It is there in our Q bank. It has been asked almost close to 10 times even in our GT papers also. And if you have a look at it, these are the different classifications D1, D2, D3, D4 as per Mission-Judy. As per Licom and ZARP, which is type 2 quality of bone, they have asked. So they've mentioned type 2 and all 4 images were there as options. So B here is the type 2 quality of bone with some cortical bone also and some cancellous bone also. Rest were 1, 3 and 4, right? So you can have a look over here. It is from our notes, and this is a simple PYQ, rather, I would say, a modified PYQ that was asked in exam. Now, let us come to 16th question. In a distal extension RPD, in a RPI concept, where will rest be placed? So, RPI concept, distal extension RPD. RPI is very simple. Mesial rest, proximal plate, I-bar. Mesio-occlusal rest is clearly given in RPI concept. Option number B, right? Come to our notes also over here, very clearly mentioned, RPI concept, mesio-occlusal rest has been given. When we discuss direct retainers in distal extension case scenarios and how the bottle opener principle works and the tipping of abutment happens in edentulous space, at that time we learn the near and far zones also. At that time we come to know also where a rest should be placed so that the abutment does not tip into the edentulous space. The mesial rest supports that. It will prevent the abutment tipping into the edentulous space, and RPI is a concept specifically built for for it. RPI is rest, which is mesial rest, proximal plate, and I bar. So simple question if you know your facts well. Now let us come to question number 17. In a distal extension RPD, best impression method to record tissue movement, or rather best impression method to record tissue. Let us have a look at the options. Open mouth technique, stock tray with irreversible hydrocolloids and no pressure, stock tray with ZOE, and custom tray and functional impression. Now logically also, if you go over here, a stock tray impression and a custom tray impression, custom tray is always far better than a stock tray, ideally, if you see. And rather than open mouth, this closed mouth technique or functional impression would be better. So from the given options, I would say ideal answer would have been selective pressure for it, but from the given options, custom impression and functional tray is better. This comes under the chapter of dual impressions, again covered under RPD and again covered with complete procedure in notes in details. You can have a look over here at the screenshots also. Now, let's come to our last question. This again was a tricky question and there were some errors in the question. Patient is a chronic complete denture user. That was mentioned in the question, that it is a complete denture user, but the image had some teeth that were visible. So patient is a chronic complete denture user, wears the denture even at night. There is no history of smoking. Patient complains of pain. Main point is this: there is no history of smoking, so no habit was there. Identify the lesion and what needs to be done before making a new denture. Is it inflammatory papillary hyperplasia? Then ask the patient to stop wearing the denture at night. Is it verrucous carcinoma? Is it squamous cell carcinoma? Or you just wait and watch for next 2 weeks, right? So patient is a chronic complete denture user, wears denture even at night, and there is no history of smoking. Straightforward, your answer becomes inflammatory papillary hyperplasia. You ask the patient to stop wearing the denture at night. Again, if you have a look, the question is there with images in our QBank also. It has been asked in our GTs also. So this has been covered very well. Since it has been mentioned there is no history of smoking, all of the other malignant options do not become relevant. Wait and watch does not work. Wait and watch will not actually work out. You need to break the habit so as to heal the lesion. If it is an advanced lesion, then you require some surgical intervention or correction also for it. After that, we can proceed for the new denture. Now, let me have a look clearly at our charts also. So some of them are saying option was selective pressure. I'll confirm once and discuss with the team also. But in any case, whether it is functional or whether it is selective pressure, answer would become option D only. Why? Because custom tray has been given, and obviously with a custom tray, the impression would be far better than what it would be with a stock tray, right? Now, apart from that, I don't think so there are any other suggestions, right? So with this, I think we can bring an end to this particular discussion of recall of questions pertaining to INI-CET 2026. Almost close to how many? 18 questions from Prosto. There may be further more also, but this is the best recall we could arrange and we got. And it's quite an accurate recall. Most of it has been covered either in our GTs, in our notes also. It is present in a QBank also, but I would still mention these are highly conceptual questions and there are chances of error if your concepts are not clear, right? So with this, we bring an end to it. We are connected with you on Telegram. If you have any doubts, you can always ask us. Thank you.
Very good afternoon, students. Myself, Dr. Divya Gupta. Okay, so just let me know I'm visible and audible in the chat box. Good afternoon, everyone. Just let me know in the chat box that I'm audible, and then we will start the session. It will be a very short session, basically. Okay. So myself, Dr. Divya Gupta, I'm periodontics faculty at DBMCI MDS. So from perio, basically, specifically from perio, there was only one question which was asked from the classification, and another question was an integrated question with prostho. So we will be discussing those two questions quickly so that there is not much waste of time. Both the question that came from perio was from the classification, and it was relatively easier question, right? So let us start the discussion. The first question is, according to 2017 classification, I have like every year in INI, they are asking question from the recent classification, and this I have emphasized repeatedly in the recorded videos, in the live sessions. I have told you to memorize the classification. We have discussed the classification very nicely in the classes, as well as it is given in the notes, guys. So 2017 was expected classification in INI, as it has been asked previously as well. Okay. So according to 2017 classification of periodontal diseases, localized aggressive periodontitis is most appropriately classified as, options were, option number A, stage 2, grade B. Option number B is stage 3, grade C. Option number C is grade 4, grade A. And option number D is stage 1, grade C. So here we discussed this staging and grades of classification of periodontitis. And in this, important is grade. Grading, in grading, it is clearly mentioned that grade A is slow rate of progression, grade B is moderate rate of progression, grade C is rapid rate of progression. Rapid rate of progression means aggressive periodontitis. So grade C is confirmed, okay, it is aggressive periodontitis. Now the confusion arises between stages. That aggressive periodontitis can be in stage 3 as well as stage 4, right? But let us have a look at the options. In the options, grade C is given with stage 3. Or in option D, it is given with stage 1. Definitely, grade C will not come with stage 1. So the answer here automatically becomes option number B, which is stage 3, grade C classification. Okay, so I hope this is clear. This questions pertaining to the classification, 2017 classification is there in our question bank. This classification is there in the notes, guys. So I hope this was relatively easier question for you to attempt. Now the next question, the last question is that in this was an integrated question with prostho. Integrated question with prostho. Okay, so the question is, in an anterior implant placement, the keyword here is anterior implant placement, the height of the crest of the bone, to interdental papilla was 2 mm below. The implant placement was 4 mm below the free gingival margin. What will be the consequences? What will be the consequence? Let us first read me the question quickly, options quickly. Option number A is, it is adequate, as adequate papillary height would be maintained. Option number B is, it will lead to crestal bone loss and peri-implantitis. Option number C is, we were not able to recall. So if you all can help, please let us know into the chat box what was option number C. And option number D is, it will give better emergence profile to FP1 prosthesis. It will give a better emergence profile to an FP1 prosthesis. Now, here if we look at the diagram, ideally the implant should be placed subcrestally 1 to 2 mm below the crest of the alveolar bone, right? Why? Because we have to maintain the biologic width. If the implant is placed at the level of the bone, at the level of the crest of the alveolar bone, what will happen? There will be bone loss. Bone loss is going to happen. 1 to 2 mm of bone loss will happen after implant placement. So that we have to keep in mind, that implant bone loss, subcrestal bone loss will be there. So always it is a rule that we have to place the implant 1 to 2 mm below the crest of the gingiva. Now here they have given that the height of the crest of the bone is 2 mm below the interdental papilla. So if we consider this, the height of the crest of the bone, if this is the bone, right, this is the level of the bone, this distance is 2 mm. Now here they are placing the implant 2 mm below the crest, right? 2 mm below the crest. This is 2 mm and this is 2 mm below the crest. So here they are maintaining the biologic width, but as in the question, they have mentioned the implant is placed in the anterior maxilla. In the anterior maxilla, we need to have a better emergence profile, right? It is an aesthetic zone. So option A can be the answer if option number D was not there in the options. Here, as it is mentioned that in the question that the implant is placed in the anterior maxilla, remember that FP1 prosthesis means only crown. When we are giving importance to the crown and when the implant is placed 2 mm below the crest of the gingiva, it has adequate tissue as well as bone level for a good emergence profile. For a good emergence profile. Therefore, in aesthetic zone, it is better to give implant, to place implant 2 to 3 mm below the gingival margin as well as subcrestally. So the best answer to choose here is option number D. If this was not given in the options, the next best answer to choose was option number A. Okay. So guys, with this, we have completed the questions of periodontics. Let me see what doubts students have. Ma'am, both stage 3 grade C and stage 4 grade C were there in the options. Yes, option were stage 3 grade C and stage 4 grade C. Okay, Saloni and Dhwani, let me connect with the team and confirm the options. Okay, and then we can come to the conclusion for this question particularly. So with that, we conclude the session, and guys, all the best and have a good day. दो क्वेश्चन के लिए आना पड़ा हेलो हाँ हाँ ओवर होगा ठीक है ओके ऐसे ही लगे रहने देना हाँ स्क्रीन को Bye.
So this is not mine, that is mine, Dr. Kunal Agrawal wala screen. Shall I start? मुझे स्क्रीन पे मुझे कुछ नहीं दिख रहा है, स्टार्ट करूं क्या?
कर दो सर स्टार्टअप।
उस स्क्रीन पे तो दिखना चाहिए ना, स्क्रीन पे कुछ नहीं दिख रहा मुझको सामने लैपटॉप की स्क्रीन पे।
तो लैपटॉप की स्क्रीन पे या वो यूट्यूब वाले लिंक पे?
लैपटॉप की स्क्रीन पे एक्चुअली।
एक मिनट सर। हेलो।
हाँ जी,
नहीं सर, अब यूट्यूब पे दिख रहा है आपका सब कुछ।
ओके ओके फाइन, ठीक है।
हाँ ठीक है सर।
All right. Hello, my dear students. Good afternoon, one and all. This is Dr. Kunal Agrawal, your original guru for the subject of orthodontics at DBMCI MDS. So, how was your exam yesterday, guys? How was the exam yesterday? I have got certain mixed reviews, very similar to what I got for the NEET exam. I had heard that the question paper was filled up by orthodontics questions and oral surgery and prosto. There were three main subjects which composed the bulk of the question paper. Am I right? And I believe whatever you have studied in the subject of orthodontics, I hope you were able to answer those questions properly. Right? Is it audible? Am I audible, guys? Please let me know in the chat box. Good afternoon, Taruna, Dadich. Please let me know in the chat box, am I audible? And is my screen visible to one and all? Please let me know in the chat box with a yes, with an affirmative thumbs up sign. Please let me know in the chat box. So yes, I have got one affirmative response. Yes, so I am audible and I am visible also. Perfect. So let's start with INI-CET May 2026 recall of the subject of orthodontics. So as I've been talking about in my recorded lectures, in my live lectures, in my doubt clearing sessions, that there has been a trend change recently since last maybe 2-3 years. Nowadays, the exam setters do not ask any direct questions. They want to test your knowledge. They want to test your in-depth understanding of the subject. They want to know exactly how much grasp of the subject you have had, and how well you can assimilate the information which has been taught to you, and how well you can present that assimilated information in the form of the correct answer, correct choice of the answer. So that has been the trend we've seen recently since last 3-4 years, and we saw the same trend in NEET MDS exam, which was conducted just 2 weeks before, and the same trend was continued in this exam also, which was conducted yesterday. So there has been more emphasis given on the clinical based questions rather than on one liner, rather than on no brainer questions, right? So the very first question said, a patient undergoing orthodontic treatment requires en masse retraction of the maxillary anteriors. Okay, we have talked about this many times using sliding mechanics. So there are two types of mechanics to retract the anteriors. One is sliding mechanics, one is loop mechanics. So sliding mechanics is also known as friction mechanics. Loop mechanics is also known as frictionless mechanics. Okay. Despite adequate anchorage preparation, including stabilization of maxillary second molars, what they mean to say is that they have included the maxillary second molars in the strap up, in the setup, in the orthodontic setup, right? The posterior teeth still demonstrate mesial movement during space closure. So there is always an anchor loss. I have told many times that anchor loss is inevitable. You cannot avoid that at all. It will happen no matter whatever you do. It is going to happen. The only thing what you can do is to minimize that anchorage loss. Okay. Which biological or mechanical principle best explains this phenomena? Is it Newton's third law of motion? Differential force theory? Third option was not properly recalled. And the fourth option was inadequate moment to force ratio. Now, we have talked about this in the notes. It's very well given in the notes. See here. We have talked about the Newton's third law of motion, that is law of action and reaction. To every action, there is equal and opposite reaction, right? I've also explained this concept in different clinical situations also. One of the clinical situation was reciprocal anchorage, and the other clinical situation was stationary anchorage, and all other types of anchorage also. In a way, I have explained this very figure in the recorded and live lectures many times earlier, that whenever you want to retract the anteriors bodily, the question is talking about sliding mechanics particularly. They are not using loop mechanics, mind it, right? So if you are going to retract the anteriors bodily, the type of anchorage what you will employ is called stationary anchorage. Okay, so stationary anchorage, you want minimum movement of the posterior teeth of the anchor unit. But with minimum movement, I am not saying that the movement does not occur at all. The movement does occur. Maybe a little bit less than the anterior teeth, but the movement is going to occur. So this phenomena is explained by the principle of Newton's third law of motion, that is, to every action, there is equal and opposite reaction. Okay, guys, that was the very first question, and very clearly mentioned in the notes also, and discussed many times in the chapters on anchorage and in the principles of biomechanics of tooth movement also. Okay, so there should not have been any doubt while answering this question. Okay, so next, let's come to the next question. Identify the bite and the best time to treat it. So this was an image-based question. This was the clinical situation given to you. So in the clinical situation, you can very well see that the patient has an anterior crossbite. The patient has an anterior crossbite. The patient also has a buccal non-occlusion about this premolar. It's not contacting any other antagonist tooth, right? So that is known as buccal non-occlusion. Now, I am assuming that this patient is in the mixed dentition stage. Mixed dentition stage means the patient is in the growing stage. Yes or no? So when the patient is in the growing stage, when the patient has reached the circumpubertal growth period, when there is plethora of growth hormones in the body, and we want to capitalize on that growth hormone, we want the jaws to grow properly. We don't want any other hindrance in the path of growth of the jaws. And this condition, if it is left untreated, this crossbite, anterior crossbite, if this condition is left untreated, it is going to restrict the forward growth of the lower jaw, rendering the malocclusion as class 3. Okay? So that's why the correct answer should be, it is anterior crossbite, and it should be corrected that the very first time you see it. As soon as it is diagnosed, it should be corrected. Okay, so why am I not choosing other options? Buccal bite, no treatment; Brody's bite, surgical treatment later; or scissor bite, late adult life. So, question is particularly asking about the best time to treat it. It is not telling anything about the timeline of the treatment. It's simply asking what is the best time to treat this kind of malocclusion clinically. That is what the question is focusing on, right? So this scissor bite, of course, yeah, it is a buccal non-occlusion. This particular tooth is not going to help in the mastication of the food in any way, but it's not mandatory to treat it right now. It's not mandatory for the orthodontist to treat it as soon as it is discovered in the patient's mouth. It can be treated very well later on. But here, again, I'm stressing the question is particularly asking about the best time to treat it. Means there is some urgency in treating that malocclusion. So, these are certain small hidden clues in the question. What is that? What is the mind frame? What is the mindset of the examiner while setting the question? You have to guess that actually. So, according to the language of the question, according to the mindset of the exam setter, what I can infer, the best answer according to me should be option C, that is anterior crossbite. It is corrected at the very first time you discover it. Again, this has been talked about extensively in the notes. You can see here, we have talked about developing anterior crossbite. What is the etiology behind it, right? then this is the very similar clinical situation what was asked in the exam, what is presented to you just now, what the clinical situation which I just presented to you. So this very figure has been given in the notes. It has been talked about in the discussions many times. This was one of my own cases. I have treated clinically at my own clinic, and also I have talked about the treatment. We have talked about treatment of developing crossbite. We have also talked about the treatment of developed crossbite during my lectures, and it's very well written in the notes also, right? So for developing crossbite, we have to go for tongue blade therapy. Whereas for developed crossbite, we have to go for inclined plane or Catalan supplants. Or we can also go for fixed orthodontic treatment. So the objective is to relieve the maxilla from growth, relieve the maxilla from any obstacle in its path of growth. And that can be done by treating the crossbite right now, right there itself. Okay? It is a clinical question basically. Next, this question was asked from the chapter on cephalometrics. So the question asked, identify the angle and the relationship it represents. Very, very simple. It's a no-brainer. Very simple. Talked about many, many times. So this question also has been talked about many times earlier. So what is the angle? We have A and B angle. This is A and B angle. And what kind of relationship does it represent? It represents the sagittal growth of the jaws. It represents the relationship of the maxilla with the mandible in the sagittal plane, in the anteroposterior plane. It does not talk anything about vertical plane. It is not an SNMP plane. SNMP planes means the mandibular plane in relation to the SN plane. It is not showing that. So the correct answer is A and B angle, and it represents the sagittal relationship between upper and lower maxilla and mandible jaws. Guys, are you able to understand? Am I audible? Please let me know in the chat box. Are you with me? There are only 8 attendees right now. So please let me know if you're able to understand this, what I am talking about. So I have talked about A and B angle extensively in the chapter on cephalometrics, and the subtopic is Steiner's analysis. It's an integral part of Steiner's analysis. So there are 3 angles, SNA angle, SNB angle, and the difference between the two angles, that is A and B angle, which show the relationship of the maxilla to the mandible, which shows anteroposterior discrepancy of maxilla to mandible, and the mean value is 2 degrees. Very, very clearly written in the notes, and many times discussed in the general discussion, in my live lectures, in my recorded lectures, in my doubt clearing sessions, on the Telegram group as well, doubt clearing group as well. So this was a no-brainer, simply. And also I've mentioned the figures also for your reference. So these figures have been taken from a standard textbook called Jacobson. Alexander Jacobson was the name of the author of that textbook. So these figures are directly taken from that textbook. Okay. Now, this was a little difficult question, I would say. Which of the following is not used in soft tissue profile analysis in orthodontics? Is it Z angle or Z line, whatever the question was, S line, Powell's analysis, or is it the meridian plane? Now, what is Z line basically? You must be knowing about that. So this line is showing the procumbency of the lower lip in relation to the pogonion, in relation to the chin. So we draw a line from the pogonion, soft tissue pogonion I'm talking about. We draw a line from soft tissue pogonion through the most anterior point on the profile of the lower lip, and the relationship it forms with the Frankfurt horizontal plane, this is called Z angle, and this plane is called Z line. And this is an integral part of a cephalometric analysis called Tweed-Merrifields analysis. So this does show that, this is one of the analysis for assessing the soft tissue profile of the patient. Okay. So question is asking not used. So Z angle, Z line is of course used. S line. What is S line? It is a soft tissue analysis by Steiner's analysis, right? So what is S line? I hope you know that. So we draw a line from the pogonion to the S-shaped profile formed between the pronasal and the subnasal. That means this point, S point, it divides the columella into two halves. The midpoint is taken as a point, and we draw a line from the soft tissue pogonion to the midpoint of that S-shaped curvature of the soft tissue profile of the nose. So that is known as S line. This is again one of an important part of diagnosing the procumbency of the lips by Steiner's analysis. So S line was also used. Powell's analysis. Powell's analysis, it is not in the syllabus, first of all. So, and it is also used as a cephalometric analysis for soft tissue profile. But what is not used, that is the meridian's plane. What is meridian's plane? You draw a line from nasion to the pogonion and you orient it at 90-degree angle to the Frankfurt horizontal plane. So this particular line, it shows the relative procumbency or recumbency of the lower lip, of the lower chin in relation to the forehead, in relation to the Frankfurt horizontal plane basically. It does not per se give any information about the lip structure. It does not give any information about the harmony of the lower third of the face. It does not give any information about the positioning of the lips. Okay, it just shows how anteriorly or posteriorly the mandible is related in relation to the upper face or to the Frankfurt horizontal reference plane. That is what it shows. It does not show the procumbency, recumbency, aesthetic harmony of the lips with relation to the rest of the face. So by exclusion, option D, that is meridian's plane, will be the correct answer. Right? Okay. Again, there was one more question, a clinical question. It was a question on clinical interpretation of A and B angle, what we just saw 2 questions back. The question was, a patient has an A and B angle of 8 degrees, whereas the normal value is 2 degrees. Which of the following findings can explain this cephalometric relationship? Very, very simple again. If you have a proper understanding of the concept, and I have been telling this time and again during my lecture, during my morning motivation sessions, during my all kind of interaction with my students, I've been telling this again and again. So whenever you come across such questions, the very first thing you should do is to read the question thoroughly, maybe once, maybe twice, maybe thrice sometimes. Just pause for a while, assimilate the information in your mind, draw a picture of the question in the mind, frame an answer in the mind first, stick to that question, stick to that answer, and then look at the options. That is the correct way to approach an MCQ, any MCQ of any subject, not only orthodontics, any subject. That is my personal suggestion to you. I have been doing this when I was studying. Nobody suggested this to me. You know, that time we did not have this kind of hand-holding support from your mentors, from your teachers. Everything had to be done by ourselves. You know, we were completely on our own. Of course, there were certain test series, some crash courses. People used to attend those random, random things once in a while, often. But we had to rely mostly on self-study. So whenever we used to get stuck anywhere, we used to go back to the textbook, open up the relevant chapter, open up the relevant topic of that chapter, read one paragraph above it, read one paragraph below it, understand the concept, clear the doubt, mark the correct answer, and then we used to move forward. But now the things have changed. You are lucky that you are in 2026. You have got hand-holding support from all the faculties at DBMCI who are there with you all the time. Whenever you need us, you just need to ping us. You just need to tag us on the Telegram group, and all your queries and doubts will be looked into. Okay. So, A and B angle of 8 degrees, That means either the point A is in the front or the point B is at the back. Either the maxilla is prognathic or the mandible is retrognathic. It can be either of the two, right? So let's look at the option again. So as I said, we can have maxillary prognathism, or it can also suggest mandibular retrognathism. It does not show maxillary retrognathism, neither it shows mandibular prognathism. For that, the A and B angle should have been -8 degrees for C and D options to be correct. But we have A and B angle of +8 degrees. So that means the correct answer will be A, 1 and 2. It should be 1, 2, 3, and 4. It's a multiple correct choice question, basically. So the correct answer should be A, 1 and 2 only. Again, this is a clinical interpretation of the same. It shows the relationship of the maxilla to the mandible where the mean value is 2 degrees. Anything more than 2 degrees means either of the jaw is at fault, right? So in this situation, you can see here the SNA angle is 91 degrees and SNB angle is 77 degrees. So that's so much of difference between the two. So that shows the maxilla is at fault in the first case scenario, and the second case scenario, the mandible is at fault. The mandible is severely retrognathic. Okay, so that's the thing about answering such questions. Just try to visualize what the question is asking in your mind. Open up the chapter. Remember me, I taught you. You have read about this chapter. You have read about this particular topic in the exam hall. And then you should be able to answer those questions without any doubt. Okay. Next question. Statement number 1 says a proper lower impression should record all teeth and the retromolar pad. Fair enough. This is a valid statement. Statement 2 says a good lower impression made with proper technique records the entire alveolar process and the deepest part of the vestibular sulcus. So yes, again, we have talked about this in the chapter on model analysis. But the only thing I did, I talked about the characteristics of a model making in general for both maxilla and the mandible, not particularly for the maxilla, neither particularly for the mandible. What I told you that what should be the characteristics of a good model making technique. So I had told you in my recorded lectures, in my live lectures, that whenever you take a model, whenever you take an impression of the jaws, it should record all the teeth. Number 1, it should record all the soft tissues. Number 2, it should record all the deepest sulcus. So that's why nowadays we have got rim lock trace, even though that was initially used for agar hydrocolloid impression materials. But still, nowadays we also have certain good quality impression trays which can be used to take impression from either alginate material or polyvinyl siloxane materials. So those trays, those impression trays are made in such a way which are designed to record the deepest part of the vestibules and the retromolar pad area of the mandible also. I have told specifically about this impression making characteristics in my lecture on model analysis, and very well it is written in the notes also. Okay, right? So what should be the answer? That both options are correct, both statements are true. So for question number 6, option A, that is both statements are true, should be the correct answer. Twin Block is saying, so good to see you. Thank you, Twin Block. I don't know your real name, so I'll address you with this only. It's good to see you too also. So he's also asking me where we also did self-study for ortho. Okay, perfect. So you did self-study for ortho. That's perfect. That's very, very, it's a very good, it's a very encouraging thing to read such comments, that you were able to crack the exam just by self-studying. That's the only thing I want from all of you. I'm of course there with you guys. I'm associated with DBMCI since last 3 years. This is my 4th year now. So I just want to give back to the society, whatever society has been blessing me with. I want to give all of it back to my students, genuinely. Okay, so the question number 7 says, which of the following does not significantly affect the force delivered by NiTi coil springs? So these are the NiTi open coil springs. That's what it's asking. It can either be open coil spring or it can be closed coil spring. Open coil spring does what? It opens up the space. It's used for space gaining. And closed coil spring does what? It retracts the anterior. It retracts the anterior teeth. So irrespective of whether it is open coil spring or a closed coil spring, the important thing here is that it is made up of NiTi material. And nickel titanium, you already know, it's a superelastic material. Okay. Okay, Twin Block is saying, abhi crack nahi hua, sir. Don't worry, you will crack it, I'm sure. You are just going to crack it. And Taruna is asking me, sir, if in state 1, if only as mentioned, it would have been false. One second. If statement number 1, one second. A lower impression should record all the teeth and the retromolar pad. I didn't understand the question. If in statement 1, if only is mentioned, then it would have been false. Only, I didn't understand the question, Taruna. Can you please be more specific? What exactly is it that you want to ask me? Okay, in the meantime, let's come back to the same question. So I was saying, irrespective of whether it is an open coil spring or a closed coil spring, we have to concentrate on the material by which it is made. So it is made up of NiTi, which is one of the most superelastic material ever used in orthodontics. Now, question is saying which of the following parameters does not significantly affect the force delivered by NiTi coil spring? Is it lumen size, length of the spring, amount of activation, or the modulus of elasticity? So modulus of elasticity is important because it is a material specific property. Nickel titanium being very flexible, so the modulus of elasticity will be less. And if the spring is made up of stainless steel, so naturally stainless steel being a stiffer material, the modulus of elasticity will be more. So it does affect the rate of force delivered. Amount of activation. So yes, if you are, so this is the original size of the spring, let's say the original size of the spring is 10 millimeter, for example. And the interbracket distance, for example, I'm talking about open coil spring. And the interbracket distance is, let's say, 6 millimeters. And you want to open up the space. So you will be activating it, you will be compressing it from 10 millimeter to 6 millimeters. That means you have achieved a 4 millimeter compression with an objective of opening 4 millimeter of space between two adjacent teeth, right? So if you compress it even further, instead of 6 millimeters, you want to compress it till 5 millimeters. So the amount of force exerted will naturally be more. Yes or no? Just think about it. Or in case of a closed coil spring, if you are extending it from 10 millimeters, you are making it 15 millimeters. You are stretching it for the purpose of retraction. So you will achieve 5 millimeter retraction. So that 5 millimeter retraction is that excessive length of the spring is going to exert that much amount of force on the teeth with the purpose of retracting the anterior teeth into the correct space. Yes or no? So that's it. Amount of activation is significant. So that will not be the correct option. Length of the spring. Again, the lengthier the spring, the range of action of force will be less and vice versa. So again, this will be a significant factor. However, out of exclusion, the lumen size will not directly affect the net force delivered by NiTi coil springs. I have mentioned this particularly in the chapter on materials used in orthodontics. So the subtopic was orthodontic wires. In that I have explained the Hooke's law. Also, I have mentioned this particular formula for you to remember, and it is taken as a very important base reference. So all such kind of questions can be answered if you remember this formula correctly. This is an important formula. So the force exerted, it depends on the fourth power of the diameter of the wire, and it inversely depends on the cube of length of the wire as well. And it also depends directly upon the modulus of elasticity of that particular appliance, of that particular material. Number one. And number two, I've mentioned that if the diameter of the wire is doubled, how is it going to affect the different characteristics? The strength will be increased by 8 times, the stiffness will be increased by 16 times, whereas the range of action will be reduced by half. And if we increase the length by twice, what will happen on the strength? The strength will reduce by half, the stiffness will reduce by 8 times, whereas the range of action will increase by 4 times. So these are the 3 formulas which you should remember by heart. They are very, very, very important formulas. If you have these formulas on your fingertips, I'm sure you will not face any single difficulty in answering such questions related to mathematical equations when it comes to talking about force exerted by lengthening the wire or increasing the diameter of the wire and questions like that. You will not face any difficulty. So this also has been mentioned clearly in the notes. Okay. Okay, 1 second. I have a question. Teeth and retromandibular are recorded only. Okay, let's come back to that question. What Taruna is asking me. Statement 1 says, this is the statement, a proper lower impression should record all teeth and the retromolar pad. A proper lower impression should record all teeth and the retromolar pad. If in statement 1, if only is mentioned, then it would have been false. Teeth and retromolar are recorded only. No, actually, only, let's say if only is written here. So, I mean, it will not make any difference. It's not going to make any difference. The statement will say a proper lower impression should record all teeth and a retromolar pad only. Well and good, fair enough. It does record that, no? It will not be false. It will be true even in that situation. Right, Taruna? Next question. Which of the following is a common source of error in lateral cephalometric radiography? Again, a no-brainer. Increased exposure, low intensity, patient positioning, or overlap of landmarks. So, increased exposure should not be a problem because any kind of exposure, if you increase it, you will have radiographic noise, maybe, or maybe the high definition of the image will not be obtained properly on the X-ray film. So that is not a common source of error. It doesn't happen that frequently. Low intensity, again, will not make much difference as a source of error. Patient positioning, no, the technician will position the patient properly in the cephalostat. The patient will be oriented according to the natural head position. And then the radiograph will be shot from the right side of the patient. But however, it's the overlap of landmarks which is a problem, which is a potential problem, because we are actually in a lateral ceph, we are shooting a 3-dimensional craniofacial structure and representing in 2 dimensions. So there are very many chances that there could be structural overlap from different structures because the anatomy of the orofacial structure is very, very complex. There are going to be multiple overlaps of one structure over the other. And that I have mentioned in the notes as well. See, what are the limitations or drawbacks of cephalometrics? So, one of the errors of identification is the difficulty in locating landmarks and surfaces on the radiograph as the image lacks hard edges and well-defined outlines, and the structures being imaged are 3-dimensional, whereas the radiographic image is 2-dimensional. There could be projective displacement, means there could be magnification errors also. Magnification errors. So this is what magnification error is. So I have mentioned this also. There could be structural overlap of different structures. Okay, So correct answer should be option D, that is overlap of anatomic landmarks. Okay, I have a question. Only was anyways not in the statement. No, it will not be false, Taruna. Sir, then it will be false. No, it will not be false. Because, any kind of mandibular impression is going to record the complete teeth, the dental-alveolar structures, the vestibular depths, and the retromolar pad also. It's not only, the impression cannot record the teeth only. It cannot simply record the retromolar pad only. Both the structure will be recorded simultaneously, right? So how can you place only word? That's my question to you. Okay, so I don't think it's going to make any difference. The statement will be correct anyways. Okay, let's come to the next question. A 9-year-old child undergoing orthodontic treatment is given the appliance shown in the picture. What is the primary function of this appliance? So before answering, you have to know what appliance is that. Can you tell me what appliance is that in the chat box, guys? In the meantime, I'm going to read the options for you. It protects the lips and mandible from external forces. It maintains arch length by eliminating lower lip pressure on the mandibular incisors. It retracts the maxillary incisors by applying the posterior forces. And it intrudes the posterior teeth to correct deep bite. First of all, you should know what exactly is the question about. What exactly is the appliance the question is asking. Can anyone guess me? Can anyone guess what this appliance is? We have talked about this in the lectures, in the notes. It's given in the notes with proper diagrams also. It's there in the notes, right? So can anyone tell me what appliance is this? Can anyone tell me what appliance is this? So this appliance is known as lip bumper. This appliance is known as lip bumper. Okay, and it uses muscular anchorage basically to distalize the molars. Also, that is the secondary use of this appliance basically. The primary use is in correction of lip trap habit. And lip trap is a characteristic feature of class 2 division 1 malocclusion, correct? That's a condition when the lower lip comes in between the palatal surface of the upper anterior and the labial surface of the lower anterior. So this part of the lip, this black color is what undergoes lip trap. So to make the lip free from the lip trap, we have to use this appliance called as lip bumper. Now, how does it work? It keeps the lower lip away from the teeth, from acting on the teeth. So it is actually eliminating the muscular forces of the lower lip from acting on the lower arch. So because of that, the lower arch had a tendency of becoming flattened. But as soon as you give this appliance, the lower arch has a tendency to become ovoid again. So you can say when the lower teeth have become flattened, the arch length has reduced. But when it becomes ovoid again, you can see the arch length has gained its original dimensions. So basically, the primary purpose is to shield the lower lip from inadvertent muscular forces of the lower lip. So it maintains the arch length by eliminating lower lip pressure on the mandibular incisors. That is the primary function of this appliance, and in a way, it makes the lip free from the trap. That is the main function of this appliance. So again, this has been talked about in the notes, in the muscular anchorage, and also in the chapter on interceptive orthodontics. I don't have that screenshot right now. So this particular appliance has been mentioned about at 2 different places in the notes. One is in the chapter on anchorage and another in the chapter on interceptive orthodontics. Okay. Next question. Okay, one option was molar distalization. Okay, let's say molar distalization. So as I said earlier, molar distalization is a secondary function of this appliance. It is not a primary function. Whereas option number B is the primary function of this appliance. Clear? Next question. PSF represents a certain kind of malocclusion. It's an image-based question. What is the cause for that? Now let's examine this figure. What malocclusion this figure is showing? So there are two lines. One is a yellow line and one is a red line. So what is the significance of these two lines? The yellow line is called the facial midline, whereas the red line denotes the dental midline. You can see very well that these two midlines are not coinciding. Matlab, there is some problem within the jaws, and most commonly the problem lies in the lower jaw, because the dental midline of the upper teeth is coincident with the facial midline in the maxilla. So the maxillary jaw is not at fault. It's the mandibular jaw which is at fault here. So now you know the diagnosis. You know what is the cause of the diagnosis. Now let's look at the option. Early eruption of mandibular molars, bilateral condylar hyperplasia, early loss of primary incisors, or is it the functional mandibular shift during skeletal development? So what do you think should be the answer? Early eruption of mandibular molars doesn't make any sense. Bilateral condylar hyperplasia, in this case the midlines would have been coincident. Had the option been unilateral instead of bilateral, then I would have to think about it. Yes, in that case, this could have been an option. This could have been the correct choice. But the question is saying bilateral, so we will eliminate it. Then comes early loss of primary incisors, and option D is functional mandibular shift during skeletal development. So option D makes the correct answer. So whenever you have any functional mandibular shift which is not taken care of during the early growth of the skeleton, there could be a permanent shift of the jaw to one side, as you can see in this PSF, and that is the root cause of mandibular asymmetry in the face. Okay. So this again I have talked about in the chapter on supplemental diagnostic aids. We have talked about anteroposterior cephalogram. So whenever you have a mandibular defect, the analysis which can be used is Grumman's analysis and Ricketts analysis. They are not in your syllabus. I have just mentioned the names. And in the notes in the lecture, both recorded and live, I have specifically talked about these two analyses, mentioning that both of these analyses are used for assessing the skeletal asymmetry quantitatively. You can know exactly by how much the asymmetry is. So that's a quantitative means of assessment using these two analyses, Grumman's and Ricketts. So it is given in the notes properly. Okay. Next, a transverse quad helix appliance typically delivers a reverse orthodontic force in which of the following range? Now, this is a controversial question because I have mentioned in the notes that the average force given by quad helix is 200 to 400 grams. That's the average amount of force given by quad helix appliance. Okay, so it could be 200, it could be 250, it could be 300, 350 or 400. That's the range of force which can be given by the quad helix appliance. Now, it all depends again. You know, some questions have to be left for luck. Actually, there are certain controversial questions. So it could be 200 gram, it could be 250 gram also. Both options are correct. But as I said, some questions are better left for luck. So, but still, most of the textbooks and most of the MCQ books I have checked, I have cross-referenced, they have given 200 gram as the correct answer. But again, I would repeat myself, both option C and option D are correct. It's at the discretion of the exam setter which option he chooses as the correct answer. Okay, so let's just wait and watch for this question particularly. A patient is undergoing clear aligner therapy for extrusion of maxillary lateral incisors. Despite multiple refinements, the desired movement is not achieved. Means the aligner is not tracking particularly in the maxillary lateral incisor area. Although the patient is compliant. Sorry. What is the most likely reason for failure? Failure for tracking of the aligner. That's what the question is asking. Plastic material does not generate sufficient vertical extrusive force. So it does generate. We can use certain attachments, we can use certain bite ramps, and extrusion can be attained. But yes, one thing about extrusion, it is one of the most complicated tooth movements to achieve clinically by aligners. But yes, by using certain proper attachments, we can achieve some amount of extrusion. So option A is not the correct answer. Aligners act only effectively on posterior teeth. Lack of effective control for complex rotational vertical tooth movements, and aligners cannot produce any vertical tooth movement. So they do produce intrusion. So option D is out of the question. Option A is also out of the question. Option B is also out of the question. The correct answer will be option C. That is, aligners have a lack of effective control for complex rotational vertical tooth movements. So it is difficult for aligners to correct rotation beyond 45-degree angulation. And it is also difficult for aligners to extrude the tooth. Okay. Again, this has been talked about in the chapter miscellaneous in the notes, chapter number 30th. But this time, this academic session onwards, I have separated orthodontic aligners from rest of the chapters. I have made a separate chapter, which will be included in the next edition of the notes properly. So which are the highly predictable tooth movement? Space closure, 2 to 4 millimeter buccal expansion, incisor rotation, low incisor extraction, moderate predictability, root torquing, distalizing, mature teenager, less predictable, extrusion with no retraction, severe rotations of premolars and lower canines. So these are the two areas which are little problematic while treating with aligner treatment, treatment with aligner therapy. So the correct answer will be lack of effective control for complex rotation vertical tooth movement. Identify the plans with bite block angulated at 70 degrees. So again, this is a no-brainer. Very, very simple question. So this, if this was the exact figure asked in the exam, this was a confusing figure. For me, it was confusing in the very first glance. So it was only after I saw this image for the second time, I could identify what appliance is that. So this is a twin block. This is a twin block along with a jack screw in between, which has a provision of transverse expansion of the maxillary arch. Okay. So you already know that twin blocks, the inclined planes are angulated at 70 degree. So there should not have been any problem in answering this question. So this has been talked extensively in the chapter on myofunctional appliances in the notes. So it's written here, the upper and lower blocks are inclined, are interlocked at 70 degree angle and are designed for full-time wear. And this is the figure of the twin block also. The only difference is that in the notes, the acrylic figure was pink, whereas here the acrylic is clear. That's the only difference, right? So this is a no-brainer question. Very, very simple question. A patient requires canine traction of a single tooth with distal control or activation. Which orthodontic loop design is most appropriate? Now, loop design. Now, loop design is not in your syllabus. As I said earlier, you know what's the hard reality of such questions, such exams, such competitive exams? The exam setters do not want you to pass in that exam. They want to exclude you. That's the harsh reality, you know. So they will always put one or two questions which are bouncers, which will go high above your head, which you have never heard of ever. It always happens in all the exams. So unfortunately, this was one of that questions. So this loop mechanics is in the PG syllabus, not in the UG syllabus. Okay. So what is the correct answer anyways? I'm going to tell you. Stop band, vertical loop, box loop, or a horizontal loop. So the most, so the loop which requires, I mean, the loop which can retract the canine with distal controller activation is the vertical loop. It is the vertical loop. So that was out of the syllabus, I told you. Next question. A patient is undergoing orthodontic treatment for closure of a midline diastema in the maxillary arch. Inter-arch elastics are being used along with fixed mechanotherapy for space closure. What type of anchorage is being utilized? So this was a image-based question. Very well, it is seen here. It's a midline diastema, and there are two brackets bonded on two adjacent incisors. A small sectional wire has been placed, and the two teeth are being brought together by elastics. So it's a no-brainer. It is not intermaxillary, it is intramaxillary, first of all. It is Baker's? No, it is not Baker's because it is neither class 2 elastic nor class 3 elastic. Is it stationary anchorage? No, because we are not causing any bodily tooth movement of the, we are not causing retraction of the anterior teeth taking support from the posterior teeth. So what is left? This is simply reciprocal anchorage. Again, it has been talked about in the chapter on anchorage in orthodontics. I have the figure also in the place, and it follows Newton's law of equal and opposite reactions. Okay, so this is the figure I was talking about. This figure clearly shows that a midline diastema is being closed by pulling the two teeth towards each other, and it follows the principle of reciprocal anchorage. The correct answer is C, reciprocal anchorage. Now, this question was asked, again, this was straight out of my notes. Again, a no-brainer. Image shows cephalocaudal gradient of growth. Which of these statements is true? Again, it's a multiple choice question. At 3 months of intrauterine life, the head takes about 50% of the total body length. Of course, this is 100% true. At birth, this proportion changes to 25 to 30% of the total body length. Again, this is true. This simply means that the direction of growth is from legs to the head. It is from head to the legs, other way around. So the option C is false. Option D, lower limb proportion increases progressively with age. Absolutely true, because we have seen the farther the structures are from the base of the skull, the farther the structures are from the brain, the tendency of the growth, the rate of the growth, and the duration for which those structures grow will be at a higher stage as compared to the structure which are closer, which are in close proximity to the base of the skull. That is the only interpretation of cephalocaudal gradient of growth, right? So we have A, B, and D as the correct answer. A, B, and D as the correct statements. See, it is written here. I've mentioned that I have given that figure. So this figure has been taken directly from the textbook of Dr. O.P. Kharbanda. This is a standard textbook for orthodontics, right? So at the third month of intrauterine life, the head takes about 50% of the entire length of the body. At birth, it is around 25 to 30%, whereas during adulthood, that percentage reduces from 25 to 13%. But does that mean that the head is reducing in size? No. It means that the length of the lower body is increasing in size because the lower limb, the abdomen, the trunk, all these structures are lying at a certain distance from the base of the skull. You can see here from 16 to 25, 35, 48, and finally almost 50% of the entire length of the body is composed of the lower limb. So this is the only interpretation of cephalocaudal gradient of growth. It can also be seen in the face, the mandible being at a certain distance from the base of the skull as the maxilla, it tends to grow for a longer period of time as compared to the maxilla. Okay, so this was a direct pickup from the notes. You should have been able to answer this properly. Now, this question, again, I want to congratulate all of you for all those who have studied my notes thoroughly, for all those who have properly given proper attention to all the figures I have placed in the notes. This was exactly what I put in my notes. What does the picture below depict? Question was, is it rotation at condyle, intramatrix, and rotation at body is called matrix rotation. Rotation at condyle is called matrix and rotation in the body is called intramatrix. Rotation at condyle matrix, rotation in body matrix, rotation in condyle intramatrix, rotation in body intramatrix. Again, this has been given in the notes and the exact figure. This is the exact figure I'm talking about. And this figure has been taken directly from the textbook of Contemporary Orthodontics by William R. Prophet. Very, very important now. This topic has become very important now. Right? So there are two situations. If the rotation occurs in the condyle, in the condyle, so that is known as matrix rotation. And if the rotation, if the point of rotation, the center rotation is centered within the body of the mandible, so that is known as body of mandible, that is known as intramatrix rotation. So again, I want to congratulate all of you that if you were able to recall this very figure, you would have been able to answer this question without any doubt. So, so the first is rotation around the condyle is called matrix rotation. Rotation around, rotation centered within the body of the mandible is called intramatrix rotation. So option B will be the correct answer in this situation. Okay. Again, this figure is taken exactly out of the notes. Again, very, very simple question. Determine the type of force according to the graphs. So these were the three graphs given. You have to identify that which graph holds true for what situation. Okay. So the first graph is for continuous forces. There are three types of forces given in the chapter on biology of tooth movement. Right? Second is interrupted forces. And the third is intermittent forces. Three graphs, three different types of forces. You have to identify which one is that. So graph A shows it is continuous. Graph B shows it interrupted, and graph C shows it is intermediate. It's not intermediate actually. It is intermittent. It's not intermediate, it is intermittent. So this is the exact figure I have shown in the notes in the chapter on biology of tooth movement. So this is for continuous forces. This graph. The second graph is for interrupted forces. And the third graph is for intermittent forces. Again, these three graphs have been taken from the textbook of Contemporary Orthodontics by William R. Prophet. Direct pickup from that book. Okay. So the correct answer will be option A. Continuous, interrupted, and intermittent forces. Also, I mentioned the examples. So continuous forces, what do they do? I mentioned the examples in the notes also. If you look at the notes properly, you will find all the examples of these different types of forces. What would be Tanaka-Johnson's model analysis? Mathematical equation for calculating maxillary excess tooth material. So this is one of the model analysis used for mixed dentition. Mixed dentition. Okay. Now, what is Tanaka-Johnson analysis? Again, it has been talked about in the notes in the chapter on model analysis. This is exactly what I've mentioned in the notes. And also I've given the mathematical equation also in the mandible and in the maxilla separately. So in the mandible, you have to divide the value obtained by 2. First of all, you have to calculate the mesorisal width of mandibular incisors for prediction of size of unerupted canine and the premolars. So all the mandibular incisors width have to be calculated. So you have to calculate 2112 lateral, central, central, lateral. You have to combine the mesorisal width of all the 4 teeth in the mandible. You have to divide the obtained value by 2 and add 2.5 and add 10.5 to obtain the sum of widths of mandibular, canine, and premolar in one quadrant, number 1. In the maxilla, you have to divide the value by 2 and add 11 to obtain the sum of width of maxillary canines and premolars in one quadrant. So these are the two values. These are the two mathematical equations. What is there in on your screens? It is very well mentioned in the notes, right? So now let's take a look at the options. The question is asking particularly for the maxillary tooth, for the maxillary teeth. So for the maxillary teeth, the correct answer should be y equals to 11 plus x upon 2. That means where x is the mesorisal width of the 4 mandibular incisors from 2 to 2. Mesorisal width of 4 mandibular incisors. So this is the combined width of canine and premolars in one quadrant. This is canine plus first premolar plus second premolar in one quadrant for the maxilla. For the mandible, only difference is that instead of 11, we have to add 10.5 value for the mandibular teeth. This is for maxilla, this is for mandible. Okay, so I think the options are not proper. So this holds true for the mandible, right? So in that case, the correct answer should be A by 2 plus 11 for the maxilla. If this would have been the option, this would have been the correct option. A by 2 plus 11 for the maxillary dentition. Okay. Bipasha Kumar is saying, I thought of your notes when I saw the question. Thank you, Bipasha. That means a lot for me. Okay. Now, total amount of IPR that can be done in all maxillary teeth combined. Now, this is again a controversial question. One second, what happened? Oh, yeah. So what happens here? Question is asking about all maxillary teeth combined. If the question is asking about maxillary anterior teeth only, the answer would have been different. But here we are talking about all the maxillary teeth combined. So in that situation, the correct answer would have been 8 millimeters. But if the question is asking about maxillary anterior teeth only, means from canine to canine, 6 teeth. So 6 teeth. So the maximum amount of IPR which can be done on one surface, this I mentioned here. You can see here. The interproximal reduction recommendation for the central incisor, both mesial surface, distal surface, lateral incisor, and canine for the anterior teeth. So let's add all of them up. 0.3, 0.3, 0.3, 0.3, 0.3, and 0.6. 3, 3, 3, 3, 3. 15 plus 6, 21. This is 1, 2. And this will be 2.1 millimeters for the maxillary teeth on one side, on one quadrant. So 2.1 into 2, that will make a total of 4. That will make a total of 4.2 millimeters. So if the maxillary anterior teeth was asked as the question, in the question, 4 millimeter would have been the correct answer. Clear? It was not there. Okay, options for this were 6 to 8 or 8 to 10 millimeters. 6 to 8 or 8 to 10 millimeters. So yes, if the option is 8 to 10 millimeters for the maxillary dentition, This would have been the correct answer. Okay. Also, I've mentioned the very same thing in the chapter on methods of space gaining, A rotor stripping by John J. Sheridan. This article was published in JCO in the year 1985. Right? So in this also I mentioned that approximately 6.4 millimeter of space can be obtained, and removing one half of the interproximal enamel between 5 anterior contacts between canine to canine, that is 0.5 millimeter per contact, that creates an additional space of 2.5 millimeter of space. This has been mentioned in the notes properly. Now, next question. A flat facial profile with lip retraction, the least desirable treatment is. For this, you have to understand the concept behind the clinical implication of the nasolabial angle. Again, this has been talked about extensively in the chapter on essential diagnostic aids. I've mentioned many times that nasolabial angle is one of the most important clinical parameter to decide whether extraction will be required in the patient or not. If the nasolabial angle is acute, in most likelihood, extraction will be required. If it is obtuse or if it is flat, the extraction will not be required. You don't want to spoil the facial profile, right? And the nasolabial angle will depend on how well the upper anterior teeth are set in the jaws, in the maxillary dentition. You don't want to flatten the surface of the face beyond a certain limit, right? So what you are going to do? We already have a flat facial profile. We don't want extraction of premolars in this case. Otherwise, the facial profile will become even more flatter. It will be ruined. You don't want to do that. So you are not going to extract any of the premolars if the facial profile is already flat. Okay. A mini screw, when loaded, puts most pressure on which location? So again, I have talked about the description of an orthodontic mini screw in the chapter on minor surgical procedures, chapter number 26 in the notes. We have a screw head, that's transgingival or the thread-free part. It is also called as neck of the screw. Then we have the shoulder or the collar. It's also called collar of the screw. And finally, we have the body of the screw. So these are the different demarcations of the screw. So finite element analysis is called FEM study. They have extensively shown that whenever a mini screw is inserted in the patient's jaws for anchorage purpose and it is activated, the most stress bearing area will be the neck part, the B part. Because the A part, the head part, will be exposed in the oral cavity. The B part is the junction between the head and the rest of the collar, rest of the body of the screw. The C part, collar or the shoulder, is again an attachment between the upper part and the lower part of the body. And D part is called the body, which is inserted within the cortical plate of the bone, either the maxilla or the mandible. So this body part is used to hold the screw in place by primary and secondary integration, right? So according to finite element analysis, multiple studies have been done over that. According to FEM studies, it is the neck part which undergoes maximum amount of pressure when a mini screw is loaded. Okay? So option B is correct here. I think this was an incomplete question. Skeletal maturity indicator in the child. So I think they are talking about hand wrist radiograph. We have talked about hand wrist radiograph extensively in the notes in the chapter on skeletal maturity indicators. We have talked about the biological principle of age assessment. We have also talked about Jock, Graven, Brown methods of analysis. We have talked about the anatomy of the hand wrist radiograph, how many different bones it contains, what is the structural anatomical arrangement of the bones. Then we have also talked about the importance of adductor sesamoid bone. The very appearance of this adductor sesamoid bone in the radiograph will signify that puberty has started. Puberty has started. That is the clinical significance of this particular finding in an X-ray. Okay. So as I said, it could be an incomplete question. Twin block is saying, what's crest? Taruna Dadish. Okay, I'll come back to the question. Twin block is saying sequence was asked. Okay, so can you please tell me what exactly this question was about? What sequence the question was asking? I think they must be asking about. Okay. I understood. It's a multiple choice question, is it, kya? So again, we have talked about that. So first and foremost, the epiphysis is equal to the diphysis. Then epiphysis caps the diphysis. And finally, the epiphysis unites with the diphysis. This is the sequence of ossification of maturation of the skeletal bone. If this was the question, this also has been covered in the notes extensively. In the very same chapter, skeletal maturity indicators, this is already covered in the notes. Okay, but if this is a question which is right there on your screen, it's an incomplete question, I said. So the first answer will be, the sequence will be, I'll say it is the widening of epiphysis, number 1. Then appearance of adductor sesamoid in the hand wrist radiograph, number 2. Then capping of epiphysis, number 3 and 4. So the correct sequence should be C, B, D, and A. That should be the correct sequence. If this was the if this was the question. Now Taruna is saying, what is crest? Where is it written crest? I was talking about the thread part. This goes inside the cortical plates of the bone. This goes inside the cortical plates for anchorage purpose. So the threads go inside the cortical plates of the maxilla and the mandible, and it is the primary stability which is given by the cortical plates of the bone. Okay. Next question, the serial extraction sequence shown in the image is. Now, excuse me. Let's examine the image closely. The dot, wherever the dot is given, that means that tooth is being extracted first. So in the first situation, it is the primary canine which is being extracted, followed by primary molar, and followed by first permanent premolars. So the sequence they are talking about is C, D, and 4. So according to this, the correct answer should be Duell's technique, CD4. Okay. Again, this has been talked about in the chapter on serial extractions in the notes. Very, very easily it should have been answered. So C, canine, followed by first molar, followed by first premolar. First deciduous molar I'm talking about. C, D, and 4. Whereas in Nance and Tweed's method, it is D, it is 4, it is C. D followed by 4 followed by C. But here in this figure, in the first situation, it is the C which is extracted. In the second, it is D followed by the extraction of first premolar. So the sequence is CD4. So correct answer will be Duell's technique, CD4. I think this was not complete. I have a few more questions for you. Let me see. This has been done. This has been done. This has been done already. This has been done. This has been done. This has been done. Yeah, there was one question I think which was omitted. I'll read it from my phone itself. The question is, the patient undergoing orthodontic tooth movement show increased rank L expression on the compression side of the PDL. What is the most likely biological event? So whenever you have more number of rank L, there is always a competition between rank L and OPG, right? I've talked about this extensively in my chapter on biology of tooth movement, if you remember properly. So rank L, what is going to happen? There will be more osteoclastogenesis because more number of osteoclasts will be formed. Whereas OPG, when it combines with rank, it leads to apoptosis of osteoclasts. So because of apoptosis of osteoclasts, the relative number of osteoblasts will be increased. There will be more bone deposition, yes? That's the only job of osteoblasts, right? Whereas the job of osteoclasts is to resorb the bone. So let me look at the options. Increase osteoclastic activity leading to accelerated bone resorption. Increase osteoblastic activity leading to bone formation. Decrease osteoclastic activity with bone deposition. And increase cementoblastic activity with root formation. So what should be the correct answer? It should be option number A, that is increased osteoclastic activity leading to accelerated bone resorption. Okay, that should be the correct answer. Let me see if there is any other question remaining. This has been done, this has been done, this has been done, this has already been done. This was taken in OMR, this has been done. So yeah, only one question was not there in the PPT that I have mentioned. That is question number 20. Which one is that? 25th. This is question number 25. So all in all, there were total 25 questions from orthodontics. And as I said, according to the feedback obtained from different students, the INI-CET May 2026 exam was filled by ortho, prosto, and OS subjects. Okay. So that's all for now. Let me see if there are any other doubts. Just a second. If there are any other doubts, let me check. Let me check. Let me check. No, there are no other doubts. So that's all from my side. Thank you so much, guys. And I'm going to see you in the finish line. Across the finish line. I'll be waiting for you to cheer all of you up. Okay? So that's all from my side. If you have any doubts, you know where to find me. You can ping me whenever you want on Telegram. Just tag the respective faculty and we'll be there to solve your doubts. Thank you so much. Have a great evening. Thank you. Done. 5 बजे तक बोला था ना मुझे उसने मोहित ने.
पर ये बेचारा चल गया ना सब कुछ.
हैं?
मतलब इन्वर्टर चल गया तो उम्मीद बिल्कुल नहीं थी, पता है.
कि बंद हो जाएगा बीच में.
बिल्कुल लग रहा था मुझे,
अच्छा.
क्योंकि सर सुबह से चल रहा है बेचारा वो.
तो क्या कुछ वो चल रहा है क्या? कुछ काम वाम चल रहा है क्या?
सर आज सुबह को मैसेज आया मुझे कि आज इधर भास्कर माय एफएम के आसपास, मतलब जो हमारा वो फीडर है
Nice. Okay. Okay. Hello, everyone. So, am I audible? Please let me know. Hello. So, how was the paper, my dear students? How was the paper? So, it was of moderate level or it was tough. So, I think many of this only 6 questions were from anatomy in the INI-CET exam. So, yes, I think the paper was good enough. Okay, it was many questions were directly asked, 6 questions were there, and I think 4 or 5 questions were directly asked, 1 or 2 questions were slightly twisted. Okay, so, okay, yes, okay. So, yes, everything is fine and we can start the session. Okay, so let me start with the INI-CET MDS examination paper. So, I would like to start with the first MCQ which has been asked. So, cervical branch of facial nerve is injured during paroidectomy and results in loss of, so option where it's A, B, C, and D. So please don't, so this are the 4 options. Okay, these are the 4 options. It will be, these are the 4 options A, B, C, D. Okay, so depression of angle of mouth and lip protrusion, lateral flexion of the neck, and forward flexion of the neck. So this was exactly 4 options. So you have to mark the right answer. And if I talk about the cervical branch of facial nerve, and I have so many times discussed about the parotid gland, and I have shown you the plane also. So you can just see this. This is the screenshots taken from the notes and the classes which I have taken, in which I have explained the 3 planes of the parotid gland, and we have seen the through the anterior border, we have got the terminal branch of facial nerve emerging. So we have talked about this previously also when I was taken an elaborate session in which muscles of facial expression has been discussed. So exactly when I'm talking about the cervical branch of the facial nerve, the cervical branch of the facial nerve will exactly, if I talk about the cervical branch of facial nerve, it will supply platysma muscle. So in this case, they are asking about the platysma muscle, and we know the primary action of platysma muscle is to pull the corner of the mouth. So it is pulling the corner of the mouth, and it is pulling not only the corner of the mouth and that of the lips, so that that facial expression of sadness, surprise, and horror is made. So it is a very important action of platysma muscle. So basically, so that means we are quite clear that the platysma muscle is supplied by the cervical branch of facial nerve. Okay, now in this case,
we can just, so any of the students, I think most of the students has marked how many questions done. Okay. So for anatomy, we have got just 6 questions here, and I'm just starting with the first MCQ. So the primary action of the platysma muscle, as I told you, it pulls the lower lip and corners of mouth down and out, down and out. So if we have to go with the most correct answer, so again, I will move with the cervical branch of facial nerve injured during paratectomy. So basically the right answer will be depression of angle of mouth and the lips. So this becomes the right answer. Okay. So I think this A option is correct. Everyone must have marked that right. Dear students, what have you marked it? Okay, so you can just message in the chat box that what you have marked. So this is the right answer, option A, depression of angle of mouth and the lips. Okay, now coming to the next question, that is question number 2. So we have got just 6 questions to be discussed. This was this was the question. The first question was a direct MCQ only, where they have asked about the action of platysma muscle. First structure to develop from, yes, doctors say you are absolutely right. Yes, first structure to develop from para-axial mesoderm. So I have discussed in the class of 2nd and 3rd week development the 3 germ layers and the derivatives of all the germ layers. Okay, so we have discussed about the derivatives of all the germ layers. So in this question, if I'm talking about this question, mandible, maxilla, and the zygomatic one, all these are. So basically, if I'm talking about all these, here also we will have A, B, C, and D as the option. So here, if I'm talking about A, B, and A, B, C, D as option. So what you have marked? So basically, these 3 bones which you are seeing, that is mandible, maxilla, and zygomatic bone, they are the bones which is arising. So basically, these are the bones listed. Among this listed bone, only parietal will be the right answer, D. Why? I will tell you, because this is the only structure we developed from the paraxial mesoderm. So we know that neural crest migration in the first pharyngeal arch. So the other structures, mandible, maxilla, zygomat, these are formed by the neural crest migration in the pharyngeal arches. So basically, mandible, maxilla, zygomatic bone is formed from cranial neural crest migrating into the first pharyngeal arch. So again, I would like to show you this image. This is taken from the notes. So this is a screenshot which I have multiple times described, and you can see we have talked about the pharyngeal arch derivatives, and we are knowing that the malus, incus, maxilla, mandible, zygomatic, these are all first pharyngeal arch derivative which is formed by the neural crest migration. If I am talking about 2 bones, so and here I have also told you that para-axial mesoderm is giving rise to, we have talked about para-axial mesoderm which is giving rise to myotome, sclerotome, and the dermatome. So when I am talking about the sclerotome, okay, so when I am talking about the sclerotome, so we are talking about the para-axial mesoderm, which can further will be forming derivatives like para-axial mesoderm will form the somatomeres, will form somites, and they will further form sclerotome, dermatome, and myotome. So basically, if I am talking about para-axial mesoderm, there is an important point that when I am talking about the sclerotome component, the sclerotome component will give rise to the axial skeleton. And basically, if I am talking about the important structures being born, so basically, if I am talking about the para-axial mesoderm, it is forming the cranial base. So it will in the axial, it forms the vertebrae. So it will form the vertebrae, it will form the axial skeleton. So it forms occipital and the parietal bone. So basically here in this, we have got an option as the parietal. So definitely we will go with the parietal as the right answer. Is it okay? So who have marked it as right answer, please let me know. Yes. So Dr. Say is telling D, parietal. Yes, parietal is right here, because how to come to a right answer is that the first 3 option, mandible, maxilla, zygomatic, is by the neural crest cell migration. So obviously the question is asking about the first to be formed, para-axial mesoderm. In that case, occipital and parietal bones will be the right answer. Here parietal is the option, so we will go with D as the correct answer. So mark it right. So this 2 questions has been done. Let's move on to the next MCQ, that is MCQ number 3rd. Actually, this I think 100% students must have done. Okay, doctors say, just see here, adenoid is located in which part of aerodigestive tract? Oropharynx, nasopharynx, oral cavity, hypopharynx. So exactly, this was a very easy one, and the correct answer was nasopharynx, and this is directly from the notes. So this is a very easy, I think most easy question of anatomy was this only. We know that there is nasopharyngeal tonsil. So basically this I have taken, this image I have taken from the notes. So you can see here, this is the image which I have taken from the notes when I have taken your class. There I have shown you the tubal tonsil and also the pharyngeal tonsil. So what you can see, if I'm talking about the pharyngeal tonsil, just see. Okay, if I'm talking of the pharyngeal tonsil, it is located posteriorly and close to the roof in the nasopharynx. So the location is nasopharynx, and enlargement of the nasopharyngeal tonsil will lead to the condition of adenoid. So you can see this was also directly written. I have explained you what is nasopharynx. It is located behind the nasal cavity above the soft palate, and there is the content of nasopharyngeal tonsil which is called as adenoid. So this was exactly asked in INI-CET 2026 examination, and you can clearly see that adenoid is the enlargement of nasopharyngeal tonsil. And other structures which is found in the nasopharynx were opening of auditory tube, that above the tubal elevation, on the tubal elevation, and we have got the aggregation of lymphatics, lymph nodes which form tubal tonsil, also pharyngeal recesses. So this was the easy one, and I have also explained the clinical anatomy where you are knowing that when adenoid is formed, it can cause breathing problems in small children, and in very large adenoids, surgical management of the case has to be done. If the small children is having mouth breathing, epistaxis and all. So is it okay, everyone? Adenoid is a mass of lymphoid tissue located on the roof and posterior wall of nasopharynx. So that is important point about adenoid. Adenoid are located in nasopharynx. It is a mass of lymphoid tissue situated on the junction of roof and posterior wall, situated on the junction of roof and posterior wall of nasopharynx. Okay, to got the right answer. So we have got here the right answer as the nasopharynx. So done with this. Done, my dear. Let's move on to the next MCQ. Nasopharynx, yes. Very good. Now we will move on to the next MCQ. Okay. This was direct from the notes. Now let's talk about this question. This is also very easy question. It is also directly from the notes. Actually, muscles of mastication, TM joint movement is number of times asked. So it is very important that you should be knowing this. So let me read it for you. A patient presents with pain, trismus on the right side along with the posterior open bite on the same side. CT scan reveals hard tissue growth involving right condyle. So this is the key point which you have to pay attention, that the condyle of the mandible is involved or suggesting of osteochondroma. Condylectomy has been done by resecting the condylar neck is planned. Which muscle must be stripped off to allow adequate and complete removal of the condyle during the procedure? So this question is related with origin and insertion of the muscles of mastication. And if I talk about condyle of the mandible bone, we know, and the condyle of mandible bone, we have got the location of pterygoid fovea. So basically, again, I want you to show this images. Actually, this is the images from the notes, and where I have clearly I have taken the session and muscles of infratemporal fossa has been done. And also we have talked about, not only this, we have talked about the muscles, where I also want you to note down that when I am talking about the muscles, we have talked about the muscles, and these are the images, and these are the images where I have shown you. For example, in this image, the origin insertion of lateral pterygoid, and you can see the pterygoid fovea. Okay, TM joint, articular disc and pterygoid fovea, the muscle inserting is the lateral pterygoid muscle.
So the action of individual muscles and the sections, we have seen coronal section, transverse section, various section, and we have identified the muscle also. So this also is directly from the notes. So I think most of the students must have done it. So let's move on to the explanation. So basically the correct answer is lateral pterygoid. Why lateral pterygoid is correct? Because the location, why lateral pterygoid is the correct answer, I will tell you. Lateral pterygoid is the muscle which is inserting into the pterygoid fovea. Where it inserts? It inserts into pterygoid fovea. And where is pterygoid fovea? And in the anteromedial aspect of condylar neck of mandible. Not only this, it also inserts into TM joint and fibrous capsule of the TM joint. So basically it is having two heads of origin, the upper and the lower head, and the muscle is inserting into the pterygoid fovea. So this gives us the right answer that the muscle affected here and the muscle which will be resected here is the lateral pterygoid muscle. So again, I think most of the student has marked it right. Let me just check. Okay, Kriti Gupta and everyone. Okay, absolutely correct. A is the right answer. Yes, A is the right. This is A, B, C, and D. Okay, A is the right answer. Yes, lateral pterygoid is the right answer. So now let's move. So we have discussed till now 3 MCQs. I have to discuss 3 more MCQs. So let's talk about the next MCQ which has been asked. So this was actually indirectly from the question bank, I can tell. Okay, out of 6 questions, 4 and 5 were directly asked. Only one was twisted. This was slightly twisted. It's an easy question, but it's very easy if the option was like that. Nothing to worry. Actually, they have made this is match the following kind of a question in which the bony features has been mentioned. Okay. Glabella. What do you mean by glabella? It is supraorbital ridge. So by the word glabella, it means supraorbital ridge. Okay. Then there was forehead mandible mastoid process. So the sexual dimorphism and sexual differentiation between male and female has been asked. So actually few features are like that make you very easy for you to. So basically if I'm talking about the, so I would like to write the features. So actually this is taken from the previous year papers which we have discussed in the MCQ bank of the DBMCI MDS app. So basically they have in that I have told you about the glabella, and we are also knowing that glabella, when I am talking about the glabella, it is actually an elevation connecting superciliary arches, which is so basically if I talk about the glabella point, it is the glabellas are actually typically robust and protruding and rounded in male. In females, they are poorly and relatively smooth. Okay, so that makes it here that if I have to go with all the points, so I just want to mention the what all things we have to know. We have to know forehead, glabella, mandible, and mastoid process. Okay, so let's write the forehead, glabella, mandible, and mastoid process. So these are actually known to us. Okay. So basically, if I talk about the glabella part, glabella part is actually robust, protruding in males, and in females it is smooth. So in females, they are relatively smooth. Okay. What about the forehead? So when I am talking about the forehead also, females has got is, if I am talking about males, their forehead is sloped profile. Males will have a sloped profile forehead. So they will have, females have got rounded, and more vertical and smooth forehead. But males have got a sloped profile and their brow ridges are prominent. Males has got brow ridges prominent. Mandible is actually male mandible is more larger, robust. They are more robust in case of females. Females will not have a very robust, and actually males have got more muscular to muscle prominence attachment is there. Females is having actually the females will have square chin or more of the muscle. So basically, if I compare the male and the female, so they will be more robust. So more robust in case of males, the mandible will be there, the male mandible. But if I talk about the its features, if it is not so robust in case, not robust in case of females comparatively. And mastoid process also is bony prominence, and it is actually robust, blunt. It is also noticeably more robust in case of males, more as compared to females. So basically, that means the features are compared. So let's see the options. Okay. So see here. Okay, dear. Okay. Okay. Yeah, Sonia, I told you about this question, about that parietal one. It was like written like axial skeleton vertebras. What are vertebral column? Vertebral columns are axial skeleton. So the other point, but it was already taken in the pharyngeal apparatus class, that the malleus, incus, the maxilla, the zygomatic, all the bones develop from the neural crest migration. So, but in case of parietal one, it was not written directly. It is from the migration of the NCC. So among the option, parietal bone is correct. Okay, I told you. So many questions are directly asked. So basically, out of 6, I think this was indirectly asked. Otherwise, most of the question was directly asked from the notes. Okay, so in that case, glabella is large and well developed in males. That is correct. Forehead is rounded in females. It is correct. Mandible is large and broad ramus in males. Mastoid is poorly developed in females. So A, B, C, D. One is A, one is A. So here the correct answer will be 1A, 2B, 3C, and 4D. It is actually according to the features only it has been written. Okay, according to features only the options are given. Okay, according to features only options are given. Now moving to the next question. This was actually the, I think, most easy one. Why I will tell you it's most easy. Actually, many of the times I have discussed this, and this was directly asked from the notes. Okay, this was a question about cavernous sinus thrombosis, and those who have attended the session of meninges of the brain and cavernous sinuses, dural venous sinuses, number of times, this clinical question, a 60-year-old woman present to the emergency department with ptosis and mydriasis of the right eye. She gives a history of infection associated with right maxillary third molar for the past 7 days. Clinical examination and investigation suggest cavernous sinus thrombosis. Which of the following cranial nerve is most likely involved in this case? Okay, dear. So, my dear students, I think this must be, if you remember, so I will come to the right answer. See here, this is exactly taken from the notes where I have explained you the cavernous sinus thrombosis, and you can see this was the case which I have explained, cavernous sinus thrombosis, and the clinical anatomy which we have done. In that, I have told you internal ophthalmoplegia. The patient is having, just see here, the patient is having the features internal ophthalmoplegia. Internal ophthalmoplegia. The patient is having the features of internal ophthalmoplegia. When I am using the word internal ophthalmoplegia, it means that the extraocular muscles are paralyzed. And if you remember the class of cavernous sinus, my dear students, in the cavernous sinus class, I have told you that in the lateral wall of cavernous sinus, we have got from above to down, we have got third cranial nerve, we have got fourth cranial nerve. So we have got third, we have got fourth, and we have got the fifth cranial nerve. Which branch? Fifth cranial nerve, ophthalmic nerve. Okay, and we have got the sixth cranial nerve and internal carotid artery, which is passing through the cavernous sinus, So basically, in the cavernous sinus thrombosis, the features, why internal ophthalmoplegia, why there is pain around the eye, because of the involvement of ophthalmic nerve, which causes pain. So we know that whole face is divided into 3 parts, upper, middle, and the lower. So basically, whole of the face is divided into 3 parts, upper, middle, and the lower. The upper part is consist of forehead, the area around the eye, and all. So basically, that is getting innervation from ophthalmic branch of trigeminal nerve. The middle part is from the maxillary division of trigeminal nerve, and the lower part is from mandibular. So this is exactly taken from your notes, and after this discussion, it is quite clear. So my dear students, according to you, which is the right answer? So definitely we have got third, fourth, fifth, and sixth. So third, fourth, we will have third cranial nerve, that is oculomotor, fourth yani trochlear, fifth ka kaun sa branch? The ophthalmic division of trigeminal nerve, and sixth ka abducer nerve. So these are the nerves which is related in the cavernous sinus, and because of infection, here clearly the question mentions cavernous sinus thrombosis. So this is the key word which you have to pay attention. And if this is a case of cavernous sinus thrombosis, that means the infection has reached inside the cavernous sinus and it has involved or paralyzed, and they have injury of the nerves, that is third, fourth, fifth, and sixth. So the condition will have a ophthalmoplegia. Okay. Okay, yes, doctor say you are right. So basically these are the question, and out of all six, only one question was twisted much. One question was twisted much because that female and male part was very easy to differentiate. We have talked about glabella and we have talked about bony prominence, pterion, asterion many times in the session. So basically, I think out of six questions, four, 5 question was direct. Only one question was twisted. That was of the derivative of paraxial mesoderm. In that question also, if you have pay attention, that we know that paraxial mesoderm form the axial skeleton. Okay, in that case also we will have what? Okay, please tell me which one. I just received these much questions also only. I have just received these questions only. Okay. Okay. Yes. Okay. Actually, okay, why condyle? That is on the anteromedial. Yes, I can, they are taking condylar neck, no? Okay, for this question, condylar neck. So temporalis, yes, one of the student is confused. Okay, so, yes, dear. Flexion of neck can't be there, actually. Yes, ho gaya hai, and okay, that is done. Anirban, that question has been already done. Yes, my dear, one question about temporalis. Basically, temporalis is inserting into coronoid process. Temporalis muscle, if I talk about temporalis muscle, it is going into the coronoid process. Okay, so basically they have written condyloid process, no? My dear students, they have written about the condyloid. So primarily, if I am talking about the location, they are covering the temporal muscle and they are actually inserting and converging to the coronoid process of mandibula. So one of the student has get confused with the temporalis muscle. So they are going into coronoid process. And in the question, they have asked about condyloid. They have mentioned the condyloid part. No, they have mentioned. See here, they have mentioned condyloid neck. And in the condyloid neck, we have got pterygoid phobia. Okay. So that is the reason we have to go. Okay, so is it okay? We have finished, and actually we have finished with all anatomy questions, and I think the questions were very good, very easy. Few questions directly, like 70% of question was entirely, 70 to 80% question was entirely directly from the notes, and one question was only twisted. So I think that would be the yeah, that is also done. Angle of the lip. Yeah, you have joined late, I think. That is also done. Yeah, platysma action, no? They are moving down the angle of mouth. Yes, that is also done. Yes, Anirban, that is also done. So please, if you have joined late, you just go and see the session starting from the beginning. Okay. So is it okay? So can we end with anatomy? Okay, no worries. Flexion nahi beta. Flexion of the neck to we have talked about that all many muscles na. No, that is not. Okay, that is not the answer. Basically, angle of mouth is lips and angle of mouth is downward direction. Okay, they are retracted in the downward direction. Okay, neck creases are formed by the platysma. That can be done, but entire flexion extension, such kind of movement is not done by the platysma muscle. So muscle in the superficial fascia. So it is an example of muscle that is panniculus carnosus. Okay. So for any doubt related to any subject of 19 subject, get your doubts cleared on the DBMCI group, that is Telegram group of Facebook, and your doubts, you can tag respective faculties of the subject specialist and you can ask doubts from them. They will definitely reply to your doubts. All the best and keep studying. Again, we will meet in the next session where we will have more of discussion of GTs and INI-CET related tests, which we already which is already planned on the DBMCI MDS group and app. All the best, and don't worry, whatever you have done your best, and 80% questions are directly from notes and some questions are just twisted, but that was also not very, so overall experience, I think it was moderate level anatomy question. Is it okay? Thank you. We'll meet in the next session. Get your doubts cleared from the respective teacher. Join the Telegram group and of the DBMC MDS app. Thank you. All the best and keep studying.
Okay, okay. So hi, evening friends, evening everybody, bache, evening everybody. I guess we know each other pretty well. I'm Dr. Sushant Soni, MBBS PharMC, MD Pathology, Resident Hemato-Oncology, AIIMS. So let's start with our INI path micro discussion. Now, before I even go further, that is why I always say that the paper is unpredictable. Because I'm saying so because the number of medical questions in this paper were extremely less. The whole paper was full of dental subjects. This was the kind of paper that we usually used to get around 2021 and so on. Uske baad, hi, evening, Saptash, evening, everybody, dosto. So, uske baad, the number of dental questions increased. Frankly speaking, looking at this NEET MDS, that occurred around 2 weeks ago or so, we were expecting more number of medical questions to come in the INI paper also, but it did not happen that way. That is why we cannot leave any subject firstly, and you have to hope for the best but prepare for the worst. So coming on to the discussion part, there were two questions from Aspergillus. I guess I was after your life forever, and I'm sure everybody would have marked that right. All of you are comfortable with the fact that Aspergillus acute angle branching. So this is something that we discussed repeatedly. We had recent INI paper also, mucormycosis, aseptate hyphae right angle branching, Aspergillus acute angle branching. The same point, you know this well that it is associated with septate hyphae with acute angle branching. The same point was again asked in the second question. So frankly, again, not a balanced paper because we do not expect two questions to come from the same topic. That is, the pathogenesis of invasive aspergillosis is characterized by which of the following? It has septate hyphae. Because the minute you know that it is not aseptate hyphae. When we talk of broad aseptate hyphae at right angles, we are talking of mucor. When we talk with respect to pseudohyphae, we are talking of Candida albicans. When we talk of granulomatous inflammation, acid-fast bacilli, we are talking of TB. So what is left by default is the septate fungal hyphae. Clean and simple. These were the two straightforward points that we had from micro. And coming to the pathology part, semomatous calcifications in ossifying fibroma. When we were talking about cell injury, we saw that semoma bodies. What are semoma bodies? Semoma bodies, which are they are type of dystrophic calcification associated with tumors. You very well know the list of tumors associated with semoma bodies: papillary RCC, papillary thyroid carcinoma, serous ovarian tumors, mesothelioma, meningioma, whatever. Fair enough, fair enough. So what are Semoma bodies? Semoma bodies, which they are firstly eosinophilic in nature. Now, the minute we had calcifications in the first three options, firstly. Secondly, they are pink. So, eosinophilic, pink calcified bodies with concentric laminations. This was the best answer. It is pink, it is eosinophilic, but firstly, the word calcification is not mentioned in option 4. Secondly, they are not homogeneous, they are concentric laminations. So the clincher in this was calcified bodies and the fact that they are pink in nature. So, Acha, Ekbar, do tell me this also. How were you guys with respect to the first three questions? हम में से किसी का भी ये गलत हुआ? Did any one of us go wrong in any of these three? These three were straightforward, yaar. I don't expect anybody to go wrong in this. Now the problematic question, that is the INI level or something, जो ना वो हमेशा INI, they put a question from a topic that is tough to comprehend. They have put two questions on mandibular swelling. Now, the first question was a child presenting with swelling of the mandible, which was painful in nature. Histopath image, and the examiner told you that it is a malignant tumor seen in the posterior mandible. So, firstly, child, malignant tumor, painful swelling. The most common cause is LCH. But osteomyelitis is not a malignant tumor, so this is totally out. This image does not look like a lymphoma at all. Lymphoma will show the presence of WBCs. Asha, you left the second. Koi baat nahi. So when you had this histopath-based, image-based question, osteomyelitis was out. Because osteomyelitis is not a malignant tumor at all. It is inflammation. Non-Hodgkin's lymphoma shows the presence of WBC-like cells. These are not WBCs, so even this is out. You are left with two DDs, LCH, Langerhans cell histiocytosis, and Ewing sarcoma. I am not going to say at all, Acha, fair enough. So I'm not going to say at all that you have a look at this image and then say it as either LCH or Ewing's. That's not the thought process that you should. Twin block, I agree those. Acha, so how will you approach this? If it has been recalled, I am extremely happy about that fact. But you tell me this, how will you approach this image? Image to kisi ko nahi pata kya hai. What will you mark? Point is that the minute we talk of a child, it is a case of LCH, whereas Ewing sarcoma occurs in adolescents. It occurs in adolescents. So history, nahi dost, Saptarshi, this is where those key. You always have to think in the manner that you're sitting in the paper, and then nahi dost, the age group does not match Ewing's at all. If it is a child with a painful swelling lower jaw, I am not even interested in telling you that all these are the coffee bean appearance nuclei. This is coffee bean appearance. Coffee bean appearance of the nuclei. It is a nucleus showing the presence of a nuclear groove, giving it the coffee bean appearance. This is hardcore path. I don't even want to say coffee bean because none of you will be able to appreciate the coffee bean appearance. देखो ये ना नजर आ रहा है. ये inside, this is the nucleus. Inside the nucleus, you see the presence of coffee bean nuclear grooving. Everything is small round only. Age group के हिसाब से, look at the age group. Look at the, ठीक है, blue cells नजर आ रहे हैं. Option 1 and 2 are out. If the same question was that of an adolescent, then I will go for Ewing's. That is the way to approach the question, firstly. Secondly, you had another question. You had another question in which it was a painless swelling. I am sure even that would have been recalled in OP. But when we talk of a painless swelling in a 70-year male who is a chronic alcoholic, so in that case, that fatty deposition that is seen in salivary glands. So comfortable. With respect to micro and path, so LCH नहीं दोस्त, अब वो अनिर्बन, यू आर वेरी राइट कि अगर लूजनिंग ऑफ टूथ या फ्लोटिंग टूथ का हिस्ट्री होता, अब इसको एक कदम और सोचो, अगर फ्लोटिंग टूथ के साथ अगर वो टेनिस रैकेट अपीयरेंस ऑफ बर्बेक ग्रेन्यूल्स भी लिख देते तो LCH होता, तब तो एग्जामिनर LCH आंसर खुद ही मार्क कर देते ना. दिस इज INI. वेलकम टू INI. You are 100% right that floating tooth history, loosening of teeth, floating tooth, bareback granules, tennis-racket appearance on electron microscopy, all these are the features of LCH. I 100% agree to that. But NEET will give you 4 pointers to a question versus INI, which will give you 1-2 pointers and will make you assume that you have to make a diagnosis on histopath. You did not have to make a diagnosis on histopath. That is what I'm still, nahi, Sonia, nahi. Adolescent में होता है यार. Ewing sarcoma is a tumor of adolescent age group. It's not a tumor of childhood. Childhood mandibular swelling, 18 to 20% cases is LCH, followed by Ewing's, which is just 1 to 2%. Versus if it was an adolescent age group, then Ewing's attribute for 30 to 40% of the cases. That was the pointed in this. And I always used to teach you in classes कि अब अगर कोई 10 या 11-year child है, is he a child, is he an adult? It will depend on whether you are asking the mother or the girlfriend. We always used to kid about this also. So child जब लिखा है ना, he is not talking of hypothetical 11-12 years. It's a clear discrimination कि 7-8-year child है. It is a case of LCH. अगर 14-15 years होता, then it would have been a case of Ewing sarcoma. Keshav, those commenting on the and twin block, you beautifully said it will make you mark wrong. INI is like that wicked girl who will always take you to the most expensive restaurant, blow up your bill, and in the end कुछ नहीं होने वाला types ना. So actually twin block beautifully said. Image को देख के इसमें diagnosis नहीं बनाना था. ये वैसे coffee bean appearance है, which is characteristic of LCH. केशव, एक कट ऑफ कमेंट करना मुश्किल है, especially because 95% questions, 95 तो नहीं, I'll say 90% of the questions were dental questions. So the dental faculties will be much better in telling you about the expected cutoff system. But all this said and done, whatever has happened and has happened, we cannot change it. So needless to say, bestest of luck for the results. But I have always said this, I'm extremely blunt. INI में तो seats ही बहुत कम है यार. Our main paper is the NEET MDS, and from bottom of my heart, I want all of you to have the seat of your choice. I know you guys have worked hard, and things will work out. Thank you, and take care. Micro के 2 थे ना दोस्त, अनिर्बम 2 थे ना, वो एस्पेजिलस ही 2 बार पूछ लिया था यार. मतलब माइक्रो में तो ऐसे नहीं करना, माइक्रो तो गलत करना ही नहीं था. एस्पेजिलस एक्यूट एंगल फ्रैक्चर, सेमोबॉडीज पैथ सिंपल था. मुझे एक बार क्वेश्चन भेज दे. Send me the question though. Send me the question. I did not have it with me in Victor. है ना? Done. Thank you, and take care.
So I know you guys are sitting with us, okay, since morning. So we will do the recall of oral pathology fast, okay. Now, first of all, with respect to oral pathology, I would say this was as a moderate paper. Now, why moderate paper? Because all the questions we had done, all these questions in the live class, in the recorded session, or in the GTs or the INI test series. Moderate, why I'm saying? Because the options which was presented to you, it was bit confusing, okay? But I'm pretty sure that if you would have solved a lot of GTs or INIs, then it would have been easier to rule out the options. So as I always say, the recall is not for the students who have given the paper. This recall is more important for the students who are slightly not satisfied with the exam. Okay, so let's start with our first question. A patient presented with a bilateral painless swelling in the preauricular region. The patient has a chronic liver cirrhosis. What is the most likely finding on the histopath? Now, whenever they have used the term as a chronic liver cirrhosis. That means there is a presence of adipose tissue, and also there is a bilateral painless swelling on the preauricular. This is pointing that there is an involvement of the salivary gland. So which salivary gland is present in the preauricular region? It is the parotid gland. So which salivary gland pathology is related to the preauricular region, and also there is a chronic liver cirrhosis, that is the infiltration of the adipose fat tissue. So we had discussed this in the class. Sialoadenosis. So it is a non-inflammatory, non-neoplastic enlargement of the salivary gland, particularly the parotid gland. So I know the confusion. You would have confused between option 1 and option B. Now both the options are very much similar. Now how you have to rule out? Now sialoadenosis, it is a non-inflammatory. So whenever there is a no inflammation, that means there is a no healing, right? So, the first option says that hypertrophy of the serous acinar cells with adipose tissue infiltrating the interlobular spaces. I agree, this is the right option. Now, coming to the second option, acinar cell hypertrophy. Similarly, what they have given in the first option, without fibrotic scarring. Now, what we will choose between option A and B? Can anyone tell me which options will you choose between A and B if you have to choose particularly? Now, I know majority of you will say as option A, but when we say the first sentence which is given in your Schaefer's, it is a non-inflammatory. That means there is no healing. So, it is very clearly said that in option B, acinar cell hypertrophy without fibrotic scarring, and hence here the answer is B rather than A. So, these two options were very, very close. So we also have a question on necrotizing sialometaplasia. Again, it was a very easy question. We will discuss that. Now, the lining of aneurysmal bone cyst. Okay, we know that aneurysmal bone cyst, it is a kind of pseudocyst. What does pseudocyst means? It means there is no epithelial lining is present. Hence, it is called as a pseudocyst. तो stratified squamous epithelium नहीं हुआ, endothelial lining नहीं हुआ, pseudostratified ciliated columnar epithelium नहीं होगा, ठीक है? So it is said that fibrocellular connective tissue without epithelial lining. Okay, very direct, straightforward. Even if you do not know about aneurysmal bone cyst and you just know that it is a pseudocyst, still you would be able to mark this answer as right. Okay, we had done this in class. Okay, in our notes, we have discussed this. The most common site of odontogenic keratosis, we all know it is seen in the posterior region. So, mandibular premolar also comes in the posterior region, mandibular angle and ramus region. Now, when we have to choose this, then we always choose mandibular angle or the ramus region. We had discussed this in class. Okay, most common location, mandibular third molar ramus area, the location of the OKC. Again, this question, okay, radiographically on a CT, how will you differentiate between a unicystic ameloblastoma and odontogenic keratosis? Now, why they had given unicystic ameloblastoma? That means there is a single cavity, unicystic, one single cavity. That means there is no soap bubble appearance or the honeycomb appearance. And OKC, it is seen as both. It is seen as unilocular, multilocular. But which is most common? It is unilocular, okay? But that is why this is also unilocular and OKC is also unilocular. Now, how we will differentiate this? We know that OKC, it is a very much aggressive, but it expands in a antero-posterior direction, while all other cysts, they expand in the buccolingual direction. That is why they are detected very early, and hence because this expands in the antero-posterior manner, it gets detected very late. Okay, so unicystic ameloblastoma will show more anteroposterior spread as compared to the buccolingual. This is not the right answer. Multilocular radiolucency, honeycomb, this is also not the answer. Hence, the answer is D. Okay, I hope this is clear. So, that is why I said this is a moderate kind of paper because the two options looked quite similar. So, this we had done this in the class, okay, where I had clearly mentioned that in 2017, aggressive behavior was recognized because of the expansion of the cyst antero-posteriorly as the other cyst expands in a buccolingual direction. According to 2017 reclassification, we know that from 2005 to 2017, OKC, they considered it as a tumor. What was the term? That was KCOT, keratocystic odontogenic tumor. But later, there were certain features they recognized, and then hence they converted it back into the OKC in 2017 by WHO classification. So, knowing the classification is very important. So, because it can be treated by decompression and marsupialization, this is not the major reason, because it has no consistent clinical evidence of the neoplasia. It never shows recurrence. We know that OKC shows recurrence. Okay, there's a presence of daughter cyst and the satellite cyst. There is no genetic mutation. Hence, this is not very well proved, but it was seen that in OKC, there is a mutation in the PTCH gene. Okay, it was also seen that in OKC, whenever there was a decompression and marsupialization was done, in most of the cases, the lesion showed better response. Okay, why it was classified it into the cyst bag? Because there was no consistent clinical evidence of neoplasia. Very easy. Just by ruling out the options, you can come to the conclusion. Okay, so all this was done in the class very much. Okay, OKC. Now the next question, a histomicrographic image of a cystic lesion was given. Okay, this image, okay, this was not the exact image, this image which was taught in the class, but similar kind of histopath image was given, and in the question it was written that it is present in the anterior mandible. Identify the most likely cyst. Now, dentigerous cyst, globulomaxillary cyst, radicular cyst, these are more commonly seen in the maxillary tooth, that too in the maxillary anterior region. Chalo, even if you do not know the histopath anterior mandible, I think you would be able to know the answer as glandular odontogenic cyst. Now, as discussed with all the students in the breakout session, they had told me ki ma'am, there was it was seen as hobnail appearance. Okay, hobnail appearance. What is basically hobnail appearance? The cuboidal kind of cells, okay, they come out. Okay, they come out and they decapitate. Okay, and they come into the lumen. So this is basically the hobnail appearance, which is seen in the superficial layer of the epithelium. Okay, so this is the glandular odontogenic cyst, and we had discussed it is more commonly seen in the mandibular anterior region, and it is also seen as the cuboidal cells exhibit hobnail appearance, and I think this histopath was given in the options. Now coming to the next question, very easy question. Okay, a lesion in the posterior border of the mandible is shown. Histopathology reveals parakeratinized stratified squamous epithelium. I have shouted in the class whenever they have mentioned parakeratinized stratified squamous epithelium, basal layer, tall columnar palisaded appearance, the most likely diagnosis. Okay, and since this is a one radiolucency, that means unicystic radiolucency. So OKC, it is seen as both unicystic as well as multilocular, but more commonly it is seen as unilocular radiolucency. Again, it is present in the mandibular posterior region. Very easy, odontogenic keratocyst. Okay, so see, epithelium, this is the histopathology of the OKC. Picket fence appearance or the row of tombstone appearance, because the nucleus is present at the same level and the epithelial lining is parakeratinized, which gives the corrugated surface. Okay, can you see this? This is the corrugated surface and this is a palisaded nucleus, which gives picket fence appearance or the row of tombstone appearance. Coming to the next question, brown tumor of hyperthyroidism histopathologically resembles which of these lesions? So we all know that brown tumor, hyperparathyroidism में हम क्या देखते हैं? Multinucleated giant cells. So let's have a look on the options. Okay, multinucleated giant cells इसमें भी है, ठीक है. चेरूबिज्म में भी हम मल्टीन्यूक्लिएटेड जाइंट सेल्स देखते हैं. सेंट्रल जाइंट सेल ग्रैनुलोमा में भी मल्टीन्यूक्लिएटेड जाइंट सेल्स देखते हैं. एन्यूरिज्मल बोन सिस्ट में भी हम मल्टीन्यूक्लिएटेड जाइंट सेल्स देखते हैं. बट व्हाट इज डिफरेंस इन द ब्राउन ट्यूमर? सो एज द नेम सजेस्ट, व्हाट इज ब्राउन? The hemosiderin pigmentation which is seen in the hyperparathyroidism, that is why they have also called it as brown tumor, and hence in the question they have mentioned brown tumor of hyperparathyroidism. Okay, so central giant cell granuloma showing a proliferation of the vascular connective tissue packed with numerous evenly distributed multinucleated osteoclast-like giant cells and mononuclear spindle-shaped stromal cells. So this suggests that vascular connective tissue packed with numerous evenly distributed multinucleated giant cells. Hence the answer is CGCG. Now, as in general, we know that hyperparathyroidism, it is very much similar to the central giant cell granuloma. We will see this, okay? Giant cell tumor, it is a true neoplasm of the long bones. Okay, now in this the giant cells are very much uniformly distributed, unlike your hyperthyroidism or your central giant cell or your aneurysmal bone cyst. Okay, cherubism resembles central giant cell granuloma, but what it is present? There is a presence of perivascular eosinophilic cuffing, and aneurysmal bone cyst, there is a presence of blood-filled cystic cavity. Okay, so whenever we talk about the brown tumor, there is a presence of hemosiderin pigmentation. Okay, this we had done in the class, and there is a very important difference which is there, okay, which we had discussed between the hyperpara and hypoparathyroidism. Okay, now features of mucoepidermoid carcinoma, very easy. So as the name suggests, mucoepidermoid, that means there is a presence of mucus cells and epidermoid cells. But along with that, there is one more cell which is present, which is called as intermediate cells. Okay, this is the answer. C is the answer. Okay, so this we had done in the class. Low grade. Now, based on these cells, they have divided into low grade, intermediate grade and high grade. Okay. Now, this was again, okay, I do not know why the students, they got confused in this question, okay. As it is seen in the lower lip, it is not ranula, okay. Ranula, it is always present. So, it is a type of mucocele which is present on the floor of the mouth. So, whenever there is a lesion, okay, bluish kind of lesion, if it is present in the lower lip, the first thing that should come to your mind is the mucocele. That too, here they have just given mucocele. They have not given mucus extravasation or mucus retention cyst. So here the answer is very direct, mucocele. Okay, young child present with bluish fluctuant swelling on the lower lip. The lesion occasionally ruptures and discharges secretions and it recurs. Which of the following is most likely the diagnosis? Okay, it is mucocele. So hence we had discussed this in detail. Most common site for mucocele, it is the lower lip. While the ranula, okay, can you see this? Ranula, it means a frog's belly which is present in the floor of the mouth. Which of these features of necrotizing cyalometaplasia? Now, as the name suggests, necrotizing, there is a necrosis which is present. Okay, now three histopathological features are very important with respect to necrotizing cyalometaplasia, the triad. Okay, first of all, in necrotizing cyalometaplasia, the lobular architecture which is present, it is preserved, it is not destroyed. Coagulative necrosis of the acini. So as the name suggests, necrotizing cyalometaplasia. And why the term they have given metaplasia? It is a pseudocarcinomatous hyperplasia. That means it is not a metaplasia, true metaplasia, but it mimics like a carcinoma. So it mimics squamous metaplasia of the ducts and acini. So what is the answer? Loss of lobular architecture without necrosis. Okay, necrotizing में नाम में दिया necrosis. तो necrosis तो होगा, ठीक है, और हमारा lobular architecture is also preserved. Okay, even if you do not know about the lobular architecture, all these, just without necrosis, you could have marked this answer as right. So the presence of mind is very important when you are giving the paper. This question is very easy. From past 5 years, I am seeing one question on pemphigus vulgaris, bullous pemphigoid, mucous membrane pemphigoid, right? It was a multiple choice question which made it bit tricky. Yes, it was little bit tricky, but if you would have actually ruled out the options, I'm pretty sure you would have come to one answer, right answer. Okay, match the following. Pemphigus vulgaris हम सबको पता है suprabasilar split होता है, intraepithelial split with acantholysis. So one is B. So how you can save your time? Okay, one is B, this one is B. That means B and C option is ruled out. Okay, now there is only confusion between A and D. Coming to the second, mucous membrane pemphigoid. It is present in the mucous membrane. It is given, and we know that in pemphigus, suprabasilar split. Bullous pemphigoid or the cicatricial pemphigoid, subbasilar split. So second option 2 ka C ho gaya. Hence, we do not have to look the question further. The answer is very much clear. It is A. Okay, but just for your now we are doing the recall. Bullous pemphigoid, it is the subepidermal bulla with tense blister formation. So 3D, and hence erythema. Last option is 4A. This is very much clear. The answer is A. Identify the malformation. Now, can anyone tell me what you guys have marked this? Anyone can tell me the answer of this? So this is a central incisor. Okay, this is one central incisor. So if a supernumerary teeth is present between two central incisor, it is a mesiodens. So this is not a mesiodens. Last year, the question in the INI, they had asked about the mesiodens. Okay, now this is the lateral incisor. Okay, now whenever a tooth which is present in extra, okay, that is always called as supernumerary teeth. Okay, peg lateral, if this lateral would have been smaller in size, then I would have called this as a peg lateral. Okay, so hence here the answer is supernumerary teeth. Now what is ectopic eruption? Ectopic eruption, tooth erupts in an abnormal position or path. Okay, but that does not mean that is an extra tooth. That is a normal tooth which is erupting in the abnormal position of the path. Transposition, when two teeth they exchange their position. Okay, for example, molar is in the place of premolar, premolar is present in the place of molar. So that is your transposition. So this is a very direct, commonsensical question. Answer is very clear. It is a supernumerary teeth. Okay. It was long and confusing. I know it was long, little bit of confusing. Not very much confusing. It was just little bit of confusing. See, even I saw the paper and then, what I did? I just tried to rule out the option. So this was the classification. It was very well dealt in the class. Okay, that too in much more detail. In the exam, the question was, it was bit easy. Okay. Now coming to this question, cemento-osseous dysplasia. Now this question I would consider this as an outlier, and that's what INI does. One or two question will always be there, okay, which you would have not read. But you should not run behind those questions. I always say, okay, even the top rankers would say that I was not aware of those 15 or 20 questions. So we have to focus on the questions which was little bit easy, okay. So in cemento-osseous dysplasia, histopathological examination reveals cementum-like calcified structures showing a characteristic maturation pattern. We know that cemento-osseous dysplasia, okay, there is a calcification which is present in cemento-osseous dysplasia. Which of the following is most commonly seen? So they had asked this in terms of histopathology. So whenever there is a mineralized structure which is present, so what happens? In the center there is a basophilic stippling, while the periphery, it is less mineralized, less osteoid formation, it is less trabecular bone formation, and hence the periphery appears eosinophilic, and because of this it gives ginger root appearance. Now there was one more question, okay, which was again it was slightly confusing and we do not know what was the exact question. When we talk about the histopathology of the calcifying epithelial odontogenic tumor, it is the leasy gangrene. Okay, now the trabecular bone formation which is seen, the classical histopath feature is leasy gangrene. But when the trabecular bone formation, again COT, the radiographic appearance, no driven appearance because of the calcification bodies which is present. Hence, the trabecular bone formation, it has been compared with the ginger root appearance. Okay, so this the cemento-osseous dysplasia, the cementum-like calcified bodies shows a classical ginger root appearance because in the center there is a basophilic stippling and in the periphery there is a eosinophilic. Okay, so here basophilic center with eosinophilic periphery. Okay, so for all the students who are seeing the recall, okay, first now what you have to do, you have given your NEET paper, you have given your INI paper, just relax a bit. Okay, and if you feel that you are not satisfied with the paper, or you could have done in a better way, or you would have just prepared in the halfway, okay, think over it and then you can start your preparation again. And now when you will start your preparation again, you will be at a better position because you know from where and what you have to study. Okay, so this finishes your recall of oral pathology.
Hello, good evening, students. Okay, so welcome to INI-CET May 2026 recall session of OMR subject. Okay, so most of the questions are discussed in oral pathology, which were merged with the oral medicine and radiology. Okay, so remaining 4 to 5 questions that are there, that we'll discuss it now. Okay, so the first question from oral radiology was the effective radiation dose of LAT-CEF radiograph is approximately, so we have discussed this in radiation protection, that effective doses from various radiographic examinations, correct? So we have discussed it in the notes also, we have it, right? Cephalogram, the effective dose that we get from cephalogram, cephalogram is 3 to 6 microsieverts. Okay, also let me tell you guys, this question is a repeat question from INI-CET November 2025. Okay, so the closest answer that is there in the option is option B, which is 2 to 4 microsieverts. Okay, 2 to 4 microsieverts is the closest answer that we have it in the options. All right. Okay. Moving on to the next question. Okay. Match this histological features of given vascular malformation. Okay. So first is AV malformation. then venous malformation, infantile hemangioma, and capillary malformation. So they are given the two columns, and you just have to match the histopath features with the column number first, which is column A. Okay, so if you read the complete like column B, okay, if you read this column, you will easily understand, you will easily be able to mark the correct answer over here. Okay, because they have directly given C. First is AV malformation. AV malformation, if you read the options that are given in column number B, okay, AV malformation, that means artery and veins, both are involved. Okay, so A corresponds to point number B, which includes abnormal admixture of dysmorphic arteries, arterioles, veins, and capillaries. Okay, so A option corresponds to second point. B option, venous malformation. So it is related to veins, correct? It is related to veins. Now, option number B corresponds to point number 3 in column B, which is irregularly dilated venous channels. Okay, veins are mainly affected with a thin, discontinuous, single layered endothelial lining and defective or absent smooth muscle walls. They are just given the histopath features. You need to match it with the column A. Okay, so second option, B, venous malformation, corresponds to third point, correct? Now, if you first solve option number D, which is capillary malformation, if you read in the column B, the fourth point, which is abnormally dilated capillaries and post-capillary venules, thickened walls. Okay, this option D corresponds to point number 4. Okay, so if you read the options that is given, you need to select the correct answer given below. Okay, so A corresponds to point number 2, B corresponds to point number 3, C corresponds to the remaining one is the point number first, which is proliferation of plump endothelial cells and pericytes with inconspicuous lumen. Correct? We had seen this hemangioma. Okay, hemangioma, where we had seen what is hemangioma. It is altered endothelial growth and proliferation. Okay, altered endothelial growth and proliferation. So if you read option number C, which is infantile hemangioma, corresponds to point number 1, which is proliferation of endothelial cells. Okay, and remaining you just have to mark it by looking at whether arteries and veins are involved, whether capillaries involved, whether only veins are involved. Okay, so this is the correct answer is option number A here. All right. Okay, this is the question. Okay, they are given the image. Okay, you need to first identify which imaging technique is this. And let me tell you, this question we had studied in the PYQs. Okay, this INI-CET PYQs, we have this question. Okay, those who have gone through the PYQs will solve this question correctly. Okay, now this technique that we have here, this imaging technique. Okay, this is the PYQ that we had in our INI-CET file. Okay, now what is this technique called as? This technique is called as stereophotogrammetry. Okay, this technique is a 3D imaging technique. This technique is 3D imaging technique. Okay, what they do in this technique is they capture the surface of object or the face. Okay, by keeping the cameras, okay, by keeping the cameras on different angle. Okay, so these cameras take your 2D photographs. Okay, and they had this software. This software identifies the common points in the image. Okay, so what they do actually is they place two cameras in different angle. Okay, now the cameras take your 2D pictures. They have this software. This software identifies the common points in the image. Okay, and then the 3D model is reconstructed. 3D model is reconstructed. This is stereophotogrammetry. Okay, now what you get, okay, this is how they take this pictures. Okay, they keep the cameras at different angle, they take photographs, and they software will identify the common points and build or reconstruct 3D model. Okay, this is a 3D model that the software reconstructed. Okay, mainly this imaging technique is used for facial analysis. Okay, then the next use of this is orthodontic treatment planning. Okay, we can use this in craniofacial deformities like cleft lip, cleft palate. Okay, here I have put example of cleft lip, correct? Then if patient need to undergo orthognathic surgery, you can get this done, correct? For soft tissue evaluation also, you can opt for this imaging technique. Okay, so we have facial analysis, we have ortho treatment plan, then we have surgical planning for any facial deformity such as cleft lip, palate, or orthognathic surgery. Orthognathic surgery. Okay. Fourth one is the important one, which is soft tissue evaluation. Soft tissue evaluation. So, what is asked in the question? See, this modality, once you identify the modality, you need to mark the correct option here. Okay. This is used to diagnose hard tissue, soft tissue, both. Only hard tissue, soft tissues, but not hard tissues. And D is localization of object in relation to both hard and soft tissue. So this technique is mainly used for soft tissues, not hard tissues. Okay, option C is the correct answer over here. Soft tissues, but not hard tissues. Okay, that is one of the disadvantage of this imaging technique. Okay, all right. Moving on to the next question, which is painless swelling on the palate that has been gradually increasing in size for last 2 years. What is the most appropriate method to confirm the diagnosis? Okay, they are not asked about the diagnosis, but most appropriate method to confirm the diagnosis. Okay, so what is given here? Painless swelling on the palate gradually increasing since 2 years. Okay, so gradually increasing since past 2 years. So most probable diagnosis, if you look at this swelling on the palate, can be a minor salivary gland tumor. Minor salivary gland tumor. Okay. And mostly the diagnosis for the minor salivary gland tumor is done using incisional biopsy. Incisional biopsy. Okay? Incisional biopsy. See, in the option B have incisional biopsy, but option A is whether the incisional biopsy is taken from the center, okay, without damaging greater palatine vessels. Option B is incisional biopsy from the edge of the lesion along with the normal surrounding tissue. Option C is FNAC. Okay, FNAC can be used, but it will not give you a final diagnosis. Okay, as compared to incisional biopsy or FNAC, you must choose incisional biopsy. Okay, CECT of that area will not give you the final diagnosis again. Okay, so final diagnosis, to confirm the diagnosis, we need to go for incisional biopsy, and that too from the edge of the lesion. Edge of the lesion involving normal surrounding tissue. What is the reason behind it? When you have a lesion, okay, when you have a lesion like this, you take biopsy from the periphery of the lesion involving normal tissue. Okay. So why do we take biopsy from the periphery? Because we take a representative tissue. Okay. If you take a junction between abnormal and normal tissue, it will help pathologist to let's say identify the nature and the extent of the lesion. Okay. So nature and extent of the lesion. Okay. Second, it will help pathologists to identify tumor margins. Again, invasion. How much tumor cells have invaded into the normal tissue. Okay. So all these points are important when you say you should take the biopsy from the periphery. Okay. Why not from central area? Why not from central area? Because sometimes what happens is in long standing palatal swelling, central area, okay, it can show central degeneration or necrosis or inflammation. Okay, so this might give us misleading diagnosis. Okay, this might give us misleading diagnosis. Third point is to avoid complication or to reduce the risk of complication. Okay, when you take a biopsy from central region, there you might injure the palatine vessels. Okay, in the first option, they are given without damaging greater palatine vessels. But what happens is you might end up injuring this greater palatine vessels, might cause the ulceration and rest complications. Correct? So, to avoid all this, we take the biopsy from the periphery with involving the normal tissue. Okay. So, option B is correct over here. All right. So these are the 4 questions, and rest of the questions that was involving the OMR, oral medicine, and radiology part is covered in oral pathology, correct? So these are the 4 questions. I hope you guys have marked it correctly. All right. If you have any doubts, you can put it in the Telegram group, and the next session will be continued by Dr. Dhruti for DADH. Okay.
Okay. Hello, dear students. Myself, Dr. Dhruti Modi, and I'll be taking a quick recall of our DADH questions. Fine. So DADH was not that difficult. It was easy only. The questions were direct and nothing much complicated. So let's begin with the first question. Which of this is the lining tissue of the joint shown in the image below? So the question was majorly asking about the articular surface, what is it lined with? Okay. So when we say lined with, the first thing should always comes to your mind is synovial membrane, but you have to know that they're asking you about the cartilage. It's not about asking about the synovial membrane, because they have given stratified squamous epithelium. So we know that the synovial membrane is not a very true epithelium. It is majorly a dense connective tissue, right? And now we know the characteristic feature of our TMJ is, can anyone tell me the answer of this for now? We know that the elastic cartilage is the one which is present into our ears, okay, and into our nose. It is very much elastic, so it's not going to be present in your TMJ, right? And the characteristic feature of your TMJ is fibrocartilage. The hyaline cartilage is present in your other joints. Fine. So this question we have taught you multiple times. You have seen also in our notes how we have very characteristically told you how the articular surfaces, they are lined by a thin layer of your fibrocartilage. All right. Okay. Now, the second question. The space present anterior to the canine in primary dentition and important during the transition and mixed dentition phase. So the image which was given was that there were primary teeth, and on top of that they were given permanent teeth, and an arrow was made mesial to your maxillary canine and distal to your mandibular canine. Okay, so this is a very frequently asked question. You know that it is primate space. Just in relation to this leeway space of Nance, that was asked in your NEET. Okay, so in your INI they asked for your primate space. And as you know that we have taught you again this, what are the various names of your primate spaces, right? And how it is a very, very important MCQ which they ask. So by now we understood that the NEET and INI, they are focusing main on the spaces only, primate space, leeway space of Nance and all that. All right. Okay, let's come to the third question. Now, again, this is one of the same question from our NEET also. In the NEET, they had asked us end-on relation. They had asked us fresh terminal. Okay, so in INI, they had asked us, this was a very, very clear picture. You know that it's not flush terminal. You know it's not mesial. It is distal step. Okay, so both of these, the same, they had come from our NEET only. Just they changed the asking pattern of it. Fine. See, again, in this also multiple times we have taught you in our notes. We have also taught you what the transition of these are going to get into, right? And how the distal step, it is very much easy with the picture it is given so that it is imprinted into your mind. So the DADH questions were very easy. So as always, expected for you to answer them and not lose these questions. Now, this one could have been a little bit tricky for some of you, okay, because it was about the protein. But the one good thing was that there were two options, okay, that was making it a little easy for us to select. Because see, DSPP, you know that it is in regards to your dentine. So you know that it is going to be in regards to your dentinogenesis. But some of you might confuse it with your odontoblastic differentiation also. Okay, so what happens is next, if you see, and in questions like this, you have to only focus on the elimination method. Okay, you might know one, but you might know all of them. So if you see the BMP, you know that the BMP is the one that is going to play a role into your odontoblastic differentiation. If any of you might have confused between the option D and option B and C, so you might know that the second they are telling BMP and they have given as an option of nerve fiber growth and angiogenesis. You know that BMP is not going to play that role. Okay, so any of you who might have got confused between dentinogenesis or odontoblastic differentiation, they had made it very clear for you that you could choose the correct answer. So by now you knew that it was either B or it was C. Fine. Then comes this part, that is your vascular endothelial growth factor. From the name in itself, we should know that it is regarding to endothelium. So it can be in relation to your nerve fiber growth and angiogenesis. So at this stage, it was very easy for us to determine that which is going to be the answer. And you know, SDF, that is stromal cell derived factor. If you would not have read this also, it was not very complicated that you could not have made this answer. I hope most of you would have answered this question. Okay, just like that, in our notes, we have already taught you how DSP is playing a role into your mineralization. If we have taught that mineralization, it should come to your mind that it is dentinogenesis. You might have also got confused between odontoblast differentiation, but I made it clear to you. And in our PYQs also, we have taught you how BMP, they play a very, very important role when it comes to HERS. Those who have attended, those who are new students over here for 2027, they know how BMP, each and every part, we have taught you very, very clearly how each BMP is playing a role into it. See, this one question from your INI, November 2021, in this, they had asked us about the epidermal growth factor. Okay, so now how in our notes, we have always given you the high yield question, how the elimination also has an explanation is always highlighted, and how that helps us in the other extra questions which are asked to us. Okay, fine. Okay. This one was a very, very simple question, nothing complicated in this. Multiple times we have taught you the embryonic origin of this. We know how the enamel, it origins from your inner enamel epithelium. In this also the options were very much clear. The only confusion you could have at the dentine level, that either we have to choose ectomesenchyme or we have to choose dental papilla. But the option again in this also was very clear, because for pulp, the only option that was given over here was ectomesenchyme. Right. So hence the answer was the B into this. Fine. Cementum, of course, you very well know that it arises from your dental follicle. As I said, DADH section was very easy, nothing very complicated in that. And now see, Those of you who have referred the notes, who have studied multiple times, you know this table, you have studied it multiple times, you know that which tissue is deriving from the which one. Okay, like how the dental papilla, you know that the further it is giving to rise to your odontoblast, then your dentine. You know your dental follicle is giving rise to your cementoblast, and then is your cementum. All right. Okay. A patient undergoes orthodontic tooth movement, shows increased rankle expression on the compression side of the periodontal ligament. Rankle, we have again taught you that it is going to play a major role into your formation of your osteoclast, right? How rank and rankle, they increase your osteoclast formation. So now when this happens, you know that if osteoclast activity is there onto the compression side, there is going to be an increased osteoclastic activity. That will lead to what? If osteoclasts are there, that is going to lead an accelerated bone resorption. So automatically osteoblast is cancelled. The decreased osteoclastic activity is also a cancelled option. Some of you might have for a while just glitched when it came to cementoblastic activity, but that is not the correct. In this also, no as such controversial options were there. So it was the clear answer of A. Okay. Now, this question. A patient shows intrinsic discoloration of teeth with horizontal band. This one might have confused you a little because intrinsic discoloration, okay, I know it might have come to your mind for that picture. The actual picture in the exam which was given, it had two permanent centrals over there and which were not discolored. So some of you might have got confused with dentinogenesis imperfecta, but so this was a controversy in the image and in the description. Okay, the image was very much focusing on to dentinogenesis imperfecta and trying to confuse you. But here comes the keyword which was given, horizontal band. You know that this is the characteristic feature of your tetracycline stain, not your dentinogenesis imperfecta. Okay, amelogenesis imperfecta again was asked into your NEET. So now you can see 3 questions were literally similar, almost 90% from your NEET. Okay. So amelogenesis imperfecta, you know it is not there because chipping of enamel would have been given. Dentinogenesis imperfecta, for that discoloration is there, but also there is adhesion of the teeth. Okay, there is break of the enamel, and in the picture we could not see anything as such onto your teeth. Right, the band part made it very clear that your answer is going to be tetracycline stain. Any who had selected it fluorosis is wrong. Okay, the horizontal band was written into it. Okay, in the question it was present, and that was making it a probable answer for your tetracycline stains. Okay, so the DADH questions were very easy. See, in this also we have taught you in our PYQs how the intrinsic staining is caused by, and how the tetracycline part also we have explained with multiple options. Okay, how we should know that that is going to cause a discoloration with bands. Fine. So I really hope all of you had a good exam, and now it's time for you to rest and enjoy. Do not worry about the results, and have a good evening, guys. Okay. Fine.